Um, so today we are going to continue by talking about um, the bacterial and exotoxins and um, the way they work. They work by different mechanisms. So we have to be familiar with each individual mechanism, how it causes a problem. So the first principle is inhibition of protein synthesis. So there are some bacterial exotoxin that cause infection or they cause damage to the cell by inhibiting protein synthesis. And the first two we are going to be talking about is Corynebacterium diphtheria and Pseudomonas aeruginosa. And these guys are like close buddies. So that's the way I remember them. Corynebacterium C and Pseudomonas close pals. So both of them they work together by through similar mechanism to inhibit protein synthesis. Please, 1 minute or 2 minutes max, please. Sorry about that. Um, so, um, so the first, the Corynebacterium diphtheria and Pseudomonas aeruginosa, they are close buddies, and both of them release their toxin. The toxin for diphtheria is called the diphtheria toxin, while the toxin for Pseudomonas aeruginosa is called the exotoxin A. You don't need to actually know the name of the toxin, just know that they have toxins. What is important for the sake of our exams is knowing the mechanism of that toxin. How does it work? And mind you, don't forget that these are exotoxins. They are different from endotoxins. We said it last class that exotoxins can be released by both gram-negative and gram-positives. So these close buddies, how do they work? How do they cause problems for the cell? How do they inhibit protein synthesis? So they do it by inactivating the elongation factor 2. So what they do is that the toxin that they release is going to cause ADP ribosylation of this elongation factor. So once there is ADP ribosylation of this elongation factor protein, it's going to be inactivated. So that's what happens. And if you remember, when there is protein synthesis suppressed, when a cell can no longer form proteins, there's no way the structure of that cell is going to be maintained. We remember that cytoskeletal components of the cell are important to maintain the integrity of the cell. So if there's no protein to do its function, it's going to die. And when they die, there's going to be inflammation. So leading to some of those pathologies. So let's say that we have Corynebacterium diphtheria now releasing its toxin, which causes ADP ribosylation of the elongation factor 2 gene, silencing or inactivating this elongation factor 2. So there's no way protein synthesis can happen. So this factor is essential for protein synthesis. So if it affects the throat, it means the person is going to be having inflammatory injury in the throat, which will present as pharyngitis. And part of the inflammatory response is actual formation of the pseudomembranes. So we are going to be seeing some whitish exudate, which lines the back of the throat in an individual with Corynebacterium diphtheria infection. So that's what we call the pharyngitis for diphtheria. So the pseudomembranes at the back of the throat is classic for pharyngitis with diphtheria. Let me show us an image. I think we should be able to get an image online. Corynebacterium, Corynebacterium diphtheria pseudomembrane. So we just have an idea in case we are showing our exam. So this is what we are going to be seeing. So once you see this whitish stuff at the person's throat, which should have a very high index of suspicion for Corynebacterium diphtheria, and at the same time, it also provokes severe lymphadenopathy. So that's just more like an inflammatory response to the infection. The inflammation can also occur in the heart. So that inflammatory injury, the protein synthesis loss can also occur in the heart. And when there is death of the cells in the heart, the myocardial cells, there is going to be inflammation. So that can lead to myocarditis. So the person can present with chest pain. They can have symptoms of heart failure. It can also affect the peripheral nerves. So they can have tingling sensation, they can have numbness and all those things. So Corynebacterium diphtheria typically present with pharyngitis, with pseudomembranes that I've shown us. they have a severe lymphadenopathy in the neck, which is going to cause this bull neck appearance. They will have myocarditis, and they can also have peripheral neuropathy. And everything starts from the fact that they inactivate elongation factor 2 by causing ADP ribosylation. Same with Pseudomonas aeruginosa. It will release its exotoxin A, which inactivates this elongation factor 2 by ADP ribosylation, and it causes the death of the host, any cell that Pseudomonas is. So Pseudomonas is causing otitis externa, it is causing um, septic arthritis, is causing osteomyelitis, anything that it is causing, that any inflammatory damage that it's causing is due to the fact that it inactivates this elongation factor in that cell, causing the host cell death with subsequent inflammation. Then the next includes the Shigella and the enterohemorrhagic. So we have to marry all these two guys together. For the sake of our exam, you have to marry them together. I don't know any way we are going to go about it. But anytime you are talking about Shigella, your closest differential should always be enterohemorrhagic E. coli, because both of them, they utilize the Shiga toxin. The Shiga toxin. Although the Shiga name is closer to Shigella, but the enterohemorrhagic E. coli also uses the Shiga toxin to cause injury. Now, they also suppress protein synthesis, but they don't inactivate elongation factor. What they do is that they inactivate 60S ribosome by removing adenine from the RNA fragment. So, from the RNA. So, this 60X what's it called, fragment is part of the RNA. So we have the 60S plus the 40S for eukaryote cells, and you have 30 plus 50 for prokaryotes. Am I right? Or am I making any mistake? Anybody remember from biochemistry? I think that's the arrangement. Hello?
You're right.
Yes.
So 60 plus 40, 30 plus 50 for prokaryotes, 60 plus 40 for eukaryotes, 30 plus 50 for prokaryotes. But the cells that most of all these Shigella and enterohemorrhagic E. coli infect, they are eukaryotic cells like human beings. So they have the 60X ribosome. So what they do is that they just remove adenine from part of the component of that 60S, and at the end of the day, they affect this RNA complex. When it's not completed, when it's no longer whole, when the structure is altered, they cannot achieve the process of protein synthesis again. So you start having damage, to whatever tissue that they are infecting. So with that, with the loss of protein synthesis, and we know that the mucosa of the gastrointestinal tract also contains more proteins. So in that way, they can damage the GI mucosa and cause dysentery, particularly Shigella. So that's how Shigella can cause dysentery. It can inhibit protein synthesis within the gastrointestinal cell, leading to damage to that mucosa with eventual dysentery. Enterohemorrhagic one also releases Shiga toxin, and the Shiga toxin is going to inactivate the 60S ribosome, just like we have explained, by removing the adenine fragment. But this one can affect a wide spread of tissue. So it can affect the kidneys, it can affect the red blood cell, it can even affect the platelets. So in the red blood cell, it can cause hemolysis. In the kidneys, it can cause injuries to the tubules, causing AKI, and also in the platelet, it can bring them down, causing thrombocytopenia. So that is how enterohemorrhagic E. coli can cause the hemolytic uremic syndrome. So, which is a triad, which is like a pentad of fever, bloody diarrhea because of the fact that it damages this GI mucosa, leading to dysentery, and the HUS, which is hemolysis from destruction of red blood cell, the uremia from injury to the tubules of the kidneys, and also the thrombocytopenia. So don't forget the enterohemorrhagic E. coli, the O157H7 subtype. How does it cause its injury? It is due to release of Shiga toxin, inactivating the 60S ribosome. But there's a clause here. We are going to talk about Shigella later, and Shigella is kind of invasive. That is, Shigella, in addition to releasing its toxin, it can also enter into the cell. Shigella can achieve cell-to-cell movement, and be causing direct injury to those epithelial cells or the mucosa that it's invading. But our enterohemorrhagic E. coli does not invade. Everything is just associated with release of this Shiga toxin. Shiga toxin will be released, inactivate 60S ribozyme, the cell dies. That is all. But Shigella will do this and at the same time invade that cell, gain entry into them, and destroy them. So don't forget the hemolytic uremic syndrome, and pentad. Don't forget the toxin involved. Don't forget the mechanism of the toxin. So moving down to the increased fluid secretion. So we have talked about the ones that suppress protein. I've talked about the close paddy, which is the Corynebacterium, diphtheria, and Pseudomonas aeruginosa, both of them inhibiting the elongation factor 2 by ADP ribosylation. And we have talked about the enterohemorrhagic E. coli and and Shiga toxin from Shigella working together to inhibit the 60S ribozyme, reducing protein synthesis and killing of the cells. For the increased fluid secretion, so there are a lot of them. You don't really need to cram them, just go with the flow. The first one is the enterotoxigenic E. coli. We have so many subtypes of E. coli. We have the enterotoxigenic, we have the enterohemorrhagic that we have talked about, we have the enteropathogenic, we have the enteroinvasive. A lot of them, like five or four or so. So the enterotoxigenic one is responsible for causing diarrhea, can cause traveler's diarrhea. So that means that there's a lot of fluid being secreted into the bowels, causing the diarrhea. So how are these fluids secreted into the bowels, causing the diarrhea? Enterotoxigenic. So it has two toxins that it releases: the heat labile toxin, and the heat stable toxin. The heat labile toxin and the heat stable toxin. Now, the heat labile toxin means that this one can be damaged easily, at higher temperature, at about 60 degrees. It can destroy this heat labile, while the heat stable is still more resistant to heat. And we talked about heat stable toxin, stable enterotoxin. We mentioned three. Yes, the day before yesterday, we talked about the stable toxin of enterotoxigenic E. coli. We talked about the enterotoxin of Staphylococcus aureus. And we also talked about the Bacillus cereus toxin. So those three toxins, they are stable. So we should have that at the back of our mind. And for the enterolabile toxin, how does it um, cause the diarrhea? So what it does is just to overactivate adenylate cyclase. That is it. They overactivate adenylate cyclase. Now, we are going to be talking about adenylate cyclase a lot with respect to this mechanism of this exotoxin. We talk about it a lot. And the byproduct of adenylate cyclase activation is what? Increase in CMP. It's as simple as that. CMP increases, and the next thing is that you have increased secretion of chloride into the gut. And mind you, just like we know, when sodium and chloride are secreted into the gut, what usually follows? Water. So that means that there's going to be a lot of water pooling within that GI lumen that is going to provoke a watery diarrhea. So this is not what? This is not bloody diarrhea, because we are not actually causing necrosis of any cell. There's no death of any cell here. We are just over secreting water. So the diarrhea is going to be watery. So if they ask you what are the causes of bloody diarrhea, we are not going to be picking enterotoxigenic E. coli. But it will make sense for us to pick something that destroys the mucosa, that causes necrosis of cells, such as enterohemorrhagic and Shigella. They can cause dysentery because they can cause a bloody diarrhea. But enterotoxigenic E. coli is just over-secreting water and chloride into the lumen, causing the diarrhea. The heat stable one also causes diarrhea by similar mechanism, but in a different way. So it does not overactivate adenylate cyclase, but it overactivates guanylate cyclase. Guanylate cyclase. So CGMP increase. So what will happen is that with increase in this CGMP, they will not reabsorb sodium chloride from the lumen. So in the heat labile, they are secreting, they are letting it go. They are letting chloride go into the gut. So that's the lability. They let it go. But each stable one, the S, they stop reabsorption of sodium chloride from the gut. So if you cannot reabsorb sodium and chloride from the gut, that means water is going to stay with them and there's going to be diarrhea. So each labile lets chloride into the gut, while the heat stable stop reabsorption of chloride from the gut. So both mechanism is going to allow water to pool there, and there's going to be diarrhea, but which is going to be watery. The next one is a Bacillus anthracis to release the anthrax toxin. Works similarly like this enterotoxigenic. It also helps in increasing fluid secretion. How? By also mimicking the activity of adenylyl cyclase. It mimics adenylyl cyclase and there's increased CMP. And when there's increased CMP, water, chloride, everything is secreted. So that is why an individual with anthrax, particularly the cutaneous anthrax, they have this characteristic edematous uh, um, uh, ISCA. So the ISCA, which is more like the primary lesion in the Bacillus anthrax, is edematous. So the borders are elevated and swollen. And I'm going to show us shortly. So the reason why it is edematous is because of the anthrax toxin, particularly the edema factor. Later, we'll also talk about the litter factor. So they do different things. The reason why it's swollen is because of the anthrax edema factor, anthrax toxin edema factor. So because it's overactivating adenylyl cyclase, increase CMP, increase fluid secretion, so the border appears edematous. So moving on to the next one, which is vibrocholeria. We already know vibrocholeria causes rice water diarrhea. Very, very voluminous diarrhea that is turbid like that of rice water. And because it releases cholera toxin, and the cholera toxin what overactivates adenylyl cyclase, just like the enterotoxigenic E. coli eat labile toxin. So both of them, they overactivate CMP by permanently activating the GS subunit. I don't know if we talked about this GS subunit in biochemistry. Anybody, please, I'm just asking as a question. Did we talk about it in biochemistry? The G protein coupled.
Yes,
uh
yes,
So
yes.
we already know that once you have overactivation of your GS, there's activation of granular cyclase, increase CMP, and water secretion. It's simple as that. Moving on to the next. The next we have here is the ones that inhibit phagocytic activity. So we have talked about the ones that increase protein, that reduce protein synthesis. We have talked the one that increase fluid secretion, and most of them, it's either they are increasing the activity of adenylyl cyclase or they are increasing the activity of guanylate cyclase. So the next is the one that inhibit phagocytic ability. Now, many people have a very high tendency of forgetting this one. That is why I want us to pay serious attention here and not gloss over it. We have a very high chance of forgetting it. But the telepathusis is the only one that is different. So it inhibits phagocytic ability of that cell that is infecting, maybe a macrophage, so that it can proliferate. That is what Bordetella pertussis toxin does. It also has a tracheal toxin that's going to be destroying the tracheal epithelium, causing the cough. But how does it evade host response and be able to release tracheal toxin to destroy the tracheal epithelium? It has to release the pertussis toxin. And what does this pertussis toxin does? It activates same adenylyl cyclase, increasing CMP, and it does this by inactivating the inhibitory subunit. So this makes sense because we said that if you activate the GS subunit, you are going to activate adenylyl cyclase. So if you activate the GS subunit, there's going to be an activation of adenylyl cyclase. Okay, but this GS subunit have something that inhibits it, which is the GI subunit. So it means that if the GI, which is the G inhibitory subunit, is activated, there's going to be inactivation of GS. But I don't want GS to be inactivated. So what do? I have to inhibit the inhibitory. So what Bordetella pertussis toxin will do is to inhibit the inhibitory subunit, which is the GI, so that there is nothing to inhibit the GS. So there's permanent activation of the GS, which will activate the guanylate cyclase, which will increase CMP. Now, when there is CMP overload in the macrophage or the neutrophils, they will be inactivated. They will not be able to phagocytose again. So that is the reason why Bordetella pertussis can, achieve the pathology of causing pertussis, because it has a way of evading the host response. So it can cause whooping cough, which we are going to talk about shortly, in which the child is going to be having cough on expiration and inspiratory. So you hear, like that, like that, like that, like that. So continuously, coughing continuously when they are breathing out, and when they want to breathe in, you have the whooping. So once you see that, you know that that's pertussis. So we have to keep that in mind, and usually I share with post-tussive emesis. So this is a very important clincher, post-tussive emesis. Moving on to the ones that inhibit release of neurotransmitter. Now, please don't forget, I've said that polyatellar pertussis increase CMP, and that increased CMP is not going to be causing water like the other ones, but it's going to overload the macrophage, and the macrophage will start misbehaving. They cannot function. So the next one are the ones that inhibit release of neurotransmitters. And we have about few of them. We have Clostridium tetani and Clostridium botulinum. So it's very simple. From the name, you can just say Clostridium species. That's the way they work. So Clostridium tetani inhibits which different neurotransmitter from Clostridium botulinum. But what are the different toxins? For Clostridium tetani, the toxin that is released is tetanospasmin. Tetanospasmin. For botulinum, it is a botulinum toxin. Now, what do? These two toxins, they are proteins that cleave off what we call the snare protein. You don't need to cram this. Just know that the snare protein is a SNSF receptor. Don't worry yourself about what it means. Just know that they cleave this snare protein. Now, we need this cell protein. We need this cell protein if this is the, if, let me draw. So, if this is a synaptic cleft and we have the muscle here, this is a muscle, this is a nerve here, N, and this is a muscle here, M. Now, within these regions here, we have neurotransmitters that dock in this area. So there's a snare protein nearby that once it is activated, it will drive these vesicles down so that they can fuse with the synapse and they can discharge their content to act on the muscle. So it means that if there's no snare protein around, there's nothing to push down the vesicles to fuse with the synaptic membrane and release their neurotransmitter into the muscle. So that is what the Clostridium tetani and Clostridium botulinum are doing. So what do? They are proteins that will cleave off the snare protein, and there's no fusion of the vesicles here to mediate release of neurotransmitter. Now, what I'm going to mention here is that for Clostridium tetani, the neurotransmitters that are released is different from neurotransmitter for Clostridium botulinum. Now, the neurotransmitter that the tetanospasmin of Clostridium tetani act against, is the glycine majorly and GABA. So glycine and GABA, they are inhibitory neurotransmitters, and they are found within the range of cells of the spinal cord. Now, let me see if there's a way I can draw this range of a thing so that we understand. So let's say that this is the spinal cord here. This is the spinal cord. So we have some interneurons that emerge from the spinal cord that we call the Renshaw cells. So these are the Renshaw cells here, RS, and it interconnects with the alpha motor neuron. So there's a bridge here. So this is where the Renshaw nerves connect with the alpha motor neuron, and of course the alpha motor neuron is going to supply what? The muscles, right? So these are the muscles. So what will happen is that um uh what's it called? This guy tetanus, what's the name again? Clostridium tetani is going to come and is going to release the tetanospasmin. Now, what the tetanospasmin will do is that because it travels retrograde, it moves like this from the muscle to the spinal cord. That's the way it travels. They travel in a retrograde manner. So what they will do is that when they get to this Renshaw cell here, they are going to inhibit release of two neurotransmitters, which is glycine and GABA, from this Renshaw cell to act on this alpha motor neuron. Because at this point, there's a synapse here. So normally, some neurotransmitters are released from the terminal portion of these Renshaw cells here to act on the initial portion of the alpha motor neuron, which supplies the muscle. So it means that, and we have said it, that glycine and GABA, they are inhibitory neurotransmitters. So it means that if the tetanus plasmin is preventing release of GABA and glycine to this alpha motor neuron, there's nothing to inhibit the alpha motor neuron. What do we think will happen to the activation level of the alpha motor neuron? Is it going to be increased or decreased?
Increase.
It is going to be increased. So that means that they are going to be overly activated, and there is going to be unopposed activation of the muscles. And that brings about the spastic paralysis that we have with tetanus. So we have the three things, all those things that we list here: the spastic paralysis, the resource sardonicus, which is hypercontraction of the muscles of the face, right? The trichmus, which is like the lockjaw, the hypercontraction is masseter muscle, and of course, the hypercontraction of the muscles of the back, the extensor muscles of the back, the opisthostonus. So you just see them stretching, opisthostonal position. I know we know that. The lockjaw, they cannot open their mouth. They have like hypercontracted face, rhizus sardonicus, and of course they are paralyzed, but in a tonic state, spastic paralysis. So once you see all these things, you know that this is an hypercontracted state that is happening, and likely to be from tetanus. So that is pathophysiology of the tetanus, causing the tetanus plasmin, toxin of tetanus causing tetanus. Now, how does this guy, Clostridium botulinum, does it all? Now, where the botulinum toxin is going to act is here, not here. So the botulinum toxin is going to act here. There's a synapse here between the alpha motor neuron and the muscle. Now, I want to mention that the neurotransmitter that we have at this terminal portion of the alpha motor neuron to this muscle is acetylcholine. That is acetylcholine. We remember that the neurotransmitter that allows for contraction of uh, skeletal muscle, which act on the nicotinic receptor, is what? Acetylcholine. Hope we remember that. We remember, right?
Yeah.
Yes.
So,
Yes.
so
Mm.
that is where this guy is going to target. So botulinum toxin is going to come to this point. It's going to cleave off the snare proteins. And when the snare proteins are cleaved off, there is nothing to drive the fusion of the vesicles with the nicotinic receptors on the muscles. So that means that there is no release of acetylcholine to the muscles here. So that means that these muscles are not going to be stimulated. So that means that the muscles are going to be flabby. They are going to be floppy. So they are going to be weak. So instead of having spastic paralysis, we are going to be having what? Flaccid paralysis. So I just want to mention that we have two forms of Clostridium infection. We have the infantile botulism and we have the foodborne botulism. Now, the way I want us to look at it is that the foodborne type is the one that occurs in adults, while the infantile one is one that occurs in infants. Now, there's a difference, and they can ask you in your exam. So we have to know it. We have to pay attention. In the infant one, it takes a longer process. That means that the organism has to grow. It has to release the toxin. Then infection setting. But in the adult or the foodborne botulism, the toxin is already there. It has grown already. So the toxin is already preformed. The toxin is already preformed. And where do we find the toxin? You can find the toxin on canned food. So people that take a lot of canned foods, they can develop foodborne botulism because it usually contains a preformed toxin of this botulinum, and from there the toxin is already ready made in the body, and it inhibits this snare stuff, and there's absence of release of acetylcholine, causing problems, right? But for the infantile form, what they take is the spore of this Clostridium botulinum. Now, when the infant takes in that spore is now going to germinate under favorable condition into the vegetative form of the organism. We remember which uh, which uh, which class of organism do we say they normally form spore? Anybody remembers?
Bacillus and
Yeah,
Clostridium.
yeah, that doctor is correct. Bacillus and Clostridium, very correct. And we said the general class is the gram positive. So that means that we can say that Clostridium is a gram positive. That's number one. We're already classifying it. We can say confidently that this guy is going to be a gram positive organism because it's forming spores. So now, when this spore gets into the human system, the blood, the condition becomes favorable because there's nutrient, there's oxygen, there's everything, there's good supply of nutrient and everything. So they can change into the vegetative bacteria. So when the vegetative bacteria develops, so that is the one that will now be releasing the toxin. So that's why they said the toxin is produced what? In vivo. And how is it acquired? That infant will have taken soil, raw soil, or the infant will have taken raw honey. So that is why in the US, they don't give their child honey when they are less than 1 year. Go and check it anywhere, you see it. It's because they are scared of infantile botulism. We in Nigeria or
You're
other
right.
countries, hello?
Said you're right.
Yeah, thank you for confirming for me. So they don't give honey because of this problem. Because if you give them, they can develop this infantile botulism from the injection of the spores, because the spores is usually contained in the honey and the soil. So no matter the way they frame the question in the exam, you are ready for them. Just look at the age, look at the presentation. Okay, this is an infant. This is likely to be infantile botulism. The toxin is not preformed. The baby must have taken the spore that will germinate into the vegetative bacteria that will now give rise to the toxin. But for the foodborne in adult, it's not going to come from soil or honey. It's coming from canned foods. They take canned Pepsi or they take Gesha that contains the preformed toxin and they develop the infection. So moving on to the ones that they lyse the cell membrane. These ones are lytic. So the way I remember them is just that the ones that end with the G, the genes. So like Clostridium perfringens, the Streptococcus pyogenes. These ones have ability to lyse anything. And the lytic toxin for Clostridium perfringens is what? The alpha toxin. You don't need to actually cram the toxin because they will not ask you what toxin. They will not. What they are actually interested more in is the mechanism by which it works. So then that of Streptococcus pyogenes is the streptolysin whole, alpha toxin. So now, how do they function? So alpha toxin of Clostridium perfringens is a phospholipase toxin. So it has phospholipase activity or lecithinase activity. So lecithin, all of them, they are like phospholipids. So it degrades this phospholipid in the cell membrane. And at the end of the day, when they break down of the cell membrane, anybody know what's going to happen? Pathology. You break down the cell membrane, what will happen?
Inflammation.
Inflammation. And inflammation is going to lead to necrosis because it is only necrosis that will say that the cell membrane is what?
Broken.
Is compromised.
Cell
In
membrane
apoptosis,
is
do we have
compromised.
compromise of the cell membrane in apoptosis? No.
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 But
No.
once the injury is irreversible or what is a necrotic death, the cell membrane is, compromised, and there is, eventual inflammation. So, that's they degrade the phospholipid of cells, triggering, necrosis at the end of the day. And the cell they usually attack, the muscle, the tissue that they usually attack is the muscle and the fascia. So they attack the muscle and the fascia. So that's why they can cause myonecrosis of the muscle as well as necrosis of the fascia, so causing necrotizing fasciitis or what we call gas gangrene. So gas gangrene is a form of necrotizing fasciitis. So if you remember when we were talking about dermatology, I mentioned some organisms that causes necrotizing fasciitis. We talked about the gas, group A strep, and we also talked about anaerobes like Clostridium perfringens that have the tendency to release gas. I think I'm going to talk about it somewhere, so would further emphasize that. And it also have the ability to lyse, in addition to lysis of the membrane of the fascia and the muscle, it can also lyse the membrane of the cell, the red blood cell, so causing hemolysis. And the hemolysis is usually like a double zone of hemolysis. Just don't worry yourself about, just know that there's hemolysis. That's all. So the double zone tells me you have a light form and you have a darker form. That's it. One is light, the other is dark. So you can check that up later. And the next one is the Streptococcus pyogenes, the gas. An example of group A strep is Streptococcus pyogenes. We are going to look at that shortly, the classification, and it releases streptolysin O. And this is a protein that degrades the cell membrane, just like the phospholipase of apoptosis. Degrades the cell membrane. It lyses the cell, just like the Clostridium perfringens, causing hemolysis, you know, And the hemolysis is beta hemolysis, so meaning that the hemolysis is complete oxidation of hemoglobin. It oxidizes hemoglobin too, and it is complete. You see like a zone of clearance around it in the Hager. We are going to see some pictures shortly, and it's going to make more sense to us. And so in addition to infection by this because pathogen, because of release of this toxin, the body produces some antibodies against it, and that is what they call the ASO. So remember that this is part of what we assay for when Dr. Babandi was talking about rheumatic fever. Part of what we assay for is the ASO titer, to be able to diagnose rheumatic fever. But I want to tell us, or I want to remind us again, that you don't correlate ASO titer with post-streptococcal glomerulonephritis. You do not correlate ASO titer with post-streptococcal glomerulonephritis. Don't make a mistake, because the problem, the type of hypersensitivity, what is the hypersensitivity in rheumatic fever? Immunology. What is the hypersensitivity in rheumatic fever? What type?
Type 3.
Type 3.
Type 3.
Rheumatic fever. Rheumatic fever. Rheumatic fever.
So,
Not
It's
rheumatic
type
arthritis.
2.
Eh?
Oh, yeah, type 2, type 2.
You see,
Two.
I'm bringing us potential questions. Potential questions. Type 2, because it is just the antibody that is causing the problem. This ASO antibody, antibody against it's not actually ASO antibody, it's antibody against the M protein, the M protein, which is attacking the heart, causing the carditis. That's antibody problem, type 2. But in post-streptococcal glomerulonephritis, there is immune complex that is deposited. That is a type 3
type 3.
hypersensitivity. Type 3 hypersensitivity. So you must always separate them and be ready for it in your exam. So you don't correlate ASO titer with the post-streptococcal. It's only correlated for rheumatic fever. So moving on to the super antigens. So what do we mean super antigens? We mean that antigens that have the ability to provoke shock without any drive, without anything that is actually like, let me use what's constitutive, continuously, no control, super antigens causing shock. So we have two organisms, Staphylococcus aureus and Streptococcus pyogenes. Streptococcus pyogenes, Staphylococcus aureus. So they release the toxic shock syndrome toxin. The toxic shock syndrome toxin. The toxic shock syndrome. There's no way you go for exam and you don't know TTST. It is not possible. You are going to see it in the exam. They will ask you. So there's the TTST and there's the erythrogenic exotoxin A of strep pyogene. So the strep pyogene and the Staph aureus, both of them can mediate toxic shock. And the toxin that is used by Staph aureus is what called the toxic shock syndrome toxin, TTST toxin. Why that of strep pyogene is the erythrogenic exotoxin A. These guys, what do they do? So what they do is just that we know that when we want to activate initial phase of T cell activation, the antigen presenting cells, they bear the MHC class 2, and that is the one that will contain the peptide portion of the antigen they want to present, and they will go and present it to the T cell receptor. Now, what these guys will do is that they would cross-link the beta region of the T cell receptor to this MHC class 2 receptor on the APC permanently. So, outside the antigen presenting side of this MHC. So that's going to be like a permanent connection, and it will activate some downstream cytokine release. So you cross-link the beta subunit of the T cell receptor to the MHC class 2 receptor on the APC, but outside the antigen binding site of this MHC. So from there, you are going to have overwhelming release of interleukins like interleukin 1, TNF alpha, interleukin 2, and gamma interferon. And there's going to be shock at the end of the day. There's going to be shock at the end of the day. So that is what we call the toxic shock. Now, what are you going to see in your exam that's going to raise your suspicion for toxic shock? Number one is that you must see something that will tell you that is a shock. And what are you going to see? That you first know that, okay, with what I'm saying, this is a shock. The first thing is you are going to see hypotension, you are going to see tachycardia, you're going to see fever. So there's always fever. There's always fever. They just put shock here. They just summarized. They have given us a summary. But what we are going to see to make us know that there's a shock is the hypotension and the tachycardia. Then afterwards, you'll be seeing some rash. And they will tell us that the rash is disquamating. It is shedding after some time. The rash sheds after some time. So once you see fever, you see rash that is disquamating, and you see end organ injury. For example, the person is presenting with AKI. For example, the person is presenting with elevated transaminase level, liver failure. You already know that this is likely to be toxic shock syndrome. It is becoming toxic to the organs. There's a shock that's becoming toxic to the organs. And I'm seeing fever, I'm seeing a disquamating rash, I'm seeing evidence of shock, and I'm seeing end organ failure. This must be toxic shock until otherwise proven. So don't forget the other toxin that is released by Staph aureus that we mentioned in dermatology, the exfoliative toxin that we talked about that inhibits. Anybody knows what is this exfoliative toxin? What does it inhibit? Anybody remembers in our dermatology? Anybody remembers?
Desmoglins.
Desmoglins. Thank you. So desmoglins are taken up, and at the end of the day, you just have shedding, separation of those epithelial layers, causing scarred skin syndrome from Staph aureus. And I said that it spares the mucosa. They can have a perioral crusting, but it will not affect the mucosa. That's how you can be sure that, okay, what we are saying is scarred skin syndrome. It can also release some other toxin, which include the heat-stable enterotoxin that cause food poisoning. So we have talked about 3 toxins from Staph aureus. Now, we talked about toxic shock syndrome toxin that does all this, and presents just like I've said. And we also have the exfoliative toxin that causes staphylococcal scarred skin syndrome. And we have the heat-stable enterotoxin that causes food poisoning. Then, moving down to Streptococcus pyogenes. Streptococcus pyogenes, similar, the fever, the rash, the shock, and there will be a scarlet fever. So the person will have some strawberry tongue, can have pharyngitis, can have a sore throat, can have strawberry tongue. They can have a maculopapular rash that has a sandpaper-like feeling. Once you are saying that, they can have the cervical lymphadenopathy. Once you are saying that, okay, this is likely to be scarlet fever from strep pyogenes. Then after that, they now tell us that the rash started becoming disquamating, person having fever, having hypotension. You know that, oh, this is likely to be toxic shock like syndrome, because this one is caused by strep pyogenes, not Staph aureus. So we call it toxic shock like syndrome. So scarlet fever is caused by Streptococcus pyogenes. So, and I'm going to mention it shortly. So that would make sense to us. So what about the what about the endotoxin? So endotoxin, just like we have talked about, all of them, they are mediated from this lipopolysaccharide, except Neisseria that has the lipo-oligosaccharide. And the major component of the endotoxin that is interesting, that is major to us, is the lipid A component. That's the toxic component. That's the part that we need. And this lipid A component is usually released by cell lysis, or when you have the living cells detaching from, detaching by formation of blebs. So you're having for example, you're having maybe this is a bacterial cell now, a gram negative, and it's now forming blebs. And these blebs are now detaching blebs, because these blebs too will contain the lipopolysaccharides. So from there, they can release the lipid A into the environment and lead to the endotoxic shock.
Look, I don't know. Is it for
So,
me?
we are breaking up.
Breaking up.
Thought it
We
was
can
just
hear
for
you.
me.
Yeah, I was even thinking it's from my side.
Me
Hello.
too.
Sorry, where did you
Yes,
notice that?
breaking.
I think your connection is something is wrong with your connection. We can't really hear you.
Wow.
It
How long
is
has it been
breaking up.
happening?
Yeah.
No, it just started.
Yeah,
When
at
you
the
started talking about
Like
Not
2
really. It's
minutes.
just on and
yeah.
Okay.
When you
Hello, docs. How is it now? So, um, back to what we're talking about. So, uh, sorry, 1 minute, 1 minute. Okay, let's just continue. So, um, let me just sort out this thing once and for all. Please, 1 minute, 1 minute. Okay, yeah. So, the lipoprotein, just like we said, it can be released by the lipid A rather, which is a toxic component. It can be released by either the bacteria forming blebs, or if there's eventual lysis of the bacteria. Unlike exotoxin that are typically secreted, the lipid A are not secreted. They are released from damage to the bacteria. So don't forget that the Neisseria only has the lipooligosaccharide. And so what does it do? This endotoxin, when it is released, how does it cause the endotoxic shock? So it activates three things: the macrophage, the complement, and the tissue factor. So it activates the macrophage by interacting with the toll-like receptor 4 and the CD14 receptor. So these CD14 receptors, they are present within macrophage. So once this lipid A interact with this toll-like receptor and the CD14 receptor on the macrophage, it will activate the macrophage. So don't forget these receptors. They can ask you in the exam too. Toll-like receptor 4 and the CD14 receptor. So that activating pathway is what will make the macrophage release all these cytokines, which includes interleukin 1 and 6, TNF alpha, and nitric oxide. The nitric oxide is going to cause vasodilation, which will lead to hypotension. The TNF alpha will cause fever and vasodilation that will lead to fever and hypotension, while the interleukin 6 and the interleukin 1 will cause fever. What additional thing will interleukin cause? Interleukin 6. What additional stuff does it provoke?
Active
Activate reactant.
Yes, it will release the active phase reactant. Very important stuff. So then the endotoxin again doesn't stop there. It will also activate the complement, and it will release two complements, C3A and C5A. Both of them, they are anaphylactic substance. That is, they can both provoke release of histamine. So if you look at the arrow, it is interconnecting to form one common pathway, which is a histamine pathway, because both of them are anaphylactic, agents. So they can ask you that in your exam. Don't forget. So histamine released from this C3A, C5A, and that will cause hypertension and edema. But C5A alone is a chemoattractive factor for a neutrophil, not C3A. So C5A can also, in addition, bring in the neutrophils for the inflammation. Then the endotoxin, lipid A component, also activates the tissue factor pathway, which will lead to coagulation, and that's the reason why some septic shock can be complicated with DIC. So moving on to the algorithm for classifying our gram-positive organisms. So we have the fact that all of them appear blue or they appear purple. They appear blue or they appear purple. That's the first thing. Once you see that on gram stain, you know that, okay, this is likely to be a gram-positive. So the next thing is to start looking at their shape. How do they look like? Are they branching filaments? Are they round or are they rod? So if it's branching, we can further classify into the aerobic and the anaerobic. So when we're talking about the anaerobic organism, we said we have A, B, C, D, F. I think so. A, B, C, D, F, right? Fusobacterium, Bacteroides, Clostridium, right? Okay, A, B.
ABCDF.
ABCDF.
So what's the D? Do we have anything for the D? No, I don't think
No.
there's
No,
D
nothing.
is
It's
not
no.
ABCF. So it's ABCF. So Actinomyces israeli, the Bacteroides, the Clostridium, and the Fusobacterium.
Fusobacterium.
Yeah. So and the Actinomyces is part of the anaerobe, and it's a branching filamentous organism, and at the same time, it is a gram-positive organism. It is gram-positive. So that's that about Actinomyces. Then, if we are seeing branching filaments, but aerobic, then we have to think of nocardia. So nocardia and actinomyces are branching filaments like this, but one is aerobic, the other is anaerobic. The aerobic one is nocardia, and it is weakly acid fast. Weakly acid fast, unlike actinomyces that is not acid fast. Okay. So coming down to the bacillus. So the bacilli, just like branching filament, we can separate them into aerobic bacilli or anaerobic bacilli. And the aerobic ones are the living bacillus community. So the living bacillus community, the L standing for Listeria, the B standing for Bacillus, not Bacteroides. Anytime you mention Bacteroides, you don't know that this is anaerobes. So, but Bacillus is an aerobic organism. So living Bacillus community. Then the C is a Corynebacterium. All the ones that are highlighted, they are very important. That's why they are highlighted. Then for the bacilli that is anaerobic, so that's Clostridium. Clostridium is number one that we must always remember. Gram-positive, because we said Clostridium can form spores, so it is a gram-positive, and it is anaerobic. Clostridium is anaerobic, and other example is Cutibacterium, Propionibacterium. Let's just know our Clostridium. That's the most important one. A gram-positive anaerobic bacilli is Clostridium. So living bacterial community, Listeria, Bacillus, Corynebacterium. Then for the anaerobic, Clostridium. Now, for the round one, the cocci, the first thing we need to do, because for the cocci one, they can be two class. Either it is a staph or it is a strep. But the first test that we do to even separate one of them is that, I believe that the staph, they are stronger. So, so staph, they are what? Catalase positive. While the strep, they are weaker. They are catalase negative. So once you are seeing catalase positive, gram-positive cocci, you already know that they are talking about the staphylococcus. Once you see gram-positive cocci, that is catalase negative, you already know that they are talking about a strep. Now, what about the shape? You are going to notice that the staphylococcus, they will be in clusters like this, something like this. They'll be clumped together. Why strep are always in chains? They are always in chains. They are always in chains. They are always in chains. So moving on, how do you further classify the staphylococcus? How do you further classify the staphylococcus? You further classify them by testing the coagulase positivity. Is it coagulase positive or negative? So the one that is coagulase positive is Staph aureus. That's the baba of the group. It is coagulase positive, and that's the reason why Staph aureus can form abscess, because it can form a coagulum around itself. Abscess, because of the coagulase positivity. Now, the other ones are coagulase negative, which is the Saprophyticus and the Staph epidermidis. But how do you separate them? Saprophyticus is stronger than epidermidis. Saprophyticus is stronger than epidermidis, and that is why epidermidis can be killed by novobaosin. So novobaosin is a form of antibiotics. You just introduce novobaosin to that solution, and epidermidis is sensitive to it and will be killed off, while Saprophyticus will still stand. So don't forget, you look at the color, you look at the shape, round. Okay, is it catalase positive or not? If it's catalase positive, that's the staph. Further confirm with the shape, it will be in cluster. Then you test for the coagulase to even know if it's aureus or the other ones. Aureus is coagulase positive, so you know that that's aureus. If it's coagulase negative, you know that it's either epidermidis or Saprophyticus. So you just do your novobaosin test. This one will die, Saprophyticus will still be living. Now, moving back to the catalase test. So if it's negative and you are seeing that it's already existing in pairs, you know that, okay, this is likely to be a streptococcus. So it can occur in pairs or in chain. Now, the next test to do for the strep is to do what we call the hemolysis test. Unlike staph that you do coagulase test, hemolysis test is the next thing you do. And you are going to categorize them into the alpha hemolysis, the beta hemolysis, and the gamma hemolysis. Actually, the best one in terms of the hemolysis, complete hemolysis, which is the beta hemolysis. But I want us to look at the word alpha literally. as alpha being superior. So you don't ask somebody that is superior for their ranking, please, your rank. So that is why we don't do the PYR status in the alpha, and you don't do the PYR status for somebody for an organism that has an alpha hemolysis. So an organism that has an alpha hemolysis pattern means that organism is demonstrating a partial hemolysis, and the color on the algae is going to be green. So don't worry, don't get confused. I'm going to show us what I'm talking about. So if you put an organism into an agar, blood agar, and you are seeing green colonies, that means like that's likely to be partial hemolysis. And that it means that that organism is an alpha hemolytic organism. So you don't ask them for their POIR status. So the only thing you do is just to do the optogene test and the biosolubility. So two organisms fall under the category of this alpha hemolysis. Either you are dealing with the viridans strep or you are dealing with strep pneumo. Unfortunately, out of these two, strep pneumo is the weakest. Strep pneumo is the weakest. Strep pneumo is the weakest. So strep pneumo is sensitive to optogene, can be killed by optogene, and at the same time, strep pneumo is dissolved if you put it in bile. But the viridans streptococcus like strep mutans, strep mitis, they are not dissolved in bile and they are not sensitive to optogene. So moving on to the beta hemolysis organisms. So these ones are the ones that they will form a complete hemolysis on the blood agar, and this is what I mean by the complete hemolysis. You will see a zone of clearance, a central zone of clearance around the organism. It means that this guy is actually hemolyzing. But these ones, although we are not seeing the green color here, but you can see that the hemolysis pattern is not very obvious. So it means just tiny. But for gamma hemolysis, you will not even see any light area at all surrounding it. You will not see. You just see complete area being surrounded by blood. So that means that there is no hemolysis. That's a gamma hemolysis. So for the beta hemolysis, they call a complete hemolysis with a clear zone around it. And the B means you are going to do bacitracin sensitivity. And of course, you are going to ask them for their PYR status. What is your PYR status? What do you rank? And of course, the bacitracin sensitivity. So you can use this to classify them into the group A and the group B. The best one here, the stronger one here is obviously the ones in group A. They are the ones that are the senior of the ones in the group B. And an example of an organism in the group A is what? Strep pyogen. While the one in the group B is strep agalati. So you are comparing agalati with pyogen because both of them, they are beta hemolytic. So you want to separate between them, and you have to subject them to the bacitracin test and the PYR status. So the group A, which is strep pyogens, they have a positive PYR status. That PYR is just like an enzyme. Don't worry about it. Just know the periloading aminopeptide is an enzyme. So it's positive in strep pyogen, and because they are stronger, they are not going to be. They actually sorry about that. That's a mistake. They are susceptible to bacitracin. They are killed off by bacitracin, but they have a higher ranking, but they are killed off by this bacitracin still. But for the group B, they are resistant to bacitracin, but they have no PYR status. So you can't have both. So the strep pyogen have a good ranking, they have a PYR, but they are sensitive to bacitracin. Bacitracin will eliminate them. But group B are resistant to the bacitracin, but they have no PYR status. So moving on to the one that do not show any form of hemolysis, that is what we call the gamma hemolysis. And these ones, they grow in bile. They can grow in bile. So they can grow in bile. And so how do you separate between organisms of the gamma hemolysis? So two classes of organisms, the enterococcus and the non-enterococcus. Under the non-enterococcus strep, we have strep bovis. Under the enterococcus, we have enterococcus fecum, enterococcus fecalis. So the enterococcus guys, non-enterococcus, enterococcus, they show no hemolysis, gamma hemolysis, but they can grow in bile. They can grow in bile. So How do you separate between them? You put them in a very harsh condition. And what is this harsh condition that you are putting them? You are subjecting them to growth in 6.5% sodium chloride. And you're also asking for their PYR status. So Enterococcus is strong. This guy is very, very strong. In fact, very drug resistant. And it has a positive PYR status. So it has a better ranking. And it can grow in 6.5% sodium chloride. But Strep galolyticus, otherwise known as Strep bovis, Strep bovis, it gets killed off in this 6.5% sodium chloride. Although it can grow in bile, but it cannot grow in 6.5% sodium chloride, and it has a negative PYR status. So I know that the algorithm is a little bit confusing, but at least this one should be very straightforward to us. The coagulase test and the novel biosyn test were done. But this, you still have to subject it into the alpha hemolysis, the beta hemolysis, and the gamma hemolysis. So gamma enterococcus guys, they show no hemolysis and they can grow in bile. But there are two types, the enterococcus and non-enterococcus. Enterococcus has a positive PYR status and it can grow 6.5, while the other one, which is Strep galolyticus, cannot. For the beta hemolysis, just do your bacitracin test. Group A are killed by bacitracin. Group B are not killed by bacitracin. Then for the alpha hemolysis, just do your biosolubility and your optogene sensitivity. Strep pneumo is under alpha hemolysis. It's eradicated by optogene and it's dissolved in bile. While the viridant will not be dissolved in bile and is not sensitive to optogene. So this is just more like what we are saying again. Alpha hemolysis, they cause partial oxidation of hemoglobin, and there's a greenish or brownish discoloration without clearing around the growth. So just like this, no obvious clearing, just some brownish discoloration. And that is for the alpha hemolytic guys like Strep pneumo and viridant. Don't forget you separate these two by doing what? Optogene test and biosolubility. Then for the beta hemolytic ones, these are the ones that cause complete paleness around the growth area. And we have to talk about the two major ones, which is what? The group A and the group B. The group A includes strep pyogenes, and the group B includes strep agalati. Strep pyogenes, group A, and strep agalati for group B. And the other ones include listeria. Listeria is also beta hemolytic, and Staph aureus is also beta hemolytic. Staph aureus is also beta hemolytic. Listeria is also beta hemolytic. So they can grow on blood agar with some pale discoloration. So what about Staph aureus? Staph aureus, what's it called? Is a very popular guy. It is a gram positive, just like we know. And the next thing to separate it is to look at the shape. It is a gram positive cocci, And how does this shape appear? They appear in clusters, just like you can see here. Cocci, purple organism, meaning it's gram positive. Circular, meaning it's cocci in cluster. So gram positive cocci in cluster. Then the next thing is to do the catalyst test. Is it positive or negative? Okay, this is Staph aureus. It has to be positive, right? Then the next thing is to do which test? The what?
Coagulase
The
test.
coagulase test, and it's going to be coagulase positive,
Positive.
right? Then we have to also mention that Staph aureus is the only staph that is urease negative. Don't forget the P chunks. The P chunks. So the chunks have double S, which is a S for Staph saprophyticus and Staph epidermidis. But Staph aureus is not urease positive. So we talked about the virulence factor of Staph aureus. I mentioned Staph aureus as a baba, and is the one that uses the protein A. The protein A, which binds to the FC region of IgG, preventing against phagocytosis and complement activation. We talked about this when we were talking about the virulence factor. So I don't want us to forget that at all. And where does it commonly colonize? The skin, the nares, in the nose, the axilla, the groin, where, we can know that the skin and the nares commonly, very important. And what does it cause? Staph usually causes two classes of infection, the inflammatory disease and the toxin-mediated disease. Please bear with me. I'm still going to show us some questions later. We have some little questions later. So, so the inflammatory and the toxin-mediated. So for the inflammatory, what are we talking about? So like skin infection, we talked about impetigo in dermatology, the bullous impetigo, right? Staph aureus is implicated. We talked about the fact that staph can cause abscess, and I said which type of staph causes abscess?
Aureus.
The aureus,
Orange.
because of the fact that it has what? Coagulin.
Coagulate.
So
Coagulants.
because of the fact that it
Coagulate
has coagulin,
positive.
it can cause pneumonia, usually after viral infection like influenza. It can cause infective endocarditis. You cannot forget this. Infective endocarditis. People with normal valves having infective endocarditis, think about Staph aureus. It can cause infection in the joint and the bones. The joint causing septic arthritis, in the bones causing osteomyelitis. Then the ones that are mediated by the toxin, not inflammation to the organism, but toxin released by the organism. So that's when we start talking about the TSST, right? We talk about the exfoliative toxin, and we talk about the what? Stable enterotoxin. It is as simple as that. Just list those toxin. TSST, the exfoliative toxin, and the what? The enterotoxin, which is heat stable. Enterotoxin that is heat stable. So TSST is the one that will cause the toxic shock syndrome, and we have mentioned the way people with toxic shock syndrome will present. The exfoliative toxin is the one that will cause the staphylococcus scarlet skin syndrome, and people with the enterotoxin present with rapid. You see, this is what you need: the rapid onset food poisoning. So if they tell us that somebody goes to a family meeting and they ate rice and beans or mayonnaise, and within 2 hours they start purging, that's rapid onset food poisoning that occurs within 2 to 6 hours, caused by Staph aureus. Very high UT stuff. Staph aureus can be methicillin resistant. So I have methicillin resistant Staph aureus, which is very common in the hospitals, very serious problem in the hospitals and the community. And that is due to the fact that they have this MEK gene. So it's because of this MEK gene. And what does this MEK gene does? The MEK gene alters the structure of the penicillin binding protein. Anybody remember the function of the penicillin binding protein?
Yes,
It causes cross-linking.
Exactly.
activity.
Because it has which enzyme activity?
Transpeptidase.
Transpeptidase. So now, the drug that we are giving, like penicillin, or our penicillin, they actually resemble that penicillin binding protein. So they bind to the penicillin binding protein and inhibit it. That is what they do. Methicillin is an example of a penicillin. So what Staph aureus will now do is that, this guy, they don't get my code. So they are now developing drugs that can bind to my penicillin binding protein and inhibit it, transpeptidase activity, AB. So what I will do is that I'm going to change the structure of that penicillin binding protein so that your drugs will not be able to bind to it. So that's how they now introduce this MEK gene. They got this MEK gene from their forefathers, and they now start altering the shape of their penicillin binding protein such that methicillin does not fit to that penicillin binding protein to inhibit it. So that is the mechanism of methicillin resistance in Staph aureus. Some of them also release this palantine leukocidin that kills the leukocyte. From the word leukocidin, they kill the leukocyte and they cause tissue necrosis. So we have talked about the TTST is a super antigen that cross-link MHC2 beta subunit, the beta subunit of the T cell receptor to the non-antigen binding portion of the MHC2, resulting in polyclonal T cell activation or release of interleukin 1, interleukin 2, TNF, gamma interferon, and the likes, causing sepsis, right? And we also talk about the presentation, which includes the fever, the shock, and the rash. Don't forget, the rash is desquamating rash, rash. And of course, end organ failure. So you can see elevation AST, ALT level for liver failure, bilirubin level for liver failure, and AKI, erythrocyte, electrolyte urea and creatinine elevation, that shows that okay, it's affecting the kidneys. Now, you must also look for the source in the question. Either they are telling you that the person had a nasal packing for like 10 days and the person did not change the pack, or the person had a vaginal tampon horn, that became infected and the person develops this guy. So it's very common in people that pack their nose with this, or people that apply tampons with their vagina for a long time without changing. So that can cause staphylococcal toxic shock syndrome. So you have to compare with the pyogenes. It's toxic shock like syndrome that we talked about. So that one is usually I share with a painful skin infection. I want to ask what is that painful skin infection, but we might not. Dermatology. Anybody knows? So strep pyogen can cause some skin infection. Anybody remembers anyone? Can we remember?
It causes cellulitis and erysipelas.
It causes cellulitis and erysipelas. That is very correct. So, it could be maybe erysipelas, it could be some form of cellulitis, So that's that about streptococcus pyogenes. So once you see that and you're now seeing features of TSS, being present, that that's likely to be, TSS-like syndrome. We also talked about the preform toxin, which is what? The enterotoxin. It is preformed too. So that's why the incubation period is very small, within 2 to 6 hours, because already preformed in the meal. So it's not the spore that's germinating into the vegetative bacteria that is not producing the toxin. No, the toxin is already preformed in the meal. So they are just eating the toxin as they are eating the meal, and they'll start having a non-blood diarrhea within 2 to 6 hours. So it is not destroyed by cooking because it's stable. We talked about the fact that it has coagulase that forms fibrin clot around itself, and that's the reason why it can lead to abscess formation. Very simple way to look at Staph aureus. That's all you need for your exam. The question cannot go beyond this. Trust me. So, Staph epidermidis. This guy is a normal commensal of the skin. So anything that involves you penetrating the skin, you can easily introduce epidermidis into the bloodstream. So don't forget, it is a gram-positive. It is catalase positive, of course. That is why it is Staph, but it's a coagulase negative. But it is urease positive, just like we have talked about earlier. And it's a coca that is expressed in clusters. And again, it is what? Killed by novel biopsy. It is killed by novel biopsy. It does not ferment mannitol. So Staph aureus can ferment mannitol, MSI agar, mannitol, salt, something agar. Mannitol, someone's laughing. So Staph aureus can ferment mannitol, but Staph epidermidis cannot ferment mannitol. So keep that in mind too. It is a normal microbiota of skin and it can contaminate blood culture. What is important with respect to Staph epidermidis is the use of prosthetic device. So if somebody gets a prosthetic device and start developing infection within 3 months of introducing that device, think about Staph epidermidis. So what are these prosthetics? Hip implants, heart valves, IV catheters, because it can form biofilms. And we said the basic composition of biofilm is what? The colonies of the bacteria attaching. And what component of the biofilm, what component of the bacteria allow for biofilm? The
The slime layer,
slime layer that is made up of what? Anybody knows what is made up of?
polysaccharides.
Polysaccharide. Fantastic.
Okay.
Polysaccharide. So if this prosthetic was there for more than 3 months and the person developed infection, it's likely to be Staph aureus. But that's like step 2. So I don't think they will be testing that for step 1. Just know that once you see prosthetics, have Staph epidermidis in your mind first. Staph saprophyticus, gram-negative too. Of course, it is a staph. It is catalase positive, but it is coagulase negative because it's not aureus. But it is urease positive, just like epidermidis. And it occurs in cluster too, definitely. But it is resistant to novel biopsy. That's why it is different from my previous guy. It is resistant, to what's it called? Novel biopsy. So it is a normal microbe of the female genital tract and perineum. Saprophyticus is a normal microbe in the genital tract and perineum, unlike epidermidis, that is a normal microbe of skin. This one is normal in the genital tract and the perineum, and it is the second commonest cause of UTI in young males. So pay attention to this. Very, very important. They give you a history of a female that has, just had honeymoon, went out and uh, developed dysuria, frequency urgency, and all those UTI symptoms. And they give you a gram stain, and they ask what organism is this. They can give you gram stain of this guy, Staphylococcus saprophyticus. Some people will be looking for E. coli. They will see the gram stain that it is what's it called, gram negative cocci, gram positive cocci rather, gram positive cocci in clusters. They'll still go and pick E. coli because they feel that E. coli is the commonest cause of UTI. Fine. E. coli is the commonest cause of UTI, but the gram stain we are seeing in the question, is it showing us E. coli? No. So pick whatever you are seeing in the question, not using epidemiology knowledge to palm it. Very, very important stuff I have said. Don't forget it. So saprophyticus can cause UTI. Epididymis can cause infective endocarditis, particularly with use of prosthetic devices. Very important. So I think there's a question here. Let me see what I have here. Let me see if this question we can answer now. Okay. A 54-year-old man comes to the physician because of persistent knee pain and swelling for 2 weeks. 6 months ago, he had total hip replacement because of osteoarthritis. Temperature is elevated. Pulse is okay. Blood pressure is 139. Examination shows warm and erythemal nature of the right knee. Range of motion is limited by pain. Leukocyte count is elevated. ESR is elevated. Blood culture shows gram-positive, catalase-positive cocci. These bacteria grow on mannitol salt agar without color change. Production of which of the following is the most important for the organism virulence?
Polysaccharide.
Nice.
Mm-hmm.
So what is your
Polysaccharide is a
diagnosis?
biofilm.
What is the
It's
diagnosis
going to be
here?
staph
Epididymis.
Staph
Epididymis.
epididymis. That is very good. So we are picking staph epididymis because this person had a total hip replacement, although it can be staph aureus or can be staph epididymis. Now, if you look at it, they said 6 months ago. So that's not even in keeping with what I've said. Because I said it from step 2. Usually, when it's more than 3 months, it's likely to be staph aureus. That's why I'm saying that always read the question to the end and work with what you are being shown and not by epidemiology. If somebody had seen it like, okay, at 6 months now, that should be staph aureus. Just go and pick staph aureus without reading to the end. But they told us that this culture that they are growing shows a gram positive, okay? Catalase positive, it is a staph. And it is cocci, this is a staph. Because it is gram positive, it is catalase positive, and please, 1 minute, my people. So moving on to strep pneumo. Strep pneumo is gram positive alpha hemolytic, right? Which other category is under the alpha hemolytic? Anybody remembers? Which other organism is under the alpha hemolytic apart from strep pneumo?
Viridan.
The viridans.
Viridan.
That's how.
Very dance.
So the more we say it,
Very
the
dance.
better we become. The more we say it, the better we become. So the viridant, the strep, both of them, they are under the alpha hemolytic. Somebody said they are outside. Okay. The IT man will let people in. So so the alpha hemolytic are lancet shape. So they are like diplococcal organisms. And if you look at this image, you see, the coccus being paired. Now, many people get distracted. Once you see a gram stain, what you focus on are the tiny organisms you are seeing, not the background. Some people just see this background and say, this thing is looking like pink now or purple, and they'll start picking gram negative. Ignore the background. That is the counter stain we are seeing. But look for the tiny, tiny organism. Which stain are they picking? Which stain are they picking? So this is gram positive because this guy is picking the purple or the blue stain. So that's what we are interested in. We are not interested in the background. And what is the shape? They are like beard in clusters. So that's a diplococcus, and that's characteristic of strep pneumo. We also have a gram-negative diplococcus that's going to be Neisseria. But for gram-positive, it's going to be strep pneumo. And they have this lancet shape, like a needle shape. And we know that strep pneumo is part of the encapsulated organism. Remember the sheen, specs, it is part. It has the IgA protease. Why? Because it's under the family of which acronym did we give for IgA protease? Anybody remembers? What's the acronym for IgA protease, guys?
Shane?
The sheen. Just look at the organisms again. Strep pneumo, Haemophilus, Neisseria meningitis, all of them, they can cause the airway problems. So the sheen also applies for IgA protease. Then it is sensitive to optogene, and it is dissolved in bile. That's why the viridans are stronger than them. And it can cause MOPS. You cannot forget MOPS. It's not possible. Not possible. So it is a major cause of meningitis. It is a major cause of otitis media in children especially. It is a major cause of pneumonia. Of course, that's the name, strep pneumo. And the last is sinusitis. Don't pick sepsis. Though. Can cause sepsis, but this is sinusitis. Sinusitis, pneumonia, otitis media, meningitis. Now, what is peculiar to the pneumonia that occurs from this guy? The sputum is what? Is rusty. So by the time we start talking about chlamydia pneumophilia, mycoplasma pneumophilia, pneumonia, we'll notice that the pneumonia that those ones cause is atypical in that pneumonia is not going to be productive. Once you are reading a question and you see that the pneumonia is not productive, you already know that you cannot pick strep pneumo. You delete it immediately because it will be productive of sputum that is going to be rusty or brownish color. So, who are the category of people predisposed to strep pneumo? The encapsulated stuff. The people that have problem with the spleen, because there's no way they can opsonize and take away the encapsulated organism. So anybody with anatomic or functional hyposplenia or asplenia, they are predisposed to infection from strep pneumo. Don't forget that. No virulence without capsule. We have said this over and over again. That is the most important virulence factor. No virulence without the capsule. And on the basis of the capsule, we're able to develop some vaccine, the PCV13, the PCV15, and the PCV20, which are the what? The conjugated vaccine. So we take this capsule that contains polysaccharide, we now conjugate it with some protein so that we can elicit which response? Anybody? To elicit
A robust
T
T
cell.
cell
T cell.
response.
to elicit a robust T cell response. That's why we are conjugating with protein. But if we don't have the conjugated one, we have the PPSV23. Usually, when you are using PCV15, not 20, if you are using PCV15, you have to give the person PPSV23 within 1 year. That's where they do it. You know, within 1 year. If the person is normal, but if the person has some chronic stuff, you can give it within 8 weeks. You know, after 8 weeks, you can give this PPSV. But 20 is standalone. You can give 20 standalone because PCV20 means that you have vaccine that can take care of 20 serotypes of this guy. 15 means you can take care of 15 serotypes. 13 means 13 serotypes. That's it. The more, the better. So moving on to the viridans. Viridans. So we talk about the strep mitis, the strep mutant. They are under the viridans. And this guy, they are gram-positive too. They are alpha-hemolytic, just like we know, but they are resistant to optogene and they are not soluble in bile. But one thing about them is that they occupy the oropharynx. That's where they are living. So that's why they can easily cause dental caries by attaching to the dental plaques through the means of what? How do they attach to the dental plaques? Anybody remembers? How does the strep mitis mutant attach to the dental plaques?
They secrete dust.
Slime layer.
No, yeah,
Dust.
exactly. Slime layer. They form biofilms. Don't worry. Any question I'm going to be asking you is what you have talked about. If it's something related to another topic, I'll mention it. So if I'm prompting us with questions like that, it's just to recall what you have learned previously. So the slime layer, that's how they can attach to the dental plaques, forming dental caries. And there's one that is peculiar, and that's a strep sanguinis. This one can form destran, and that destran attached to the fibrin and the platelet aggregate on the damaged valve to cause infective endocarditis. So that's why this guy is super as a cause of infective endocarditis. Why? Because it has the ability to form destran. So sanguines can form sugars like destran that attach to fibrin and platelet aggregate so that it can stay there and cause problems. Don't forget this destran for sanguines. Don't forget. So they are normal flora of the oropharynx. Moving on to the strep pyogenes. That's our group A. That's our group A.
Babawale,
Yeah.
I get confused there a little bit. Did you say the dextran allows them to attach to
Yes.
the surface, or is it the biofilm, the slime layer?
No.
The virus I'm talking about.
No. So I mean that it allows it to attach to the vegetation on the damaged valves. So
that's the dextran.
Yes. You know that infective endocarditis is made up of the bacteria, the platelet, the fibrin, everything on the valves. Doc, are you following me? So now,
Yeah.
this sanguines has extra ability to generate dextran that further attached to the fibrin and the platelets so that it can stay close together on the valve and, continue the inflammatory damage to the valves.
Okay, the biofilm you mentioned, you were talking about other things that.
Yes, I was talking about mutants and mitis.
Okay.
Mutants and
Okay.
mitis causing their own
Okay.
dental caries. That's the
Okay.
biofilm.
Okay. Thank you.
So the strep pyogenes, the group A. So this one we said that they are what? They are beta hemolytic. And we said that the PIYR status is positive, but they are sensitive to bacitracin. Bacitracin can kill them. And an example of group A strep is what? Strep pyogenes. What is the shape? Gram-positive, cocci, but in chains. In chains. Gram-positive cocci in sorry, what's the word? Gram-positive diplococci. What's the organism? Two stuff like this.
Strep pneumo.
Strep pneumo.
Strep pneumo.
Strep pneumo. But gram-positive cocci in chains, then there's a possibility it's going to be strep pyogen. It can be any other one, but it won't be strep pneumo. So group A streptococcus is a possibility. Now, what does it cause? Just like Staph aureus, we classify it into the inflammatory and the toxigenic and the immunologic. So the pyogenic one are the inflammatory ones. Like this guy is a very common cause of pharyngitis. By the time we come back for step 2, we talk about the central criteria. And we are going to mention strep pyogen as a cause of pharyngitis there, acute bacterial pharyngitis. It can cause cellulitis, just like Staph aureus. It can cause impetigo, just like we have mentioned, the non-bullous type. It can cause erysipelas, just like we have rightly mentioned just few minutes ago. And the toxigenic one. So what are the toxins that this guy can release? We talked about erythrogenic exotoxin A that we said can cause what? Toxic shock-like syndrome. The erythrogenic exotoxin A is also the one that causes scarlet fever. So don't forget the way the erythrogenic toxin works. So it can cause scarlet fever. It can cause toxic shock syndrome. Strep pyogen can also cause necrotizing fasciitis. Anybody wants to remind us what toxin is going to be responsible for this necrotizing fasciitis? Anybody? From what you have done?
Is it not alpha toxin?
Staph aureus.
Okay, so from that answer, I know that there's an idea. So we remember when I was explaining the somebody mentioned aflatoxin. Aflatoxin is for paphyringes. Aflatoxin is for Clostridium paphyringes. But I said it there. I said we have the genes. The one that handle genes, they are the ones that have ability to lyse. So you have strep pyogenes and Clostridium paphyringes. So they will release their lysine toxin, and the lysine toxin for Clostridium papillomavirus is the alpha toxin. Why the one for strep pyogenes is the what? Streptolysine O. So your question in the exam will now be, they'll paint scenario of necrotizing fasciitis for you. And the question is, what toxin is responsible for this? So you have to flash your mind back to that algorithm. Okay, so this is likely to be from streptolysine O. It's as simple as that. If it's toxic shock syndrome, TTST. Okay, so if it's for Staph aureus, it's going to be TTST toxin. But since this one is toxic shock-like syndrome, which is from group A strep, it is going to be from the erythrogenic exotoxin A. And that is the same toxin that also causes scarlet fever. Do we understand what I'm saying, or the information is getting confusing? Anybody? Okay, I think we are following. So the next is the immunologic. Immunologic. So this one is not mediated by any toxin. It's just antibody antigen response. So the immunologic, first one, rheumatic fever. So anybody with strep pyogen infection that develop a pharyngitis, after like 2 weeks, they can develop rheumatic fever. You know, anybody that develops strep pyogen infection that causes impetigo, after some few weeks, they can develop what? Glomerulonephritis. Do we understand that? We remember that from
Yes.
immunology.
Yes.
So we know that the group A strep is what? Percitracin sensitive. It is beta hemolytic. It has the PIR positivity. Now, what I cannot forget to mention is that this guy is also part of the specs, the Shin specs. It is part. You remember that when we were talking about the Shin specs, I mentioned group A strep. I also mentioned group B strep. In fact, I mentioned salmonella. There's a lot of S there. So it has a capsule, and the capsule is made up of hyaluronic acid. So if we say carbohydrate capsule, yes, but which carbohydrate? Hyaluronic acid. In fact, this could be what they will put in the question. They are that wicked. They are that wicked. They might not put polysaccharide there. They will just put hyaluronic acid. And some people will just be like, answer no day there, answer no day there. So the answer is what? Hyaluronic acid. That is the virulence factor you are looking for. And it also has the M protein that we said that is the reason why there is mimicry. You know, why people getting infected with strep pyogen can also develop carditis, because they produce antibody against this M protein, and this M protein is very similar to the cardiac myosin, you know, and the antibody attacks it, causing carditis. It's as simple as that. And both of them work collaboratively to inhibit phagocytosis. So I've talked about the M protein, we have talked about the carditis. Now, how do we make the diagnosis? If it's step 2 now, it is a stepwise, you have to obtain a score. But here, we don't need to know anything about score. Forget about the score. Because it can be clinical and it can be laboratory, depending on the score. So, but here, we're just talking about the laboratory. You obtain a throat swab. They've asked this question before. I think it's in U-word. You see it in U-word. So you have to understand this concept to be able to palm that question. So you obtain a throat swab, which you can test by doing rapid antigen assay quickly in your office, or you can culture it on blood agar and get your result in 48 hours. So if you culture group A strep on blood agar, what are we looking out for? Anybody knows?
Beta hemolysis.
Oh my God. I have asked this question before.
Result of complete hemolysis.
Exactly. And
Completely.
people don't remember. I'm glad that we remember this. So that's the way to learn it. So once the culture on blood agar, you already know that what they are looking for is what? If there's going to be a complete
Complete.
hemolysis or not. That is it. So you can either do your rapid antigen test or you do culture on blood agar. So we have talked about this point. Now, there are some other virulence factor aside its hyaluronic acid and M protein. So it can produce some enzymes like the deoxyribonuclease enzyme. We have talked about this guy, very important, which is the reason why it's causing toxic shock-like syndrome and scarlet fever. So streptokinase is also important because with this guy, it can break down clots. because once there's an inflammatory response to an organism, clot might be formed, to confine that organism. So this guy is already prepared to lyse that clot so that I can travel far and wide. We also talked about the streptolysin O, which is a lytic toxin that helps it to cause what? Necrotizing fasciitis. We also say that there are some antibodies you can assay for rather, to know if there's a recent infection, and that includes the ASO, particularly for glomerulonephritis. True or false?
True.
False.
False. False.
Bronchitis.
False.
False.
It is only in rheumatic fever
Bronchitis.
Rheumatic
Aromatic fever. Mm.
and the anti-DNase B. So these are the two titers you can check for, to know if there's a recent infection. And the recent infection is most likely linked to rheumatic fever and not glomerulonephritis, particularly the ASO. So this is scarlet fever, which is associated with fever, just like the word. You are going to see strawberry tongue, sarcomora pallor, and some people like rash. So let us see if we can get an image that shows the scarlet fever quickly. So, yeah. So this is like the maculopapular rash. From the screen, we cannot know if it's sandpaper like. So they will tell us in the question that it feels gritty like sandpaper, and they will also tell us that the person is having this tongue, strawberry tongue. So what's the closest differential? Somebody having strawberry tongue and the rash, Kawasaki.
Kawasaki.
Kawasaki disease.
So now to
Kawasaki.
quickly now, to quickly know what to look out for to separate them without wasting too much time, just look at the question. Am I seeing conjunctivitis in this question or not? If you are seeing conjunctivitis, your diagnosis is Kawasaki until otherwise proven. And the fever in Kawasaki lasts for a minimum of 5 days. The fever is there. So, but in your scarlet fever, there is no conjunctivitis. And of course, in Kawasaki, you also expect edema, the legs, in the, hands. You will not have that in scarlet fever. You can have, what's it called, sore throat in Kawasaki. You can have strawberry tongue. We can have the rash. But what is going to separate them is a conjunctivitis. Very quick way, to delineate those things. So don't forget the erythrogenic egotoxin that I've talked about, which is the one that is implicated in causing the scarlet fever as well as the TTST. So moving to A. galati, group B. So A. galati is also one of the complete hemolysis guy. And this guy is very strong. It is resistant to bacitracin. It is beta hemolytic. It is for babies. You cannot forget that point. Oh my God. You cannot. There's no way you can forget it. For no way you can forget it. Oh my God. Some people are trying to join this car. I don't know what's going on. Sorry. Please won't continue. Okay. So, group B streptococcus, which is A. galati, is under the group B. A. galati. It is for babies. Don't forget that. Don't ever forget it. Remember the MOPS2, it works. But the difference is that the O is not there. There's nothing like otitis media here. And the S is not sinusitis. So it's actually sepsis. So the meningitis is still there. The pneumonia is still there. And the S is for sepsis. So a newborn baby having sepsis, it is A. galati. A newborn baby having meningitis, think of A. galati. A newborn baby having pneumonia, think of A. galati. This guy is a normal colonizer of the vagina. So vagina that is, the hygiene is not very good. Group B streptococcus A. galati can easily colonize. It should not be there, but it can colonize when there is a breeding ground, for it to enter. So, and it can cause MOPS, which we have talked about. Don't forget, just like I mentioned, Group B and the Group A, both of them have polysaccharide capsule. It's just that the capsule of Group A is what? Hyaluronic acid capsule. So they are both capsulated. And it's said to be producing this CAMP factor that allows the area of hemolysis to widen, particularly when it's grown with staph aureus. So it produces CAMP factor, which expand the area of hemolysis when it's cultured with staph aureus. And CAMP is just the name of the authors of the test. So what tests do I want us to pay attention to? Ipure test. So it's very unlikely for them to ask, but it's good just for our information. And I think I have a short note there. And the Ipure test is just like a test in which you culture A-galactine into the medium. And to know if it's A-galactine, you will see that there is going to be a color change. Glycine is going to appear purple because A-galactine has what you call epurate hydrolase enzyme or epuricase. That is something that can break down this epurate into benzoic acid and glycine. Glycine stains the indicator and it's going to make the medium appear purple. So you can say that the epurate test is purple ire. So you are calling purple exactly. Thank you for helping me. So the purple is there. So that's the epurate test. Then the PYR status is negative because they don't have a rank. The one that has a rank is what? The group A, the pyrogen. But this guy is although it doesn't have rank, but it does not respond to bacitracin. Step 2 is not acceptable. Step 2, to forget that you must screen. You screen pregnant women at 35 to 37 weeks of gestation with rectovaginal swabs for this guy. It is not acceptable. I don't know if we do it in Nigeria, but in the US, it is a standard practice. By 35 to 37 weeks, you must always screen pregnant women for group B because a very serious threat to the babies because of MOPS, meningitis, pneumonia, and sepsis. So if you find this guy to be positive, if you find it to be positive after you have done your recto-vaginal swab culture, then that mother must receive intrapartum, not postpartum, intrapartum penicillin or ampicillin prophylaxis. Intrapartum penicillin or ampicillin prophylaxis. As simple as that. So let me say, I think there's a question here. So most of the time, the questions I have, they are not related. They might not be talking about what we are discussing currently. It might be something we have discussed earlier. So I just want to be trying to see if we can recall all those things that we have learned. So a 9-year-old boy who recently emigrated from sub-Saharan Africa is brought to the physician because of 2-day history of fever, of chills, of cough that is productive. His mother reported that he had had several episodes of painful swelling of fingers during infancy that resolved with pain medication. The immunization status is unknown. Temperature is elevated. There is pale conjunctiva and yellow sclera. There are decreased breath sounds and respiratory crackles on the left lower lungs. Hemoglobin is 7. Blood culture shows optochin sensitive gram-positive diplococca. Optochin sensitive gram-positive diplococca. Spot diagnosis on the other hospital.
Strep.
Strep pneumo, thank you. Strep pneumo.
Strep pneumo.
Deficiency of which of the following most likely contributed to this patient infection?
A.
Clearance. Bacterial clearance.
People are too good. People are too good. So, that is that. Sorry, I don't have too much question, but you see, the major gist is just understanding the peculiarity of this thing. You can apply it and solve any question you want to solve. It is as simple. There's no way there's no way how they want to twist it. Once you understand all these things, we are good to go. Let me see. I think there's another one here. A 61-year-old woman comes to the physician because of 5-day history of fever, headache, cough, and thick nasal discharge. Headache, fever, cough, and thick nasal discharge. She had had a sore throat and nasal congestion the week before and had initially improved. Her temperature is 38.1. Physical exam shows purulent nasal discharge and tenderness to percussion over the frontal sinuses. The nasal turbinate are erythematous and swollen. Which of the following describe the microbiological properties of the most likely causal organism? Spot diagnosis. What is the diagnosis?
She has maxillary
Sinusitis.
sinusitis.
So this person has
Sinusitis.
sinusitis, maxillary or frontal,
Mhm.
because they said tenderness to the frontal too. So sinusitis. So what organism?
Strep pneumo.
Mm,
Positive.
Strep pneumo.
the
Optochin
Lancet.
sensitive.
Sensitive
Lancet
Lancet shaped
shaped
diplococci.
diplococci. B.
Yeah, B.
Sorry, Doc. Let me just attend to this person calling. So, sorry, I was distracted with that. Okay, so the sinusitis. So what organism is this? Is likely
Strep
Strep
pneumonia.
strep
pneumonia.
pneumonia. Yeah, nice one.
Pneumonia.
So what
Mhm.
answer are we picking?
Went for
B.
B, the gram
B.
positive
Very
The
very
gram
lab.
positive
very
lasted
simple.
Up
strep.
to
Very
10.3
simple.
lab
No catch at all. No catch. Let me see what is in the last. What organism is the last? This
Gram
Actinomycin.
actinomyces. Actinomyces.
Yeah.
Actinomyces. What organism is this?
That'll be
Staph.
Staph
That should be
aureus.
Staphylococcus aureus.
Staph aureus. I think
Cosmos.
we already know the
Yeah.
algorithm. We know the algorithm already. So that's Staph aureus. So moving on to strep galolyticus or strep bovis. You will see this in the exam. Everybody usually gets this one. So it's bonus question. You will see it. So strep galolyticus, formerly known as strep bovis, is also one of those guys. And we said that it's the one that falls under the gamma hemolysis, the enterococcal and the non-enterococcal, and is an example of a non-enterococcal. Both of them can grow in bile, but the difference is that put them in 6.5% sodium chloride, or try to what is the other stuff? 6.5% chloride or what? Anybody remembers? Eh? PYR status. So which one has a positive PYR status?
Enterococcus.
Enterococcal. So
Enterococcus.
which one will not grow in 6.5% sodium chloride?
The non-enterococcus.
That's the
Galoticus.
The galolyticus.
Analyticus.
then
Resistant.
Yes, exactly. So it can cause bacteremia and infective endocarditis. That's the most important thing to remember here. Infective endocarditis. I know Dr. Brandi will have said it, and it is very common in people with colon cancer. That's what they are testing you. So they'll just be like, some don't have this blah 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 blah. So what do you want to do? So this person has high incidence of colon cancer, right? So what do you want to do? You want to
You
rule
want to do a
out, you
colonoscopy?
want to do a
colonoscopy.
colonoscopy. Very important stuff. It's as simple as that. So, enterococcus, we have talked about it too. Two types, Enterococcus fecalis and Enterococcus faecium. They are normal colonic microbiota. They are normal organisms in the colon, right? They stay in the colon. And they are penicillin G resistant, just like I've said. And one thing that is peculiar to this thing that you must always watch out for in your question is that they will tell you that the person has undergone a GI or GU procedure, and the person now developing maybe a UTI or biliary tract infection like maybe cholecystitis or infective endocarditis. After the person had undergone something that involves the genitourinary tract, like cystoscopy, or the person had undergone something that involves the gastrointestinal tract, like colonoscopy. You first want to calm down. This is likely to be enterococcus they are talking about. So that's the way you look at it. Any procedure, GI, GU procedure, and the person is developing a UTI, biliary tract infection, or infective endocarditis, just go and pick enterococcus. So it is vancomycin resistant too. So they are very, very more resilient. That's why they tend to grow in 6.5% sodium chloride, and they can also grow in bile. So I think that's the most important thing with respect to enterococcus. Moving on to bacillus anthracis. The bacillus anthracis. So this is part of the living bacillus community or the living bacterial community. They are what? The gram-positive, bacillus that are aerobic. So of course it is spore forming too. It forms the spores, which we have talked, and it produces a toxin that I call the anthrax toxin. And if you remember when I was talking about the mechanism of how the exotoxin work, I talked about the anthrax toxin, and I said that it mimics what? Adenylate cyclase. So increasing the level of CMP and causing increased water secretion, leading to edema and necrosis. So, but I want to say it here that that toxin has two components. So it's made up of the leader factor, and the edema factor. So the one that it mimics adenylate cyclase and increase intracellular CMP, offsetting homeostasis and causing edema due to increased water secretion, is the edema factor. So that is why the borders of the lesion look edematous. But what is causing the necrosis, gongon? In addition to that, what's it called? The edema factor, causing swelling of the tissue with the necrosis. The major also thing that also helps the lesion to quickly develop is that they secrete this little factor component, and what it does is just to inhibit MAP. So it's an inhibitor of the macrophages, which is the MAP. So MAP kinase. So the little factor inhibits the MAP kinase that will not allow the macrophage to come in, because it's going to trigger apoptosis of the macrophage. So the way to look at it is that little factor inhibits MAP kinase. When you say kinase, more like something that allows something to flow, to come, to come and go, flow. So if you inhibit MAP kinase, that is macrophage kinase, it doesn't allow the macrophage to come in, and they are dead at the end of the day. So the mobilization of the macrophage is impaired, and they are dead by apoptosis. So once you take out MAP kinase with the little factor, there is nothing to threaten the growth of that bacillus again, and the inflammation damage can proceed. It's just like our other organism. There's another organism that I said that it has a way of also evading phagocytic clearance. Anybody remembers the organism?
Pertussis.
Pertussis. So pertussis will also release a pertussis toxin that's going to
Mhm.
inhibit the inhibitory G subunit. Hope we remember. Inhibit the inhibitory subunit so that we can have overactivation of the stimulatory subunit, which can now activate adenylate cyclase, increase CMP. CMP overwhelm the macrophages, and they will die at the end of the day. So, what is peculiar to Bacillus anthracis? It is the only organism that has a polypeptide capsule. All the capsules we have been talking about, they are polysaccharide, but this one is a protein capsule, a polypeptide capsule, which is made up of sequence of poly D glutamate. Don't forget this. You cannot forget this. You cannot. Poly D glutamate is a component of the capsule of the bacillus. And the colonies grow like halo of projection. So just see the colonies like growing in like halos of projection. So Medusa head of the bacillus. So in case it shows in our exam, you know what to look out for. So like something like, so this is more like the enlarged form, something like this. It's very unlikely that they will show us though. So most of the time it will be described. You see that projections, halo projections like that. So that's Medusa head appearance. What are we have like 3 forms, but we're emphasizing 2 forms here. The cutaneous anthrax. It causes painless purple, which we see like a purple that develops, and later it's surrounded by vesicles, and everything will ulcerate at the end of the day, forming a black necrotic center that we call the eschar. So if they say that we have like a papular lesion that is painless and later became ulcerated with swollen borders and a central necrotic center, that is anthrax they are talking about. That is the eschar of anthrax they are talking about. So most of the time, it disseminates into the blood, leading to sepsis and death. So that's the cutaneous form. So don't forget what is responsible for this edematous border. This is the edema factor. Pulmonary anthrax means that this spore-forming guy, this bacteria forms a spore, and somebody inhales the spore. Or some people find, a way to lay their hands on the spore, and they can be released during war, as a bioweapon. So they use it to kill people during war, maybe in the olden days. So anthrax is very common. It commonly colonizes all these animals, like the animals and the the hair, the height from the animal. So the human beings can refine those heights and collect those spores, and from there, use them as a weapon of mass destruction. So how does it cause mass destruction? So once they release the spore into the atmosphere, it is inhaled immediately. And one thing about this toxin is that it has a lethal effect on the endometrial cells, endothelial cells. Endothelial cells. So just like the enterohemorrhagic form of E. coli that I did not mention, most of the protein damage is on the endothelial cells. So that's how it can cause the hemorrhage, the thrombosis rather. I'm still going to talk about it shortly. So the pulmonary anthrax release the spores are inhaled, the organism germinates into vegetative form, and it will start releasing the anthrax toxin. And when it releases the anthrax toxin, they are going to start causing necrosis and injury to the endothelial cells lining, the vessels as well as the airways. So because of the damage to the endothelial cells, there's pulmonary hemorrhage. This bleeding can be so severe that it's extending to the mediastinum, and there's going to be hemorrhagic mediastinitis. In fact, by the time you do X-ray, you're going to see that the hemorrhage is so massive that there's a widened mediastinum. And the person can be so bad that the person can easily progress to hemorrhagic shock. So that's what you call the wool-Sutter disease, because these spores are attached to the wool or the height of animals. So people that sort wool, they're highly predisposed to getting pulmonary anthrax. So what do? Anyone that is high risk for developing it, just give them DC, the doxycycline or Cipro, to take care of them when they are exposed. So these two forms can also disseminate into the blood and travel to the brain, and it will affect the vessels of the brain, and the person can have hemorrhagic meningitis. So everything about anthrax is always hemorrhagic mediastinitis, hemorrhagic meningitis.
Dr. Gopal, I have a question on that anthrax.
Okay.
You said that it has a excuse me, a polysaccharide capsule, and the others have what?
Yeah, doctor, sorry. I'm so sorry.
It has a polysaccharide capsule, and the others have what?
It has a polypeptide capsule. So the others have polysaccharide. Polysaccharide is a carbohydrate. Polypeptide is like sequence of proteins, sequence of amino acids. So polypeptide join together to form is it protein now? Yeah. So
protein, polypeptide.
that's what
when you say yes, I want to understand: is it other encapsulated organisms or all other organisms?
yes, other encapsulated organisms. Other encapsulated organisms. Yeah, you're welcome.
Okay.
So Bacillus cereus. Let me see. I think there's a question here. Okay, I think we can answer this. We can. A 5-year-old boy is brought to the emergency department because of one-day history of poor feeding, irritability, and noisy breathing. The mother did not receive any prenatal care. Respiration is 26. Physical examination shows Sonkiel frontalis, tightly clenched fist, and erythema around the umbilical cord stump. Which of the following best describe the pathogenesis of this disease process in this patient? A. Decreased release of acetylcholine. B. Inhibition of sodium channels. C. Destruction of the Schwann cells. D. Decreased release of glycine. E. Destruction of the anterior horn cells. So
maybe A. Tetanus, I think.
So the first thing is always follow that sequence. The first thing is to have a diagnosis. So what is the diagnosis? What is happening?
I'm wondering if it's maybe they're being infected on because
Neonatal
tetanus.
This is neonatal tetanus. This is neonatal tetanus. Yes. So because you can see the hypercontraction, tightly clenched fist, right? And there's the what's it called? The source, which is the umbilical stump. You know. So what is the answer going to be?
Decreased release of
That should be
inhibition of glycine and GABA.
Exactly. Decreased release of glycine and GABA. What condition will have made us pick A?
Botulinum
Botulinum
That's
toxin.
toxin.
Yeah.
Toxin.
It's as simple. It's as simple as that. The
Sorry,
other one,
Baba Wale. So how do we know this is like tetanus then?
yeah. So actually, the question is not very, very detailed. They didn't put all the classic tetanus, but because this person is a 5-day-old boy, so this boy might not be having opsotonus because the external muscles of the back might not be very developed. So, but the baby is having noisy breathing. So it means that there's like a form of spastic paralysis of the chest, and at the same time, the baby is having tightly clenched fists. So that's another, spastic tone too. Do you understand, Doc? So it means that there's something that is causing like a form of spastic contraction in that baby. And they now gave us that there's erythema around the umbilical stump. So usually that people with poor umbilical cord care, can easily have tetanus because that's a good portal of entry for that organism. So that's why this is tetanus. Usually if it's adult now, they will be talking about the lockjaw, the opsotonus, the resource adonicus, but in neonatal patient, it might not be that classic. But do you understand it now?
Yes, I do.
So
Yeah.
so that is neonatal tetanus. So Bacillus cereus, the living bacterial community, it is a gram-positive rod that is aerobic and it causes food poisoning that all of us know. And that is because the spore survive cooking rice, which is a related rice syndrome. So this is bonus if we see it in our exam. But we have to be careful at the same time. So because keeping rice warm results in germination of the spores, growth into the vegetative organism, then the enterotoxin formation. But you have two forms, the emetic form and the diarrhea type. So there's a type that classically what they present with is diarrhea. There's a type that what they present with is only vomiting. So the vomiting type is usually caused by a cerulide toxin, which is a preformed toxin. So that one does not undergo this phase of germination of spores and the toxin production. No, that will have happened in the food already, not when the person has swallowed the food. So that will have happened in the food. The toxin is already in the food. The person just takes the rice and this cellular toxin is released and it will cause the emesis. But for the diarrhea type, they have to eat that rice that have been reheated. So when they eat the rice, they eat the spore. The spore will now germinate into the organism, which is the Bacillus cereus. Then the Bacillus cereus will now produce the enterotoxin that will now lead to enteral problem, which is diarrhea. And don't forget, it's going to be non-bloody, non-bloody. So the emetic type, the vomiting and nausea occurs within 1 to 5 hours, very fast. So just similar to which other organism?
Staph aureus.
Staph aureus.
Staph aureus.
Staph aureus causing, releasing the heat stable enterotoxin, and it can cause vomiting and diarrhea within 2 to 6 hours. So we're already palming all those things like that. So we know that in the question, if you are saying that the vomiting and the diarrhea is within a short time, we're either thinking of serious, Bacillus cereus or what? Or Staph aureus. What is going to differentiate them is that what food is the person eating? Is there anything like rice? Once you see rice, let's speak of Bacillus cereus. What is another thing like mayonnaise, and other things like that, likely to be staph. So moving on to Clostridium difficile. Clostridium difficile is also one of those organisms, and it is an anaerobe, but it's gram-positive, and it releases two toxins, the enterotoxin type A and the cytotoxin type B. Enterotoxin type A and the cytotoxin type B. So the enterotoxin destroys the epithelial cells of the GIT tract and they cause the diarrhea, while the cytotoxin destroy the actin filament in the cells, cytoactin filament. And when they destroy the actin filament, there is loss of protein, the cells become weak, they die off, there's inflammation in the process. The inflammatory response is what leads to this formation of these pseudomembranes that we are seeing. So just similar to pseudomembranes you'll find in the throat in people with what? Diphtheria.
Bacteria.
So you also see pseudomembranes in the colon of an individual with pseudomembranous colitis from Clostridium difficile. So once you see this image in your exam in the colon, you know that this is Clostridium difficile. So you want to ask yourself, what is the secondary cause of this? Usually there's no secondary cause, but you can have a secondary cause, like antibiotic use. Has the person used any antibiotics that have killed off normal flora that is keeping this Clostridium difficile in check? Antibiotics like what? Ampicillin, cephalosporin, fluoroquinolones, PPI, clindamycin. I don't know if Dr. Babande gave us any acronym when we were doing this in GI. Did he?
Mm-mm.
No. So it's something we can relate with. So ampicillin and cephalosporin, they are together. Fluoroquinolones, broad spectrum, clindamycin for the anaerobes, and PPI. So if you use PPI, you suppress the acid. The acid there are very toxic to this Clostridium. So, but once there's no more acid, that means that they can have a free way to be proliferating. So that's why PPI is bad. It can provoke Clostridium difficile infection. So people that use PPIs, people that take antibiotics, broad spectrum, proquinolones, ampicillin, cephalosporin, clindamycin, high risk. So when infection becomes fulminant, so it becomes very severe, vomiting, abdominal distension, diarrhea, fever, hypotension, and they can progress to develop toxic colon. So you just notice that there's paralysis of this colon. It starts getting distended with fluids that cannot move again. So that normal onward movement of fluid and fecal matter is stopped. The colon will just start enlarging like that. So that's toxic megacolon. You need surgery, ASAP, decompress, nutritional and fluid hemostasis or maintenance, then you do your surgery. Paralytic hilus too, of course, from the abdominal distension, there's going to be cessation of contraction. So there's going to be hilus. And that can progress to shock. Anybody knows what type of shock that would be? What kind of shock would that be? The hypovolemic, is it hemorrhagic? So that's because it's more like we are sequestrating, what's it called? Body fluids in the colon. So fluid that should be in the blood, is now sequestrated in the colon. So that's going to be a form of like distributive shock in a way. So that's that about the shock they under. And of course, if they are vomiting too much too, diarrhea, so that can lead to hypovolemic shock. So in any way, it's still going to cause shock. So how do you make diagnosis? You can do a PCR or antigen detection of the toxin is true. It's not likely we are going to be asked this. Step 1 is not majorly actually with diagnosis. That's step 2 stuff. But it's good to know it. Do a PCR analysis or your antigen detection for the toxins. Treatment, you cannot forget oral vancomycin, or especially when it becomes like fulminant, you can use your fidaxomycin and oral vancomycin to treat what's it called? The pseudomembranous colitis of this guy. So oral vancomycin and fidaxomycin. So when it's recurrent, they can wait for you here. They'll tell you that the infection has been ongoing for so many times. Comes, goes, they treat, comes again. So you have to repeat this management, or if you don't see repeat prior treatment, just pick fecal microbiota transplant. So most of the time it will be logical to pick microbiota transplant. If they have repeated trials like maybe 2 times and it's not still working, just go and do your microbiology transplant. Just go and transplant the normal flora. Because we have said it that if you are using these broad spectrum antibiotics, it kills us the normal flora and you have uncontrolled proliferation of this guy. So what you want to do is that you want to restore that balance. So transplant this microbiota and keep the Clostridium activity in check. So that's that about recurrent cases. Then moving on to the Clostridium. So we are not going to talk about this again because you already know everything here. I've talked about it. And what I'm just going to mention is that we prevent the tetanus infection by giving tetanus vaccine. Just give your tetanus vaccine, you prevent the infection. And if somebody is infected, you want to neutralize that toxin. Although you cannot neutralize toxin that is already bound. So what I'm saying is toxin that has already gained entry into this rancher cell, there's nothing you can do about it. But the toxin that are still in the blood, you can neutralize them. So that's why you give them antitoxin. You give them antitoxin to neutralize the toxin in the blood, and not the ones that have traveled to the what's it called, to the rancher cell. You cannot reach that one again. It's gone. So, and you can also give the vaccine booster. So this is step 2 stuff. Depending on the age, depending on the last time the person took the booster, and at the same time the dirtiness of the wound. So if it's a clean wound and the person took booster last maybe 11 years ago, so you have to give another booster, because you have to give a booster if it's a clean wound and the person um took the last one more than 10 years. More than 10 years. So if a patient comes to us now and the person took the booster 8 years ago, are we going to give the booster or not? And it's a clean wound.
No, you won't give it.
We won't give it. We won't give it because it's 8 years. So, but once it's more than 10 years, you have to give it. But if it's a dirty wound, you don't work with 10 years, you work with 5 years. If the person took the booster last more than 5 years and above, you have to repeat that booster. If it's a dirty wound. So that's that about the booster. And you have to give antibiotics. The reason why we are giving antibiotics is that this organism has entered that wound. There's a wound somewhere, the organism has entered it. Although it's a localized organism, it is not invasive. It doesn't penetrate into other teeth. It just stays there and releases the toxin. And the toxin will now be the one to be doing the traveling. So the toxin is the one that will be traveling from the muscle through the motor neuron to the rancher cells of the spinal cord. It is the toxin, not the organism. But we need to eliminate the focus of the toxin, which is the organism itself, by giving antibiotics. So antibiotics that is majorly preferred is metronidazole, but you can use penicillin. Metronidazole is very good. Then, because of the fact that they'll be having muscle spasm, there's inhibition of release of glycine. It means that these alpha neurons will not be inhibited again, and they will be hypercontracting these muscles, so they spasm. So you have to calm the spasm down by giving diazepam. And of course, you have to debride that wound. That's the number one thing. Debride the wound. Remove that organism that is there. Remove the necrotic tissue. Give antibiotics. Administer your antitoxin and booster if it's necessary. So for botulinum, I've also talked about it. But I said that in babies, the source is usually what? Consumption of what? Anybody remembers? Consumption of
Honey.
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 So
Raw honey.
they take raw honey or soil. While in adults, they have taken some form of canned food. And that of adult is containing a preformed toxin.
Canned food.
Preformed toxin, don't forget that. The toxin is already formed on that canned food. Why? And that's why it's shorter, because they are well grown, the adults. But babies, it has to grow. So they have to take the spore, form the organism release the toxin. So, and it can cause a floppy baby syndrome. So this is just opposite of tetanus completely. So the baby would have a poor neck control. The baby is going to be hypotonic. The baby is just having a weak cry. They cannot cry. They are weak to even cry. And they want to cry because they are suffering, but they are too weak. The neck is, just on one side like that. Poor control. They are floppy. You bring up the hand, it will drop like that. They have poor suck because of the fact that the muscles cannot contract. Floppy baby syndrome. Just go and pick botulism straight, the infantile type. But for the adult, you have the 5Ds. The 5Ds. So starting from the head to the legs. So they have a diplopia because of paralysis of the muscle of the face. The mouth, paralysis of muscle of the mouth, dysatria. Muscle of the esophagus, dysphagia. The chest, dyspnea. The legs, descending flaccid paralysis. Don't forget, the paralysis is what? Flaccid. As opposed to tetanus, that the paralysis is what? Spastic. So they are not going to have any sensory deficit. If you see somebody having this feature and having sensory deficit, what will be likely diagnosis? Anybody, you see somebody having this diplopia, dysarthria, and now having sensory deficits, reflex issue. No, don't let me say sensory deficit. I'm saying that thing again. Let me remove the sensory deficit, but the person now having reflex issue. Anybody?
Thinking GPS. GPS.
Ah,
Rabies.
it's not
Guillain-Barré.
going to be. It's not going to be GBS because GBS is not going to cause
Rabies.
descending paralysis. So
Okay. Okay.
it's
It's
not
Rabies.
descending.
ascending.
GBS is
Okay.
ascending.
Eh?
Can it be rabies?
No,
Polio.
it's not
Polio.
rabies. No, not polio. No, polio is not what. Like so. Okay, now
Myasthenia gravis.
Rabies.
wait, sorry. Let me add another information to kill it. So these might be there, and the person is going to be having problem with the reflex as well as the autonomic nervous system. So the person starts developing.
Myasthenia.
No,
Mm-mm.
no.
Give us more information.
So when the person is having, urinary incontinence, the person is having sexual dysfunction, and the person is having stuff that look like myasthenia. What is that?
Lambert.
That's lumbar.
That's Lambert.
That is
That's
lumbar.
Lambert.
Lambert, yeah.
You are not going to have the DTR, incontinence in myasthenia. So that is lumbar. Please have that by your mind. Don't forget. So sensory deficit is not there because if you don't know, you can easily look at that pathway yourself. And we just see that the Renshaw cells actually supplies a motor neuron. So definitely, motor neuron should not be controlling sensory, stuff. This is not spinal thalamic tract or spinal something. So it's not going to cause any sensory issue. It's just going to be purely motor. So don't forget that. So how do you treat? You just give the human botulinum immunoglobulin that is going to neutralize some of those toxins. And sometimes this toxin A, this botulinum toxin that is even causing this problem can be useful in humans. So people that do plastic surgery, they use this Botox, which is a botulinum toxin itself. They can use it to do some human treatment. For example, somebody that's having focal dystonia. So in focal dystonia, let's say that we are just having dystonic contractions of a particular part of the body. Does it make sense for us to give something that can paralyze the muscle?
Yes.
Yes. So give Botox. Botox will come here and it will prevent release of acetylcholine at the neuromuscular junction so that there's no acetylcholine to contract the muscles again and the muscle will relax. Good. You can use it to treat hyperhidrosis. I don't know if Dr. Babinde mentioned it, but majority of the sweat glands in the body, they are supplied by sympathetic cholinergic nerve. True or false? True or false?
True.
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 So this is a
True.
sympathetic
True.
nerve.
True.
This is a sympathetic nerve, but what you have here is acetylcholine. So that is why
Yeah.
somebody that has what was it called now? If somebody is on anticholinergic, the person is going to have dry skin because the person will not sweat. That's it. So the reason why they are not sweating is that acetylcholine that is a neurotransmitter in the sympathetic nerve. That's a little bit weird, but that's the way it is. And there's no acetylcholine to travel to stimulate the sweat glands to secrete again. So that is why if somebody is having hypersecretion, why don't we give something that can prevent acetylcholine to be released so that it will not sweat again? Hyperhidrosis. So just give your Botox toxin. It will inhibit release of acetylcholine from the nerve terminals to the sweat gland, and there's reduced sweating. Muscle spasms, just like dystonia, the same principle. Cosmetic reduction of facial wrinkle. So if we're having a wrinkle, it means that there's contraction in this direction. That's why there's wrinkling of the skin. So why don't you relax the muscles that are wrinkling? Relax the skin. Relax everything there by giving botulinum, which will paralyze the muscle. As simple as that. So moving on to Clostridium paphyringes. So what toxin of Clostridium paphyringes do we say is responsible for gas gangrene?
Alpha
Alpha
toxin.
toxin.
Alpha
Alpha
toxin.
toxin.
Alpha toxin, which is a lecithinase or a phospholipase. Lies the muscle, destroy the fascia, and there's going to be myonecrosis. Now, what are we looking for in our exam? We are looking for, number one, presence of discolored skin like this. They are going to tell us that there's numerous purple or black bullous lesions. That's number 1 point. Bullous lesion, that is going to be purplish bullous lesions, number one. Number two is that they will tell us that this infection is causing crepitus. We are going to be hearing like crepitus, which is like we are stepping on dry leaves.
Mm.
This is due to the gas gangrene. Now, what is peculiar to Clostridium perfringens? Clostridium is a what? Is an anaerobe. And we said anaerobes form which gas? CO2 and H2, hydrogen, CO2. And the gas can easily track along the facial planes, causing the crepitus. So if you see any organism causing crepitus, you know that it's likely to be an anaerobe until otherwise proven. So that's why, in addition to all this necrotic tissue, you're also going to be hearing, the crepitus, and they can also tell us that it's foul smelling, because we said it that anaerobes have the ability to release short chain fatty acid than that are what's it called um um uh that 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 exact that smelling effect. Do we understand that? Sorry, I'm a little bit
Yes.
okay. Yeah, so sorry about that.
Mhm.
So now these papharinges at the same time also release the aflatoxin that hemolyzes the blood, causing hemolysis. So don't forget about the gas gangrene presentation, the necrotic, lesions, the necrotic bullous lesion, the crepitus. They are going to say there's a crepitus. They also tell us that the pain is out of proportion to what we are seeing. We just touch that area mildly. The person is screaming, yeah, yeah. So that's also in keeping with gas gangrene. So it's just due to the spore germinating, forming the vegetative bacteria, releasing the enterotoxin. And okay, so this one is another stuff entirely. This is the gastrointestinal complication of Clostridium perfringens. So it can release this aflatoxin, and it can also release this enterotoxin. So you can see it in the question too, please. I almost forgot that. Don't forget, it is not only the aflatoxin that this Clostridium perfringens releases. It can cause gas gangrene, and at the same time, it can also cause diarrhea. Don't forget. But the diarrhea of Clostridium perfringens is usually late onset, within like 10 to 12 hours after eating, and it will resolve in 12 hours. So it's self-limiting. Within 24 hours, it's gone. It's gone. So, but it's late onset, and it's due to the enterotoxin. Now, there's another important point here. I forgot to mention that most of the time, before they develop all this gas gangrene or something, there's usually a focus that allows entry of this organism. Either maybe the person had a trauma to that part, or the person underwent a surgery or something, then subsequently develops that gas gangrene. But sometimes some individual can develop what we call spontaneous gas gangrene without any focus, without any injury, without any prior surgery, without anything. So that organism is likely to be Clostridium septicum. So in that situation, you are not going to be picking Clostridium perfringens in your exam. You're just going to pick Clostridium septicum. So they will tell you the question that the person has been, living normally, no symptom, no problem, but suddenly develops this complication, just a bullous lesion with blackish, discoloration of the skin and crepitus sound on examination. They are talking about spontaneous gas gangrene from hematogenous dissemination. So you must rule out an underlying colonic malignancy. So it's also associated with colon cancer, just like strep bovis, associated with colon cancer. This one too is associated with colon cancer, and the organism is what? Clostridium septicum. Very, very important. Please don't forget at all.
Dr. Babawale, I got so confused. Kind of, they, mix them all up for me. I don't know. Now, is it only forming the malignancy, or does it also form this necrotic bullous lesion? And
So the only difference, the presentation is the same thing. The only difference is that in one, there is no history of trauma, no history of surgery, no history of injury to any part of the body.
Okay, which is that one?
So which is a spontaneous gas gangrene.
No, which one is it's the absence of trauma, or
Yeah, so
is
that's
it?
what I'm saying. Spontaneous
Mhm.
gas
Okay.
gangrene from Clostridium septicum.
Okay.
So
Okay.
do we understand it now?
Okay.
And
So spontaneous gas gangrene, is it the one? So it's not the one that formed the
no. Both of them will form this necrotizing picture. Everything will be like this. But in one, there's going to be like a predisposition, which is what? There's a trauma, or there's a surgical treatment, or there's injection somewhere, or there is anything, road traffic accident, anything. There's an injury to that part. Then the infection comes in, and later the person develops the bullous lesion. In the other one, there's nothing that is wrong with that leg initially. It just develops spontaneously because the organism is already in the body. Why? Because the person has an underlying colonic malignancy. Are you with me?
So the pharynges, are you saying that it's because of underlying malignancy and the septicum trauma?
No. The septicum is a malignancy. See, can you see the screen?
I
See,
can see this. Mhm,
the spontaneous gas gangrene is associated with colonic
mhm.
malignancy caused by Clostridium septicum. Septicum is
Okay.
a spontaneous one, and
Okay.
that is the one that is associated with colonic malignancy.
Okay.
Now, we don't have to break the skin to get that organism into the body.
Okay.
So that's why it is spontaneous. It is already in the
Okay.
bloodstream
Mhm,
because it can be released from the colon cancer.
mhm.
But in the other form, um, there is
Which is the pharynges.
which is the preferences. There is already
Okay.
more like a perforations into the skin, either from trauma
Oh.
or
Mhm.
surgical treatment, anything that compromises the body. So that is a portal for the organism to not gain entry. So if it enters in that situation, if the gas gangrene develops, we cannot call it spontaneous again because there's already a predisposition from outside.
Mhm.
But for the spontaneous, there's no break in the skin. So it's just due
Mhm.
to the organism being released from this colon malignancy. So it's believed that people with colon malignancy, they have a very high rate of release of this Clostridium septicum. And from there, it gets into the blood. And from there, it can, cause gangrene in any part of the body.
Okay.
Do you understand it?
Okay.
Is it clear?
I understand.
Okay.
One more question. Is pharynges, is it a normal habitat of the colon or of the body, just like the difficile?
No, it's not normal habitat of the body. It has to gain entry
Okay. It
because
has to
of
gain it
breaking
from
the
this
skin and stuff.
break or
Yes.
spontaneously. Okay. Okay. Thank you.
So, moving on to Corynebacterium diphtheriae. I think there's a question here. Let's see what is here. A 27-year-old man comes to the emergency department because of nausea and repeated vomiting for the past 30 minutes. 2 hours ago, he was at summer barbecue gathering where he ate spicy, freshly grilled chicken that was fully cooked. Through week. That was fully cooked. Is it thoroughly you want to say now? That was cooked thorough with some reheated leftover lime basil rice. He has not had diarrhea. This kind of examination shows a mild tender abdomen with no rigidity or rebound tenderness. The next morning, the symptoms have resolved. Which of following is the most likely cause of this patient's symptoms?
Injection of preformed cellulitis.
Good job. Good
Mhm.
job. They even told us
Serious.
that. They even told us that.
Doctors.
Yeah.
Reheated rice.
Reheated rice, number
Yeah.
one. The
Mhm.
second point is that he has not had
No diarrhea.
diarrhea.
Yeah.
Diarrhea.
Yeah. So that's it.
The
So
result.
exactly.
Emetic type.
Emetic
Mhm.
bad. So this guy is self-resolving. do not treat with antibiotics in any of the question. It's going to be wrong. So just do supportive treatment. Give the person enough fluids, correct nutritional electrolyte imbalance if there is any. That is it. You don't give antibiotics. So we have talked about corynebacterium diphtheria, sometime back, and it's more like a gram-positive rod that part of the what's the acronym again? Living Bacillus community. So that's the community part is the corynebacterium diphtheria. It is an aerobic gram-positive rod. So they have angular arrangement, the way they arrange themselves, angular. So that's not very important. It is transmitted by respiratory droplets. Very important. Very, very important. Transmitted by respiratory droplets. It has the diphtheria exotoxin, which works by what? Inhibiting protein synthesis. Alongside with what? What organism works similarly?
Pseudomonas.
Pseudomonas. You can see. Once you hold it like that, it stays with you. You can't forget it. Pseudomonas. Both of them, they inhibit protein synthesis by causing ADP ribosylation of EF2. You sit like that in your exam. You just speak. People will be trying to remember, that table, God. But you have picked, you have gone. You have even saved time for the questions that will be challenging, in the front. So that's how microbiology is. Microbiology is you know it or you don't know it. Either you know it or you don't know it. And once you know it, you are happy. You pick your answer, you are moving. There's no time to be wasting time. So because you still be having all this cardio, all these what's it called, ethics, that still be thinking what's going on here. But microbiology just give you the case scenario, you pick your answer, you are even confident of what you are picking. So that's microbiology for you. Though it can be volatile, but we have to just find a way to arrange the stuff in our head. So
Dr. Baba, sorry to take you back. The last question we did, what was the answer?
the answer, that should be cerulite toxin. That's Bacillus cereus. So this person they cooked it.
Last one, huh? Okay.
Yes.
Yes.
Cooked thoroughly with some reheated leftover rice.
Rice. Okay. Thanks.
So Staphylococcus. Sorry, Bacillus cereus. So after that ADP ribosylation of the elongation factor 2, protein synthesis become cut off. The cells start dying. Pharyngitis, myocarditis, and the CNS, the canal peripheral neuropathy. So what do we see on gross examination? Pseudomembranes, pharyngitis, grayish white membrane in the throat. Pseudomembranes, pharyngitis. Don't forget that. With the lymphadenopathy, which will give them the bull neck appearance. See the neck, it will be swollen because of the lymphadenopathy, and because of the toxin, they can have the myocarditis that can lead to heart failure and arrhythmias. They can have the neuropathy in the nerves, just like we have mentioned. So those three structures are affected in corynebacterium diphtheria. So where they can wait for us is that they'll describe the situation. They open the mouth, the person's having fever, sore throat. They open the mouth, they saw the pseudomembrane, and what else again? They can just say that, okay, maybe the person they can just so the person is having like an enlargement in the left side of the neck, which is consistent with the lymphadenopathy. And the next thing is, what other complication do you expect in this patient? So they can just scribble arrhythmia there. So people will be so sure that it cannot be arrhythmia because they will have forgotten that this thing can cause myocarditis. They'll be so sure and they will not consider arrhythmia. So we have to open our mind, categorize it: the pharynx, the heart, and the nerves. So the nerves, neuropathy; the heart, myocarditis. They might not even put myocarditis, they can put heart failure there. It can cause heart failure because of the myocarditis. Can have arrhythmia, can have, neuropathy. So those are potential way by which the USMLE, come for us. So how do you make the diagnosis? Yeah.
Please, how do we differentiate this with the difficile?
Okay, good question. Don't forget, Clostridium difficile, you are going to be seeing the pseudomembranes where?
In the colon.
In the colon. you are never going to see the pseudomembranes of diphtheria in the colon. The pseudomembranes will be in the throat. So don't forget that. So laboratory diagnosis is, gram-positive rods with metachromatic blue-red granules in the low flare medium. So if you remember when we were talking, I know we're just, I don't know, that those medium were a little bit confusing, I know, but we'll keep talking about some of them, so they would be coming back. So for Corynebacterium diphtheria, what you use is the low flare medium, and you are just going to be seeing metachromatic granules. So metachromatic means like different colors. So red, blue, metachromatic granules for low flare for chroma for this. So sorry, please, just 1 minute. One minute, please. Um, okay, let's just continue. Okay, so let me just show us. Okay, so something like metachromatic granules. So something like this. This blue, although this like blue, I don't know if we have good like in low flare medium. Anyway, it's not likely they are going to show us the media stuff. It is not likely. It is not. So I don't have a very good one here. Just something like this, like blue, can be red. From the symptoms, you already know what they are talking about. So just know that we can grow that in the low flare medium, and they'll be club shape. Just like we are seeing, round like club. And on the 16 tellurite agar, there's going to be black colony. So with time, we'll be very conversant with all these agar. Tellurite agar, black colony, low flare medium, metachromatic granules. There's the LF test to diagnose the presence of the toxin. I thought I put a short note. Okay, it's nothing to worry about. It's just a test to just assess if the toxin is present or not. So we have to give a toxoid, a toxoid against this diphtheria. We talked about this diphtheria. I said it's part of those what's it called, toxin that is encoded within the what the bacteriophage, right, which can be transmitted through which form of gene transport, horizontal gene transfer. Anybody remembers? The
Is it the
diphtheria,
specialized
the
transfer?
specialized what?
Yeah.
The
Yeah, the
specialized what?
specialized.
The specialized transduction.
Con-
Very important.
Confession.
So
Oxygenic.
yes, so you have to give a toxoid vaccine because it produces a toxin just like tetanus. So you give a toxoid, which more like is more like the denatured toxin to provoke immune response. And if somebody gets infected, you have to neutralize the toxin by giving antitoxin and plus or minus antibiotics like erythromycin or penicillin, depending on the severity. So most of the time you don't use any antibiotic, but it's very severe. You might need to give erythromycin or penicillin. The next is Listeria. Listeria is one of the living bacterial community. So it's gram-positive facultative intracellular rod, which can be acquired by injection of so many things. But the commonest one is taking dairy products and cold deli meat. You cannot forget this. People that take cold meat, I think people from India also, I'm not really sure, but people that just take all these cold deli meats, unpasteurized dairy products, they have high risk of acquiring this infection. The commonest transmission is transplant center. It occurs through transplacenta. So by the time we get to O and G, we're talking about this transplacental transmission of hysteria. Transplacental movement, and of course, intrapartum delivery. So when the baby is coming out through, the individual can develop this Listeria infection. So that is why it will make sense for us to say that Listeria is a common cause of a problem in babies or neonates, just like which organism we have discussed today. Just like which one?
Group B.
Exactly. Just like the
Group
group
B.
B, just like the group B strep causing MOPS, which is a meningitis, the pneumonia, and the sepsis. So that's it. So Listeria 2 is a problem of pregnant women, young children, newborn, and people that are immunocompromised. That is Listeria for you. So don't forget the unpasteurized dairy, cold deli meat. It likes cold environment. Transplacenta and what's it called? Vaginal transmission. So it grows well in refrigeration temperature. So they can put that in the question. It grows well refrigeration, cold temperature. That this is Listeria they are talking about. So when it's moving, it forms these rocket tails that we are seeing here, and that is due to proliferation of its actin filament. So Listeria will be able to move from one cell to another cell. So Listeria has the ability to evade phagocytic damage, because once it's engulfed by the phagocyte, it can move, through the cell of the phagocyte by this rocket tail, just be whipping the rocket tail, and it can move from one cell to another cell. So avoiding the phagocyte, even avoiding the antibodies at the same time. So it can also generate pulse, in the phagosomes to escape from the phagocyte into the cytoplasm. So it's elicit this tumbling motility. This is not very important. What is important is, what does it cause? What does it cause? So we have said it that it can move transplacenta, right? We have said it that it can occur vaginal delivery. We have said it that it can occur through unpasteurized dairy product consumption. So if a mother takes unpasteurized milk, they can easily develop chorioammonitis. And from there, it can enter, into the amnion of the, baby, and from there into the blood of the baby, causing neonatal sepsis. And from there, you can even have spontaneous abortion. So sepsis in the mother, in the baby, before even being delivered. Sorry, I'm not supposed to say neonatal because they've not even given birth to that baby. So sepsis in the baby before being the fetus. And at the end of the day, they can even have spontaneous abortion, if not being properly managed. Chorioamnitis is a very serious problem. Can lead to sepsis and abortion at the end of the day. Some of them might be born with some granulomatous lesion that will call granulomatosis infantiseptica. So I think I have one image here before, but I don't think it's still here. It's just a granulomatous lesion, in a newly born. It's not commonly tested. It's not very likely. You just see something that looks like a necrotic, area like this. So if they tell you in the exam that a baby was born and we are seeing granulomatous lesion, with abscess in multiple organs or in the skin, just go and pick granulomatosis infantiseptica from Listeria. That's it. So in people that are immunocompromised, in neonate and elderly people, it is a problem because it can cause meningitis. That is why step 2, once we see that somebody is immunocompromised, somebody is a young patient, or somebody is an elderly, and the person is having meningitis, you must add ampicillin to it. I don't want to know what you are giving initially. You must add ampicillin because you are covering for Listeria. Only because of Listeria, you had this ampicillin. Once you see that this person is old, maybe more than 65, the person is immunocompromised, and the person is a neonate because of the weakened immunity in this category of people, add ampicillin to cover for Listeria. You cannot forget this. You cannot. So ampicillin to cover for meningitis in those guys, they can also develop the chorioamnitis, which can lead to all these things we have talked about, and the granulomatosis infantiseptica. In adults or elderly individuals that are okay, it's usually self-limiting diarrhea that they experience, and it goes. That is it. So moving on to nocardia and actinomyces. So these guys, we have said it, they are what? Gram-positive.
Dr. Mawale, can I stop you right there? That's a question. You said give ampicillin to cover for listeria.
Yes.
And then you said something about meningitis.
Yes. So, like I said, if immunocompromised people, like people with HIV or neonates or elderly people are having meningitis, we must always add ampicillin to that regimen to cover for the listeria causing the meningitis.
Okay.
So because they are at high risk of developing meningitis from listeria. So anybody that is immunosuppressed, that is a neonate, that's an elderly person, part of your empiric treatment, and ampicillin must be there to cover for listeria. So the gram-positive, we said they can be branching, they can be cocci, they can be rod. So the branching now, it can be aerobic or anaerobic. The aerobic one is nocardia. The anaerobic one is actinomyces, right? So nocardia is one of those catalase positive guys. You know why? And actinomyces is an anaerobe and it's catalase negative. And actinomyces is not acid fast. We know that nocardia is acid fast. What is the commonest? What is the preferred sensitive stain to use in the screening?
Nelson.
No, please,
for
let me,
nocardia.
no, please let me finish the question, please. So what is the sensitive stain which is used in the screening for tuberculosis?
Rhodamine. Rhodamine
Oramine,
stain.
oramine, rhodamine
Yes,
stain. Please don't let us go and pick
Amazing.
Yeah.
zinestino.
Rhodamine.
Oramine, rhodamine stain. Very important.
Mm.
So nocardia, acid fast. Nocardia is found in the soil. Is a son of the soil. Why? Actinomyces is a product from the GI, reproductive tract, and oral. So from the mouth to the reproductive tract, the genitourinary to the GI, that's where actinomyces is. What does nocardia cause? Nocardia can cause cutaneous problems. It can cause pulmonary problems and cutaneous what's it called? Cerebral problems. So three things: the skin, the lungs, and the CNS. So nocardia causing a pulmonary infection is just similar to tuberculosis. The way tuberculosis will present, that's the way pulmonary nocardosis too will be. It's just that once you do your PPD test, it will be negative. So that can increase your suspicion. It can be even so confusing that even if you do the acid fast staining, it can be positive. But once you do your PPD, it will be negative because nocardia is not, going to test positive for PPD. So the cutaneous lesion usually follows trauma in someone that is immunocompetent. So they have a trauma that maybe because you know that we have said it that nocardia is present in the soil. So there could be like traumatic inoculation from something that have been in contact with soil. Maybe the person had maybe like stick injury or maybe any form of knife injury that is already, contaminated with the soil and they stab somebody, can introduce that nocardia into that wound and they can be cutaneous nocardosis. And what we are going to be saying is just multiple discharging, something that looks like a fungal infection. It's very chronic. So cutaneous nocardosis. So something that looks like exactly, see, this kind of thing. So once you are seeing this, think of cutaneous nocardosis. But they are going to help us. They are not going to stop with image. They are going to give us the clinical scenario. Person had an inoculating injury. They did the staining, is weakly acid fast, and the organism appeared filamentous. We know that, okay, this is nocardia they are talking about, And from there, it can also move to the CNS and can cause a brain, a brain abscess, which is like a cerebral abscess. So how do you treat? You give Septrin. SNAP is the acronym. SNAP. Septrin, S for nocardiosis, and A which is actinomycin treating with penicillin. So you treat actinomycin with penicillin, you treat nocardiosis with Cetrin. So what about actinomycin? We have talked about the fact that it's an anaerobe. We have talked about the fact that it is not acid fast. We have talked about the fact that it's a normal flora of the mouth, the GI, and the reproductive tract. Now, how will they ask the question on actinomycin? They will just give us a clinical scenario of somebody having multiple oral or facial abscess that is draining via multiple sinus tracts. And they can tell us that there's a preceding history of the person having a dental procedure, maybe dental extraction or oral trauma, or even dental caries. So that is the focus of the infection. So what happens is that if somebody develops a dental caries, or the person had a dental extraction that involves some surgical manipulation of the dental tissues, or the person had maxillofacial trauma, all those things can make this actinomyces guy change from a normal flora of the mouth to a pathogenic form, and it will start causing this facial or oral abscess with discharging tract. Now, this discharging tract will be releasing sulfur, yellow-like granules. So if you remember, the pigment produced by organisms that we talked about, which organism produce red pigment?
Serration.
Serratia mercescens. Very good. Blue yellow. Blue green.
Pseudomonas.
Pseudomonas. And what's it called?
Golden yellow.
Golden yellow, Staphylococcus. And the yellow is actinomyces. So another place they like hiding is that they will tell us that somebody develops PID. So they start saying that somebody develops a fever, low abdominal pain, foul smelling vaginal discharge, and when they did, cervical motion tenderness positive. That's a PID. So, and they just say that the person developed it few days or few weeks after inserting an IUD. Just go and pick actinomyces until otherwise good. That's not the time to be picking chlamydia or Neisseria. I'm saying epidemiologically, that's the commonest. There's a risk factor here. They can even put it there that the person is not sexually active for that confuse somebody. So the person has IUD there, and that's it. Although if somebody is even having IUD, the idea is because the person is sexually active now. Am I wrong? I don't know if we get what I'm trying to say.
Yes.
So, but the IUD shall be there. They will shall put the IUD there. They will put the IUD there. Okay, if the person is sexually active, it will be with one partner. You can say that the person is only sexually active with the husband. So, and the person has an IUD. So, that sexual history might not be sufficient to, to explain chlamydia or Neisseria, provided that the man too is faithful. So, but let's just don't overthink it. Don't let us overthink it. IUD insertion and subsequent PID, think of actinomyces steadily. So you treat with penicillin, SNAP, actinomyces, penicillin, nocardia, sulfonamide, SNAP. So moving on to Mycobacterium tuberculosis, we are not going to waste too much time on Mycobacterium tuberculosis, something we already know. So it is acid fast, grows slowly in the culture, takes about 6 weeks. Culture like lowest Jesse medium, we have Mycobacterium tuberculosis, we have the avium intracellular. They like this guy. Very important stuff. Avium intracellular. Cannot go for a guy, don't know avium intracellular. It's very dangerous. There's the Scrofulacium, that can cause cervical lymphadenitis, and there's the marinium. So people that develop skin injury after, or like some abscess after they have handled some aquarium animals, that's because they have acquired this Mycobacterium marinium. So it's very, very common in people that are handling maybe fish or all these oysters in the aquarium. So the Mycobacterium marinium is usually hiding in those areas. Then the Scrofulacium just means that the person is developing like a cervical lymphadenopathy. Just a solitary cervical lymphadenopathy that we call scrofula. So the implicating organism is usually Mycobacterium scrofulaceum. avium intracellare is very common in people that have CD4 count less than 50. Please, if the CD4 count is not less than 50, don't ever pick avium intracellare. It has to be less than 50. And they will tell you that the person is having, maybe the person is having diarrhea. You know, the person is having some diarrhea, the person is having disseminated form of TB, just stuff like that. And maybe they did gram staining or something, they're not gram staining and acid, not gram staining, acid fast staining. And you're not saying something that looks like TB. Please don't pick TB. It's going to be avium intracellare. Acid fast organism in an individual that is HIV positive, with CD4 count less than 50, having like maybe what's it called? Diarrhea, nausea, vomiting, and chest infection like fever, cough, weight loss. It's likely to be avium intracellare. So, how does TB typically present with? You have fever, you have night sweat, weight loss, cough, hemoptysis, just like we know. And there are some virulent factors that we need to know for TB. The first is cord factor. The cord factor. So what does the cord factor do? The cord factor is there to form a cord around that TB. So it forms a cord around the TB, and the cord that is formed around the TB is the granuloma. And how does it do that? It promotes granuloma formation by inducing release of TNF alpha. We remember that we said that TNF alpha is the factor that helps to maintain the granuloma. The granuloma is
Yes.
maintained with the use of the TNF alpha. So if you give anything that breaks down TNF alpha, there's no granuloma again, and the TB is released. We have the sulfatides, which are like surface glycolipids that is released by the TB, and they inhibit phagolysosomal fusion. So some TB releases sulfatide. Why? Because they want to prevent fusion of the phagocytes, with fusion of the phagosome with the lysosome. Because once the phagosome engulfing the TB fuses with the lysosome, it is over for that tuberculosis. Otiton for tuberculosis for some of us that understand Yoruba. But the tuberculosis is not going to allow that. It already have sulfatide that will just stop the phagosome from fusing with the lysosome. The sulfatide put a end to the phagocytosomal fusion. While the cord factor forms a cord around the TB, which is the granuloma, by inducing release of TNF. But sulfatides do not allow for phagolysosomal fusion. Don't forget that. So, moving on to the presentation, all these things, we are not going to be going into too much details. It's something we already know. Somebody get exposed to the infection first time, the tuberculosis, it gets inhaled. The next thing is that the antigen presenting cells are going to take it, and they are going to start presenting it to the immune system. So the immune system recognize it, they differentiate into TFR cells, and they start forming the granuloma. But they will drag everything like that, and they will drag it to the base of the lung. So the simple way why it goes to the base of the lung is like, it's assumed that the blood flow here is actually high. So more immune response in this point. So this is where they start from. So, you have the initial inflammatory response in the lymph node, then later the organism is being held or calmed within the pleura of the lower part of the lung zones. So, and that is what you call the gun focus. The gun focus. So the lymph nodes, which is the hilar lymph nodes, and the gun focus together are known as the gun complex. So the bacteria enters, it's been, a portion of the bacteria is being presented to the lymph nodes in the hilar area, and they differentiate into their respective CD4 cells that can recognize the tuberculosis, and they go and drag the organism like that to this base, and this is where they form the gun focus. So together we call them the gun complex. Now, most people will just have their gun focus here. Normal, nothing happens. They camp it like that. So nothing happens. It's heals by fibrosis and calcification, and nothing happens. But in like 10% of people, it's not going to stop here. The infection is going to be progressive. So it starts spreading to other parts of the lungs, particularly in people that have HIV/AIDS transplantation, transplant recipients, steroid use, malnutrition, that immune system is very weak. They find it very difficult to camp that tuberculosis. So tuberculosis is virulent. It's just a fight, anything, killing the cells, destroying the lung parenchyma. So that's going to be the progressive primary tuberculosis. So primary tuberculosis, because that's the first time the person is getting exposed to it. But what is the fate? Either it goes through this gun focus route and becomes silenced by fibrosis and calcification of that granuloma, or it spreads to both lungs and becomes progressive, especially if the person is immunosuppressed from either AIDS, from malnutrition. But I said that in most people, 90%, everybody is going to wall off that organism as a gun focus somewhere here, and nothing will happen. But we can have reactivation. Now, where the USMLE will now wait for us that we have to be careful is that once they tell us that there's reactivation, maybe the person now studying develops any form of immunosuppression, maybe he's on steroids, had a lung transplant, had any transplants, maybe on some certain drugs, and the immune system becomes weakened. Now, this tuberculosis will now will come out of this walling off and to migrate to the upper lobe where you have high oxygen, and the inflammatory response is going to be causing at this point is going to be more robust, which will lead to formation of cavitary lesions. So what you are looking for in your question is formation of cavities. When you are saying cavities in the upper lobe, that is secondary tuberculosis until otherwise proven. That's not primary. Secondary tuberculosis until otherwise proven. At the upper lobes with the cavities, the cavitary lesions, fibrocaseous necrosis with cavitary lesions, right? And that's all for the secondary tuberculosis. But for the progressive, it can progress to bacteremia. It can continue destroying the lungs, then it progresses to bacteremia. And when it gets to bacteremia, enters the blood, it can shower to other part of the organs, like the meninges in the brain, causing tuberculous meningitis. Which we are going to be seeing this exudate at the base of the brain. So they like putting that description. Once you're saying exudate, the base of the brain, just know that, okay, it's likely to be tuberculosis. Goes to the spine, pot disease, the lymph nodes, the liver, the lungs, spleen, the adrenal glands, tuberculous adrenalitis, right? What's the commonest cause of adrenalitis in the US, in the resource developed area?
Autoimmune.
People are ready. So that is what you are looking out for. In your question, just look at, where's this person from? They said this person is from Africa. This is tuberculosis. They said this person is from Canada. This is likely to be autoimmune. So I want to be looking out for, maybe this person has pernicious anemia, Hashimoto thyroiditis, or something, other autoimmune disease. But if it's from Nigeria, Ghana, just go and pick. Because you see question, they put Nigeria there. Where we are coming from, they put a 50-year-old man from Nigeria. So we have to know all those things. Very, very important clinchers. So that's that about the tuberculosis. And we have to also talk about some certain tests. And the first is the PPD test, the purified protein derivative test, in which you just get a purified form of the bacillar antigen, you inject it into the skin, and you wait for, an hypersensitivity reaction, which is type 3, true or false?
False.
So what type is it?
False. Type 4.
So type 4, waiting for the T cells to come around to form an inflammatory response around it. And you are going to be reading that inflammatory response by looking at the zone of the erythema, how big it is. So people with current tuberculosis infection or past infection are usually positive to this PPD. The past infection will be positive. Anybody know why? Anybody knows why? Anybody? Why would past infection be positive for PPD? Anybody? Immunology, back again. Memory cell, no catch.
Because of the
Memory
cells.
Memory
cells.
It is the memory cells. There's no catch at all. It is the memory cells. They are there. So Just like we said that memory cells reduce in aging. True or false?
True.
True.
Memory cells reduce
It's
in
false.
aging.
No.
True.
They don't
Don't
False.
false.
Ah,
False.
which one did we say
They
will
don't make
reduce?
new They don't make new memory cells. The existing ones remain.
Is the
Old ones
Exactly.
unable to mount a new
the
response.
old ones?
So the concept of immunosenescence is that the naive cells are reduced. They are gone. While the
Yeah.
memory cells
Yes.
are
Mm.
still there. So that is it. Don't forget.
Mm-hmm.
So PPD negative if there's no infection. Of course, if somebody is not previously infected or not currently infected, PPD will be negative. But PPD can be negative in people that are immunocompromised. So that's one of the false negative stuff about this PPD stuff. You know, somebody is having tuberculosis, but because the CD4 count is very low, they cannot mount any immune response to the antigen. So the PPD test will be negative. So that's one of the flaws of PPD testing. But we have a better one, which is the interferon gamma release assay. And the advantage of this guy over PPD is that they can test this. Very important. You tend to avoid false positive from BCG vaccination because somebody can receive BCG vaccination and develop T cell response against it, and the T cells will be there. They'll be waiting. And when you introduce PPD antigen, because that PPD antigen is very similar to the antigen we use in BCG. So it means that the antibodies induced from this BCG, the T cells rather, not antibodies, the T cells provoked from when somebody received this BCG vaccination are very similar to what will be induced. You know, sorry, let me take it again. The T cells that are formed following BCG vaccination, they have a very high tendency of recognizing the antigen when you will give somebody PPD. So that's why there's a false positive, rate. So somebody takes a BCG vaccination, even despite the fact that the person does not have tuberculosis. If we do PPD test for that person, it will be positive because of that cross reaction. But to avoid that, we just do our interferon gamma release assay. So because here now, the antigen in a way is different. So from that of the PPD. So once we introduce the antigen, we just measure the level of what's it called, of the gamma interferon that is released from those T cells. So because the antigen here is quite different from that of the BCG vaccination, we can still catch people with tuberculosis or people without tuberculosis, regardless of their BCG vaccination status. So the go-to standard of diagnosis is always the interferon gamma release assay because it does not have this false positive effect from BCG vaccination. So, presence of caseating granulomas with central necrosis and cavitations is what? Classic for secondary tuberculosis. Don't forget. And they said it here, the Langerhans cells are the cells that surround the granuloma. They should not be confused with the Langerhans, which are antigen-presenting cells of the skin. So the Langerhans are the ones that surround the granuloma, while the Langerhans are antigen-presenting cells. So tuberculosis reactivation is very common in people with HIV, organ transplant, TNF inhibitor. This is one of the most important stuff you should not forget. TNF inhibitor, adalimumab, infliximab, etanercept, all those things, they can suppress TNF, and before you give them, you want to rule out presence of tuberculosis by doing what? Your interferon gamma release assay. So, yeah, so that is that. Because if you give somebody TNF alpha inhibitor and you do not rule out TB, the person has a TB, it should become reactivated. So reactivation has predilection for the apex of the lung due to the oxygen. So this is central necrosis. You can see the granulomas here, and that is tuberculosis. So moving on to leprosy. Leprosy is very simple, commonly
Dr.
tested.
Babasola, I have a question. Can you elaborate more on the PPD positive skin test? The reason why it's positive on a patient that doesn't have a TB, and the one for skin test PPD negative for immunocompromised. Just the reasons why.
So we said it is negative in somebody with no infection. Why? Because if the person doesn't have tuberculosis infection, that means that there's no memory T cells against that tuberculosis. So that means that if I give that person PPD antigen, there's no memory T cells to interact with it. So there's no reaction.
Okay.
Doctor,
Okay.
do you understand that?
Yes, I get that
So
one. Mm-hmm.
because this PPD antigen is kind of suppressed, in a way, so it's not very severe enough to provoke large inflammatory response to even cause, tuberculosis itself. So you are relying on the memory T cells to collaborate with this antigen of this PPD and form, the erythematous lesions that you can use to read. Now, the reason why it is not also positive in people that are immunosuppressed is because if somebody has a low CD4 count, even despite the fact that this person has tuberculosis, it will still be negative. Why? Because their low CD4 count means that their T cells, their memory T cells will be low. Are you following? Are you with me?
Yes.
So if their memory T cells are low, it means that once we introduce the PPD antigen, there is no T cell to interact with it because it is low. So there's not going to be any inflammatory response. So we assume that test is negative. Do you understand? Or it's
I
not
do.
still clear? Okay, cool. So that's the way it works. That's why that guy is not. It can be somehow. So, Hansen disease, that's leprosy. Leprosy is also one of
and
the.
the one for positive skin test, you forget that one in a patient that does not have TB. I know you said it's due to cross-linking. Can you explain a little bit about that cross-linking?
The cause of negative test in somebody that does not have TB. Is
It's
that
a
your question?
negative. I thought you said positive. When you were saying, you said a positive skin test on the patient that does not have TB.
Positive skin
You know
test
what?
on someone that
Yeah,
does
I
not
know
have.
that it can happen due to BCG. Have people that have taken BCG. So does it mean that there is how do I put it?
Yeah. So I
Um,
said the antigen for this BCG
mhm,
can
mhm.
easily interact with. So okay. So after they receive, we know that the idea of giving BCG vaccine is to provoke T cell response, right?
Yes. Mm-hmm.
So that the memory T cells will be there. So that by the time the mycobacterium is now coming real life, T cells are there to attack it. So that means that
Mm-hmm.
after receiving BCG vaccination, everybody in this world will have this. So now, the reason why people with BCG vaccination will have a false positive result, they will have a positive PPD test, despite not having tuberculosis, is because they already have this T cell in their serum. So by the time I introduce the PPD antigen, the antigen will just go and react with this T cell, and there's going to be inflammation.
Okay.
So, and we are going to say, oh, this person is reacting, it's positive. Do we get it?
Yes, I do. Thanks.
So, you're welcome. So, leprosy. Leprosy is caused by Mycobacterium leprae. It is an acid-fast bacillus that lies cool area. You cannot forget this. You cannot go for your exam and don't remember this. Just like you cannot forget what organism thriving in cold environment.
Listeria.
Listeria. So that is the reason why leprosy likes infecting the skin and the superficial nerve, because this area, they are cool and it can cause the glove and stocking loss of sensation, just like diabetes. So distal arms, distal legs, loss of sensation in those areas. You cannot culture leprosy in vitro. So it's more like an intracellular guy. It needs something to, proliferate inside. you make a diagnosis by skin biopsy or TG-PCR. This is more like step 2 stuff. The reservoir in the US is armadillos. So areas where you have a lot of armadillos, they are reservoirs for leprosy. You don't want to be touching armadillos because you are scared of leprosy. There are 2 forms, and they like asking this. 2 major extremes. Actually, it's more than 2, but with the sake of our exam, they have narrowed it down to 2 for us, which is very good. We have the lepromatous form and the tuberculous form. The lepromatous form and the tuberculous form. The lepromatous form and the tuberculous form. So what I just want to say that will make this stuff very easy for us is that we have to assume in our mind that tuberculous form, the immune system is very good. The immune system in an individual with tuberculous form is very strong, very excellent, like gallant. Tuberculous form, the immune system is gallant. But the lepromatous form, the immune system is weak. The immune system is very weak, very, very weak. In what's it called? In the lepromatous form. So in the L form, the immune system is very, very weak. They are tired. Now, what is this going to have? What's the effect of this on the bacterial load? If the immune system is very weak, it means that the bacterial load is going to be what? Very, very high. Do you understand that? The bacterial load is going to be very, very high because the immune system is very weak to take care of it. But in the tuberculous form, the immune system is too strong, so they have little lepromatous bacteria. Now, when I say that the immune system is weak or the immune system is strong, I mean that for the strong one, I mean that the TFR1 immune response is what is provoked because that is what we need to handle bacteria. TFR1. Do we need TFR2 for bacteria? No. TFR2 is for which pathway? Anybody knows?
Eosinophil.
Allergic pathway
Exactly.
asthma.
Or
Eosinophil.
allergic stuff.
IG
Yeah,
production.
allergic. Yeah.
Allergic stuff. Now, somebody's having tuberculosis, leprosy, mycobacterial leprosy, and you are provoking TFR2. Are you dealing with allergy? It's like they don't know what they are doing. So, in the lepromatous form, the pathway of the cell-mediated immunity that is provoked is the TFR2, which is weak. And therefore, the bacterial load is going to be very, very high. In the tubercular form, the immune system is very high. TFR1 is what is provoked, and the bacterial load is going to be controlled. Now, don't forget what they are mentioning, cell-mediated immunity. We are not saying humoral. This is a type 4 hypersensitivity response. We are not saying humoral. It does not involve anything like B cells. So it's cell-mediated immunity, TFR. TFR1, TFR2. Now, what is all these jargons we have been saying? What is it going to affect? What's going to be the consequence of all this? For the lepromatous form, because the cell-mediated immunity is low, is weak, and it is differentiating along the TFR2 pathway, they cannot adequately take care of that bacteria, and the bacterial load is going to be high. And when we have large amount of bacteria in the skin, in the superficial nerves, they are going to be destroying the skin and be forming granuloma. Hope we remember that leprosy is one of those guys that can form granuloma too. We said the word is microbacterium. Anybody remembers that day?
Yeah.
Yes,
It was
that's one.
microbacterium that we highlighted. We did not highlight microbacterium tuberculosis. We said
Mm-mm.
microbacterium. So all of them, they can form granuloma. If you look at this guy's face now, this is a lot of granulomas forming in the face. We call this lioning phase. It's almost looking like a lion. So lioning phase because of excessive granuloma formation in the skin. These granulomas will be forming in the nerves, and suddenly we'll notice that the person cannot feel pain. The person put the hand on something that is hot, cannot feel pain. The sensory nerves are gone. That's the clinchers that you need for leprosy. Sometimes it can also cause amputation of the limbs. Because of chronic inflammation, the body starts absorbing the bones, absorbing the muscles, and it leads to digital amputation at the end of the day. So And we also see like some hairless lesion. So there are some on the skin, because of the excessive granulation, they start losing the hair, they start losing the sensory nerves, and it becomes painless. That's why they have the word hypoesthetic. So because of damage to the sensory nerve, painless. And of course, because of the inflammation, takes away the hairless granulomatous lesion in the skin. This is leprosy until otherwise proven. So just watch out for the granulomatous plaques, which is hairless, as well as the hypoesthesia, no pain, because superficial nerve is gone. Leprosy. But for people with the tuberculous form, they will have little hypoesthetic, hairless skin plaques. Once you see little hypoesthetic, hairless skin plaque, you know that this is a tuberculous form. This guy is doing well. He's able to control it. The bacterial load is small. Nothing is causing problem. So how do you treat? Regardless of the subtype, you give dapsone and rifampin. Anybody knows the side effect of dapsone? What we are scared of? Anybody?
Oh, granules.
Agranulocytosis, are you sure?
Yes.
Dapsone,
Hemolytic anemia.
Direct
hemolytic
cons-
anemia in which category of
hemolytic
people?
anemia.
This
In,
is PD.
in which? In
Yeah,
GGSPD?
This is
hemolytic
PD
anemia.
deficient
What
patient.
else? What else? There's something else.
Met
Direct
hemoglobin.
test
Fantastic.
positive.
Met hemoglobinuria. So if somebody has met, what do you give? How do you treat the person?
Methylene,
Vitamin
methylene
C
blue
or
or
vitamin
vitamin
C.
C.
Or
Vitamin
vitamin
C.
C. That's very good. That's very, very good. So if the person is now having lepromatous form, you have to add clofazimine. So in addition to giving dapsone and rifampin, you add clofazimine. Add clofazimine for lepromatous. Don't forget to add it so that you can help this immune system, take care of this guy's face. You have to add clofazimine to help the TFR2 to take care of this guy. So, moving on to the gram negatives. The gram negatives, please, so sorry, we are going to be taking a break soon and we are going to reconverge later. So let me just push it to these gram negatives. So for we to say that something is a gram negative, that's to show the pink coloration. Then we divide it into 3 spectrum. The cuff rods, unlike the gram positive that is going to be branching, but here it is cuff rods here, the cocobacilli here, and the diplococcus. So you don't have any rods. You don't have like, okay, we have rods. Sorry about that. I almost omitted that. So we have the bacilli, we have the cuff rods, we have the cocobacilli, and the diplococcus. So let me start from the cuff rods. The 3 cuff rods, they are oxidase positive. So Helicobacter pylori is curved, Vibrio cholerae is curved, Campylobacter jejuni is curved. So Campylobacter jejuni grows well at 42 degrees Celsius, which is very high temperature. It still grows well. It's an adaptive mechanism. Vibrio cholerae grows well in alkaline medium, and Helicobacter pylori release urease, which we talked about previously. Diplococcal, you just have to remember 2 guys, Neisseria and Moraxella. Those are the diplococcal. Once you see gram-negative diplococcal, in 90% of the situation, it's going to be Neisseria, but it can be Moraxella too. And it is aerobic, but it can be further classified by the maltose fermentation ways. So, Neisseria meningitis from the word M ferment maltose. Gonorrhea and Moraxella do not ferment maltose. So that is that about the classification of the diplococcal. So once you see diplococcal gram negative, think of Neisseria. And you can further separate them by testing for maltose fermentation. So the cocobacilli, they are the ones that end with the Ella. So Bordetella, Brucella, Francisella, Pasteurella, Bordetella, all those Ella guys, they are cocobacilli. And the only one that is playing with the Ella, and I don't know what he's looking for there, is Haemophilus influenza. Haemophilus influenza is the guy that is flirting with all these Ella guys because they are ladies. Somebody that the names end with Ella is always most likely going to be a lady, Emanuela. So Hemophilus is the guy, attached to all these Ellas. So then moving on to the bacilli. The bacilli, we use the LOS algorithm to classify them. The first is a lactose fermentation. Are you a lactose fermenter or not? If you are a lactose fermenter, are you fast or you are slow? So the lactose fermenters, they are like 5 that we are expected to know. And the fast ones include E. coli, Kleb, and Enterobacter. Sorry, I don't have any acronym for this. But we are going to get used to them. E. coli, Kleb. E. coli and Kleb are always going together. They are fast lactose fermenters. Fast. E. coli, Kleb. While the slow includes Citrobacter and Serratia. So Citrobacter and Serratia are slow fermenters. Okay. So after the lactose fermentation is negative, the next thing is to look at the O, which is the oxidase positivity. Do you have oxidase enzyme or not? So 2 organisms that have oxidase enzyme that I want us to pay attention to, Pseudomonas and Burkholderia. Now, one thing that is common to these guys that I usually use to remember them is that both of them, they can constitute problems in people with, in what?
Abscess.
Cystic
Lung
fibrosis.
In
abscess.
cystic fibrosis.
Cystic fibrosis, yeah.
In cystic fibrosis, Pseudomonas and Burkholderia is a problem for people with cystic fibrosis, and they are both oxidase positive. When we are done with that, and it's negative, we go to the S, and that talks about the H2S on the TSI agar. So the ones that have fishy odor of H2S, those are Salmonella. Salmonella is from salmon, fishy odor. And Proteus have fishy odor when it causes the UTI. They have the fishy odor. So Salmonella and Proteus, have H2S production when they are cultured on TSI agar. While the opposite of Salmonella, which is Shigella, and the Yersinia, are negative. So sly is a word. So which is Yersinia and Shigella. They lack L, they lack the H2S. But the ones that have the H2S are the ones with the fish odor, which includes the Salmonella, salmon, and the Proteus, which is a cause of fishy odor UTI. So I know the algorithm is quite complex, but with time, we'll get used to it.
Dr. Baroni, please,
Yes.
the LOS, what's the S in the mnemonic for this?
So the S is for the H2S.
Okay.
The H2S and the TSI agar. So any one of them that we remember, just to make it make sense. So H2S for the TSI agar stuff. So moving on to the individual organism. So the first is Neisseria, and I've said it that I think there's a question here. Let me see. 2 questions. A 54-year-old woman, I know some people are already ready to tear questions apart. So I'm so sorry, bear with me. We just have to move at, because there's a lot to cover. A 54-year-old woman comes to the physician because of low back pain, night sweats, a 5 kg weight loss during the past 4 weeks. She has rheumatoid arthritis treated with adalimumab. Temperature is 38. Physical examination shows tenderness over the T10 and the L1 spinous process. Passive extension of the right hip causes pain in the right lower quadrant. These patient symptoms are most likely caused by an organism with which of the following virulence factors? Anybody?
What
This
facts?
is
Colitis.
the TB. She has Pott's
Colitis.
disease, TB spine,
Disease.
and I think it's the cord factor, but here I think it's more of lysosomal for
Yeah.
surface
So
glycoproteins.
yeah,
Glycolipid.
so this surface glycolipids are the
Sulfatide.
sulfatides, yes,
Sulfatide.
which prevent phagolysosomal fusion.
Fibrolysis.
We can also look for the cord factor that form a cord around the tuberculosis, by inducing TNF1 that, allows for formation of the granuloma. So any one of them that is there, we pick it.
Okay, so doctor, cord factor is not for preventing phagolysis, huh? It's
No,
just to allow for formation of granuloma,
granulomas, yes. Which one is this?
which prevents. I thought granuloma prevents phagolysis too.
So the idea why the tuberculosis is forming the granuloma is that so that it will not be killed. You know that
Mhm.
if it's confined within the granuloma, it still have chance of coming back when there's immunosuppression. There's still hope for it. So please, don't kill me. Oh, just put me inside the cell. I'm okay there. Yes, that's what the tuberculosis is trying to do. But if they now say, we are going to kill you, but we are not going to kill you here. We are going to take you to the lysosome. We target you for
Oh,
lysosomal degradation. You will now be like, I'm on a death with this. Let me release sulfatide to prevent the fusion
to prevent.
of the phagosomes with the lysosome. That's the idea.
Okay, thanks.
So, which one is this last one talking about? Proteins that cleaves immunoglobulin A.
Chains.
That should be the
Yeah.
shame.
IG.
IgA
That's
protein.
correct.
That's
Yeah.
easy. What about this?
South Orange.
Stuff. Strep pneumo.
Which one?
This I'm
FC
highlighting.
South
portion.
Orange.
Is Staphylococcus aureus.
Staph. I think it's
So
Staph
what
aureus.
protein?
South Orange.
Protein A.
Protein
That should
A.
be protein A.
Protein
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 A.
A. Yeah.
That's very easy. So a 35-year-old man comes to the physician with 2 months history of fever, night sweats, and a cough productive of white sputum. He lives in New York. Is currently homeless. He uses intravenous heroin several times a week. 3 months ago, he was admitted to the hospital for aspiration pneumonia. His dad passed away at the age of 54 because of bad heart condition. Fever, respiration of 22. Physical examination shows coarse crackles in the upper left posterior lung field. An X-ray of the chest shows a cavitary lesions with calcification of the upper left lobe. Which of following is the most likely source of the pulmonary finding?
Reactivation of
A.
the
Reactivation of
I
latent
think activation of
activity.
TB.
Good
TB.
job. Good
Secondary
job.
tuberculosis.
Good job. Good job.
Secondary
Good
TB.
job. Moving on to Neisseria. So Neisseria, we have said it is a gram-negative diplococcal infection that is aerobic. And how you can separate between Neisseria meningitis and Neisseria gonorrhea is, to check for does it ferment, maltose or not. In which the meningitis is going to ferment maltose, but the other ones will not. They're part of Shin and they release IgS proteins, just like we talked about. They both metabolize glucose, but it is maltose that they don't both metabolize. They both contain lipo-oligosaccharides. See, they are emphasizing it again with strong endotoxic activity. Neisseria gonorrhea is intracellular, lies within the neutrophils. That's where it stays, and that point is very important. Neisseria gonorrhea stays within the neutrophils. That's why it's intracellular. And we have talked about the acid production, which the meningococcal will produce acid from maltose fermentation, while the gonococcal only use glucose. So what are the differences? One more time. There's no polysaccharide capsule in gonococcal. There's a polysaccharide capsule. So the one that is encapsulated is actually the meningococcal. Meningococcal is the one that is encapsulated. The gonococcal is not. Because of fermentation of the maltose, we generate maltose acid in meningococcal. There's no maltose acid with gonococcal, right? The gonococcal, there's no vaccine against it. So there is no vaccine against the gonococcal organism. There is no vaccine. Why? Because of recurrent antigenic variation of the pilus protein. It's always changing this pilus protein from time to time. So it's a problem to form a vaccine. Gonococcal is sexually or perinatally transmitted. Meningococcal is transmitted by respiratory or oral secretion. So this one is because of how that is transmitted by respiratory and oral secretion. Hope you remember when I mentioned this fact. Anybody remembers where we mentioned this fact that meningococcal can be transmitted through respiratory secretion? Anybody remember
Yes.
what we're trying to
Mm-hmm.
explain?
Yes. Yes.
When we're trying to explain the IgA proteins that colonize the mucosa. So that was when I mentioned that. Don't forget it. And it's very common in people that live in close quarters. So people that live in barracks, dorms, college, all those things, hostels, they can acquire this. That is why at that age where they are going to college, living in dormitories, we give them this meningococcal vaccine, usually between 11 to 12 years. That is when we administer it. But if there's a need, you might administer it earlier at around 9 years. But most of the time, you give it 11, 12 years. And the vaccine that we give them is usually the one against the type B. So there's another one, the type A, C, W, Y. But the common one that causes meningitis and the other problem is the type B. So, but there's no vaccine against gonococcal. Don't make that mistake. Acid for the meningococcal. There's no maltic acid for gonococcal. Meningococcal has a polysaccharide capsule. Gonococcal does not have a capsule. So, what does the gonococcal cause? Gonorrhea, just like we know, painful urethral discharge, painful urination and all those things. Septic arthritis. We cannot forget that gonococcal can cause septic arthritis. There is no way we can forget that. It is not acceptable. Staph aureus can cause it. Gonococcal too can cause it. It is a cause of neonatal conjunctivitis. So 2 to 5 days after delivery, the baby start having, blurry vision. Like the baby will say he's having blurry vision. But there's just going to be like exudative discharge from the eyes of the baby, and to be red after birth. And Neisseria gonococcus is also a cause of pelvic inflammatory disease, PID, which includes the fever, the abdominal pain, bowel smelling, vaginal discharge, and most importantly, the cervical motion tenderness. And also the feet uch cutis syndrome. Anybody knows what this is from GI? Have you done it in GI or where did you do it?
It's when you have
Primary hepatitis. There's
hepatitis
Yeah.
inflammation
So
around the liver.
exactly. So there's now tubo-ovarian abscess. So that means that for some of us that did not join that class. So if this is the vagina now, or no, so let me say that this is uterus. So this is the vagina leading to the uterus, so we can have the bacterial entry from the vagina getting into the uterus, so causing endometritis. It can infect the fallopian tubes like this, causing sapingitis, and from there come down to affect the ovaries here. So from here, endometritis to sapingitis here in the fallopian tube, then down to the ovaries, causing a tubo-ovarian abscess. And just around here, we have the liver, so it can spread to the liver and cause a perihepatitis and also irritate the peritoneum. So all those additions that is formed around that area, from the abscess spreading to the liver and the surrounding peritoneum is what you call the feet uch cutis syndrome. So it's associated with like right upper quadrant pain. So somebody having initial lower abdominal pain, fast smelling discharge, now having right upper quadrant pain now, you know that it's likely to be a complication of the PID from the feet uch cutis syndrome. So how do you make the diagnosis? The NAT. You just do a PCR analysis. That's the NAT. And that's nucleic acid amplification test. And you want to reduce the spread by encouraging use of condoms because it's sexually transmitted. So use condoms, and for the babies that have neonatal conjunctivitis, because when the babies are born through the vagina of the mother with gonorrhea, they can easily get it intrapartum and develop that infection. So we want to give them prophylactic erythromycin high ointment to prevent the blindness. Another cause of neonatal conjunctivitis is chlamydia. So, both of them they go hand in hand, but that of chlamydia usually occur after like 2 weeks, 1 to 2 weeks. It's not as acute as that of Neisseria that occurs within 2 to 5 days. So how do we treat? Just one single dose of ceftriaxone. Just give them one single IM dose of ceftriaxone. They are okay. But the USMLE wise, step one, step two. If you have not ruled out concurrent chlamydia, these guys, they go hand in hand. In fact, I want to tell you that chlamydia is the commonest sexually transmitted infection in the US. Check it anywhere, you see it. So you must always rule out this guy. So once you have diagnosed the PID, you have checked for gonococcal and it is there, but you have not ruled out chlamydia, you must always, in addition to giving the ceftriaxone for the gonococcal, always add treatment for chlamydia. So as you are giving the IM ceftriaxone for the gonococcal, we are adding oral doxycycline to the person. Oral doxycycline. But if we did a co-testing and we ruled out chlamydia, you will not need to add your doxycycline because both of them can cause PID. Very important stuff. Very, very important stuff. So what about the meningococcal? We have said it. Young children, young people, adolescents that live in parks, close quarters, they can easily acquire this guy. And of course, from the presentation, the meningitis presentation, we'll have done the lumbar puncture. We'll see the bacterial evidence. Dr. Babahinde will have told us the CSF picture for someone with bacterial meningitis, so we should not forget that. And in addition to causing meningitis, they can have meningococcemia, which is more like sepsis, from the organism, and it's characterized by presence of petechial hemorrhage. So once you see this petechial hemorrhage, just have it at the market. Okay, this is likely to be sepsis from meningococcemia infection. In some very severe condition, they can have the Waterhouse-Friderichsen syndrome, in which they just have this bilateral hemorrhagic bleeding from the adrenal glands, and they suddenly have an acute adrenal insufficiency. That's very terrible, and hypoglycemic, dehydrated, hyperkalemia, and all those other things. So that's a very serious complication of what's it called? Meningitis, the Neisseria meningococcal infection destroying the adrenal glands. So that is that. And how do you make your diagnosis? You can culture or do the PCR analysis. And don't forget this prophylaxis. I'm very serious about it. Don't forget to give RCC as a prophylaxis from, you know, for some of us that attend reading, maybe RCCG will help us. So RCC, don't forget. I used to use RCC. I don't use RCCG so that people don't start worrying about what is the G standing for now. So RCC, renal cell carcinoma or something. Don't forget rifampin, ciprofloxacin, and ceftriaxone. Prophylaxis. They can ask you step one, step two. It has to be with you. Rifampin, ciprofloxacin, ceftriaxone for prophylaxis. So we are living in close quarters so they can ask us now in our exam that somebody suddenly starts, having symptoms of meningitis, and there's this boy that is staying there, and the boy was brought to the hospital, and they will be like, okay, so what do you want to give this boy to prevent any further risk of blah blah blah. So you just know that, okay, you want to give either of this guy to prevent him from also developing this meningococcal infection. So don't forget, you treat by ceftriaxone, just like the gonorrhea, or you give penicillin G. But most of the time, you see ceftriaxone there. So the next is Haemophilus influenza. This is the husband of those Ella, and that's why it's a cocobacilli, just like we said. And sorry, that's even another thing. So that's even okay, yeah, it's the one I was talking about. Yeah. I thought I was saying another thing because I think I mentioned Haemophilus, I mentioned Bordetella pertussis. Yeah, but I remember now. So it's the husband of all those Ella, Haemophilus. It has philia for all those Ella people. So it's transmitted through respiratory droplets, and we have the typeable form and the non-typeable form. And I said that for the basis for the classification is just a capsule. So if it has a capsule, you can type it. If it does not have a capsule, you cannot type it. And we said that the unencapsulated form is the one that is responsible for causing otitis media, by attaching through the biofilm. Hope you remember biofilm. Don't forget. So
Yeah.
the form that attach in the hair and cause otitis media is usually the unencapsulated one, and also it can also cause some other infection like the curb, conjunctivitis, the bronchitis. So it can affect the eyes, conjunctivitis, the throat, the lungs rather, bronchitis, and the hair. So it's not very common, but don't forget the otitis media, as well as other, invasive infections like even meningitis can go anywhere since the vaccine for the polysaccharide type B was introduced. So because there's now a vaccine for the polysaccharide type, which is a typable form, type B, so we're now having a more prevalent cases of this unencapsulated strain. So it produces IgA proteins because it's part of Shin, right? And it grows on chocolate agar. It grows on chocolate agar. And when we're talking about those culture medium, I mentioned that two factors are added, which is the factor 5 and the factor X. The factor X is the hematine, and the factor 5 is the NAD for growth. And the staff forest also use Thai to use this factor 5, to also grow too. So factor 5 is available for everybody. So factor 5 is NAD plus, factor X is hematine. It's used by both of them. And Haemophilus type B can also cause epiglottitis. If we don't know anything about Haemophilus influenza, we have to remember that it can cause epiglottitis. Very, very important stuff. And they are going to tell us that there's a child that is having high fever. The child is having drooling of saliva, cannot swallow, is assuming a tripod position, in which just sitting down with the head protruded like that, having very severe difficulty swallowing, which is dysphagia. And because the child cannot swallow, saliva is going to be pulling in the mouth and might be drooling at the end of the day. So high fever, dysphagia, drooling saliva, assuming a tripod position. That is epiglottitis on the otherwise problem. So ideally, step 2 wise, somebody comes in to you with epiglottitis, what you want to do is to secure the airway, but we don't need that for step 1. But it's good to know that so that by the time we come for our step 2, the fat is still with us. So what you want to do is that if you try to do an endoscopy, maybe when you are trying to secure that airway, you are going to notice that the mucosa of that epiglottis is going to be swollen. So there's going to be a cherry red appearance of the epiglottis. So cherry red mucosa, that's epiglottitis we are dealing with. And if you do a lateral x-ray, so the x-ray has to be lateral so that you can see the anterior posterior view. If you do x-ray that is anterior posterior, you'll be seeing lateral view. So just like, the way we are taking this now. So this is a lateral x-ray, and we are seeing the anterior posterior dimension of the epiglottis, and it's showing this inflamed thumb sign. So that's in keeping with epiglottitis. And the other things that Haemophilus influenza type B can cause is the MOPS, just like strep pneumo. Both of them, they work together. There's nothing that both of them cannot cause together. Both of them will cause meningitis, they will cause the otitis media, and they will cause the pneumonia, alongside with sinusitis. Don't forget, sinusitis can also be caused by Haemophilus influenza. So there is a vaccine for the type B capsular form, which contains the capsular polysaccharide. Don't forget, it's part of Shin. So that means that it has a capsule. And the capsular polysaccharide is made up of repeating units of polyribosyl ribitol phosphate. Just PRP phosphate, PRP, polyribosyl ribitol phosphate, and it's conjugated with diphtheria toxoid or other proteins. So that's the basis of the pentavalent vaccine. Can conjugate it with hepatitis B vaccine, the Haemophilus influenza vaccine, the diphtheria, the pertussis, and the tetanus. So that's why it's 5. So you can give, I think 2 doses between the age of 2 to 18 months. So it does not cause flu. What causes flu is not influenza from the name. It causes MOPS, 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 and the unencapsulated form will cause the COB, conjunctivitis, otitis media, and the bronchitis. But it does not cause flu. Influenza virus causes flu. How do you treat? So somebody having mucosal infection, you can, like all these epiglottitis, bronchitis, conjunctivitis, otitis media, you can give amoxiclav. It's going to take it away. But if somebody is having a much more serious problem like ceftriaxone, like meningitis, you have to give your ceftriaxone. Very, very important. You give your IV ceftriaxone. Somebody's having invasive problems like meningitis. But if it's just normal mucosa stuff like bronchitis, um, um, conjunctivitis, otitis media, you can give amoxiclav. But once it becomes meningitis, you give ceftriaxone. And you have to administer rifampin prophylaxis for people that have, achieved a close contact with people that have Haemophilus influenza. Just like you are giving RCC for Neisseria meningitis, you give rifampin for people with Haemophilus influenza stuff. So moving on to Burkholderia cepacia. So Burkholderia cepacia, okay, just stop at Pseudomonas and yeah. So Burkholderia cepacia, it is aerobic catalyst positive, gram negative or odd, and we said this guy is paired with Pseudomonas, and both of them they are what? Oxidase positive. Don't forget, and it causes pneumonia in people that have an underlying lung disease. It's not very common, such as cystic fibrosis. So somebody having cystic fibrosis, having pneumonia, you want to rule out Burkholderia cepacia. So the only problem with it is that it is MDR. It is a multi-drug resistant organism. And once somebody has infection with this guy, you cannot transplant that lung to give another person because it's going to cause serious problem in the person that's going to be receiving it. So anybody that has a lung infected with Burkholderia cepacia, you cannot transport or transplant that lung to another person again. So that's that about Burkholderia cepacia. Moving on to Bordetella pertussis. Bordetella pertussis is part of the Cucubacilli. It is a gram negative rod and a gram negative Cucubacillus rather. And we said it has the two toxins, the trachea cytotoxin and the pertussis toxin. And we said that the pertussis toxin majorly helps for you to what? Anybody remembers? What does it do?
It inhibit the G1.
GI.
Yes.
Guy.
So to
Increase
what is
GI.
going to be the end goal?
Increase cyclic AMP.
AMP.
Cyclic AMP. Yeah. So that it can what?
Increase sodium and chloride, phagocytosis.
Exactly. So don't get distracted and be talking about water. It is to prevent phagocytosis, evade phagocytosis. What is going to be causing the major damage is going to be tracheal cytotoxin. The tracheal cytotoxin is going to be causing the major damage. The pertussis toxin is just there to just take care of the phagocyte. And it does that by disabling the G1 subunit. And we have three phase. We have the catarrhal phase, the paroxysmal phase, and the convalescent. So catarrhal phase, they're just having like sneezing, low grade fever, coryza, runny nose, all those things. And then moving on to the paroxysmal phase, where they start having the cough and the inspiratory. So the cough doing expiration, then doing inspiration, the whoop, and that is usually followed by vomiting. So when they cough, they usually vomit afterwards. The positive vomiting. Then in the convalescent phase, you have a gradual resolution of the symptoms, particularly the cough. Now, how do you prevent it? You prevent by giving the DTaP or the TDAP. Now, the difference is just talking about the dose intensity. So in the capital DTaP, consider everything is capital. Diphtheria, tetanus, and pertussis. We give this to people that are like what's this stuff now? So people that are less than 7 years, they take the DTaP. But if somebody is more 7 or more, they take the small one, which is a Tdap. So that's the way you give it. So you can give both of them for primary immunization or for booster dose for what's it called, tetanus or majorly tetanus or all these pertussis too. You can use it. So, but there's a age limit to that. So the one that is bigger, use it in people with smaller age. While the one that is smaller, use it in people with what's it called, bigger age. So 7 is the cutoff. So what is something you cannot forget? They can ask you high yield, very high yield. But Patella pertussis is the only bacterial infection that causes lymphocytosis. I don't know why. It's just what it is. So a typical bacterial infection should be causing neutrophilia or high neutrophil count. But Patella pertussis causes what's it called? Lymphocytosis. How do you treat macrolides? Macrolide is the mainstay of treatment. Macrolide. Anything that involves chest infection, always remember your macrolide. If allergic, you can try your Septrin. Septrin also works for which infection that we talked about today? SNAP. Which infection?
Gonocardia.
Myocardial.
Nocardia. So, Brucella is not very high yield. It's not very, very high yield, but just know that it comes from animal products, unpasteurized milk, and it can survive in the macrophage of the reticuloendothelial system and can form granulomas. And they present with like fever, night sweat, and arthralgia. And you treat with the DRS, with doxycycline, rifampicin, and streptomycin. Brucella is not very high yield. Legionella is very high yield. You cannot go to your exam and you don't know how to make diagnosis of Legionella, or you don't know how it presents. It's very dangerous. So Legionella is one of the gram-negative rods. And when we're talking about silver staining, we said always remember Legionella and what?
Fungus.
And the fungi. So
Fungal.
you use silver stain to stain for Legionella and the fungi. That was the first point. So stains poorly. Use silver stain. Use silver stain. It also grows on CIC, which is charcoal yeast extra and iron and cysteine stuff. So for all the hellers. But most commonly they usually do like a serum antigen test, or they test for the antigen in urine. They look for the antigen of this Legionella commonly. And you cannot forget the fact that Legionella is associated with hyponatremia due to SIDH. You cannot forget that. You cannot. No problem. No way you can forget it. So it can elevate the transaminases, but this is more important. Hyponatremia. Hyponatremia is more important. How do somebody develop this Legionella? Just be looking for source of water bodies anywhere. Either the person is, swimming in hot water, is very close to hot water tanks, or the person is cruising on ships, or they are working in some nursing homes. Outbreaks can happen there, but it's very common in people that work in office because of the air conditioning systems and maybe hot water tanks because it's water loving. So there is no person-to-person transmission. So it does not get transmitted by sneezing. There's no person-to-person transmission. So just like pertussis, you can also treat them with the macrolide. But if macrolide is not available, give them the quinolone. So don't forget the Legionella disease. That's a severe form of pneumonia from Legionella. And what are you going to see in the question that's going to raise your suspicion? Number one, they will tell you that the person is coughing. And the next thing you want to ask yourself, is this cough productive or not? People with Legionella pneumophilia have a form of atypical pneumonia. The typical organism is strep pneumo, H. influenza, and maybe CLEB. Any other one is atypical. And when they cause pneumonia, the cough is usually non-productive. That's a very important clincher for you. So they will tell us that the person is coughing and the cough is non-productive. And in addition to that chest infection, you are seeing GI symptoms and neurologic symptoms. That is Legionella until otherwise proven. Quote me anywhere. That is Legionella until otherwise proven. It is Legionella until otherwise proven. So, GI problems, fever, pneumonia-like presentation, and CNS issues. Just go and pick your Legionella and you move. So it's very common in people that are old, people that have a chronic lung disease, or people that are smoking. So Pontiac fever is a mild form of Legionella. It just have mild flu stuff. So Old people, smokers, CLD people, people that have chronic lung disease, they can easily develop Legionella infection and have problems. So yeah, so that's that about Legionella. Don't ever forget uh the 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 presentation in terms of the fact that affect the GI and the CNS. So somebody having nausea, vomiting, diarrhea with pneumonia, chest pain, cough, fever, rule out Legionella. And the cough is now non-productive, rule out Legionella jejely. So it causes a lobar pneumonia, and that is like what we are looking at here. So don't forget the treatment, macrolide and quinolone. There's a lot of story under Pseudomonas. Pseudomonas is is a big guy, causes a lot of things. So Pseudomonas is aerobic, it's motile. All this information is not very, very important. The major information to just remember is just write your LOS. So LOS, the lactose fermenters, we already know them, CLEB and the E. coli for the fast, and for the slow, we have the Citrobacter and the Serratia. Then the next is to look at oxidative positivity, because I know that Pseudomonas is going to be a non-lactose fermenting agent, so it's already here. And the next thing is to look at the O, are you oxidative positive or not? Yeah, Pseudomonas and Burkholderia are partial oxidative positive. So it is here. And it's commonly found in water. It's commonly found in water, and it has a grape-like odor. So what are the things that Pseudomonas can cause? Pseudomonas for the P can cause pneumonia. So the acronym is the name. It can cause sepsis. It can cause ecthyma granulosa, which is a form of a necrotic skin lesion that's very common in people that are immunocompromised. So you see this. Once you see a necrotic skin lesion like this, the question describe it to be a necrotic skin lesion in someone that is having immunosuppression. And the culture maybe gram-negative bacteria, that this is likely to be Pseudomonas or otherwise proven. So that is ecthyma gangrenosum. Can cause a UTI, Pseudomonas. It's a very common problem in people that are diabetic, just like CLEB. CLEB is very common in people that are diabetic. Pseudomonas is also common in them. It can cause osteomyelitis. It has a mucol polysaccharide capsule. It's part of specs. It's a P in specs. It's a cause of otitis externa. Oh, you cannot forget this. There's no way we can go for exam and we don't know that Pseudomonas is a cause of otitis externa. So they will tell you that the person is having some hair pain, especially when you are manipulating the hair, the tragus. This is otitis externa until otherwise proven. It's a serious problem of nosocomial infection. So when we're talking about Pseudomonas, we said it is a cause of ventilator associated what? Anybody remember ventilator associated what?
Pneumonia.
Pneumonia.
Yeah.
So that's why healthcare problems,
Okay.
like equipment, like ventilators, and also in catheters. So it's a problem with people with addiction. So people that use high injection drugs, they're susceptible to three major organisms: Staph aureus, Pseudomonas, and Candida. Infective
Candida.
endocarditis. You can't forget. There's no way you can go for exam and you don't know that three things. It's very dangerous. So they can cause skin infection, like hot tub folliculitis. So they tell us that somebody is swimming in the hot tub and started having some erythematous lesion in the skin afterwards. Think hot tub folliculitis and the implicating organism in. You can never be wrong. Just shade your Pseudomonas and you move. And it's a very common cause of problem in people that develop burn injury. So they can develop wound infection from Pseudomonas. So you have to get like all the silver nitrate and likes to just prevent infection. Um, so what are the virulence factors? We have talked about the fact that it has a polysaccharide capsule, and it can contribute to the reason why it causes chronic pneumonia in people with cystic fibrosis is because of the biofilm. So Pseudomonas can cause biofilm. When we're talking about the biofilm of Pseudomonas, we said it can cause biofilm with the ventilator-associated stuff. We said it can cause biofilm with people that use contact lens. Do you remember contact lens keratitis? It is
Yes.
Pseudomonas until otherwise proven. So the virulence factor includes the PEEP. So the P for the phospholipase C, that helps it degrade cell membranes. So that's why it can lyse cell membrane, phospholipase C. It has E, which is an endotoxin for why it can cause septic shock. It has exotoxin A, and that's the reason why it inactivates elongation factor 2. Exotoxin A, which is the reason why it inactivates elongation factor 2 alongside with its close buddy, which is Corynebacterium diphtheria. And it emits some pigments like pyovadine and pyocyanin. So don't forget, it can cause corneal ulcers and keratitis in people wearing contact lens. We've talked about ecthyma granulosa. You cannot go for your exam and you don't know any of the anti-pseudomonal drugs, because you might get stuck at the stage that you make your diagnosis to be pseudomonal, and the next thing they will be asking us is, what is the treatment you want to give that person? So we have to be familiar with the anti-pseudomonal drugs. And the commonest everybody knows in this world is piperacin, tazobactam. So very common drug. Piperacin, tazobactam is the major anti-pseudomonal penicillin. In fact, that's what they call it. They call it anti-pseudomonal penicillin. It's very specific for pseudomonas. Then don't forget any of the third or the fourth generation cephalosporin, ceftazidime, commonly they talk about this a lot, and cefepime, two of them. The monobactams, fluoroquinolones, of course, these ones are broad spectrum. So your carbapenems and although aminoglycoside also have some anti-pseudomonal activity, but you don't use it because it does not work very well in acidic environment. And one thing about pseudomonas is that pseudomonas thrives in an environment that is acidic. Which other organism can we not use aminoglycoside against?
The
Anaerobes.
Anaerobes.
Yeah, anaerobes.
Okay. Should we this is 4 o'clock
Yes, break.
my own time.
Yeah,
Please, I want to ask, is it possible,
it's 5:10.
can we reconverge maybe in the next 4 hours? Is it possible?
Again?
4.
How many?
4 hours. Yeah. So Salmonella and Shigella are quite very, very similar organism. And the first thing I'm going to mention is just their characteristics. So both of them are gram-negative rods, just like we know. And they are both non-lactose fermenters. We should not forget the LOS. So these guys are the last spectrum. So LOS, the lactose fermentation, the oxidase positivity or negativity, and the last is the H2S production on the TSI medium. So they are non-lactose fermenters. They are oxidase negative, but one of them, can produce H2S, which is Salmonella, why Shigella does not produce ATS on H2S, which is the hydrogen sulfides on this TSI medium. Both of them can actually invade the GIT tract. So this is important. Both of them can invade the GIT tract and cause the dysentery. They can invade the GIT tract and cause dysentery. And it's important for us to also know that they gain entry into the gastrointestinal tract through the hem cell. They are also called as the microfood cells of the Peyer's patches. So they are just cells that help to process antigen or microbes and present them to the nearby lymph nodes for immune recognition. That's what they do. But this Shigella and Salmonella enters the Peyer's patch through these microfood cells, and from there they gain entry into the gastrointestinal mucosa, and they start causing whatever damage they want to cause. So these are the factors that differentiate them. We just take them one by one. We have the Salmonella typhi, and we have the types that infect humans and animals, which is Salmonella paratyphi usually. That's the common one. We have so many of them, but the ones that is common is the Salmonella paratyphi. Just talk about any species of Salmonella except the Salmonella typhi. So Salmonella paratyphi is a very good example, and of course the Shigella. So the reservoir for the Salmonella typhi is only human. But for the other ones, aside the Salmonella typhi, like the paratyphi, for example, they affect both humans and animals. While for Shigella, it only humans too. So just focus on the ones that are important. For the spread, Salmonella spreads through the blood. That's the way it spread. But for Shigella, it moves from cell to cell, just like Listeria. If you remember what we talked about Listeria, beating its actin filament, moving from cell to cell. So Shigella can invade by moving from cell to cell. It doesn't spread to the blood. So we have talked about this. Salmonella can produce hydrogen sulfide, but Shigella cannot. Salmonella is flagellated, so it's multi. Salmonella is multi, but Shigella is not. For the virulence factor, all of them produce endotoxin. They are gram negatives. All of them produce endotoxin, but some of them are further encapsulated, and that's Salmonella typhi. So Salmonella typhi has a V high capsule. So that's the characteristic capsule that is present on the Salmonella typhi species. We call it the V high capsule. Why the other form of Salmonella is not encapsulated, and also Shigella is not encapsulated, but Shigella also produces the Shiga toxin aside the endotoxin. So the Shiga toxin is an exotoxin. We should not forget that. The Shiga toxin is an exotoxin, while the endotoxin is a normal endotoxin that will cause shock. So, and we should not forget the way the Shiga toxin work. What is the mechanism of action of the Shiga toxin? Anybody remember?
Inhibit the 60S.
Inhibit.
Remove
60S ribosome.
Thank you. Inhibit the 60X ribosome by removing adenine. Don't forget that. So very important stuff. And always we should separate it in our heads, the exotoxin from the endotoxin. So what about the infectious dose? So the infectious dose of Salmonella is very high. That means that it is susceptible to destruction from the gastric acid in the stomach. So that means that we actually need a very high inoculum of Salmonella to cause infection, because it is readily destroyed by the acid of the stomach, as opposed to Shigella that is acid resistant. It is stable to acid, so you need a very low dose of Shigella to cause problem. So what about the effect of antibiotics on fecal excretion? So the way I want us to look at this is just to have it at the back of our mind that Shigella is not dependent on any normal flora to survive. It's just there on its own. But Salmonella, in a way, its activity is regulated by the normal flora. So if there is the use of antibiotics, these antibiotics in a way can um, can kill off those normal flora and can allow Salmonella to proliferate. Why? Because Salmonella number one is another organism that is intracellular, so it can stay inside those neutrophils or macrophages, the monocyte usually the macrophages, and can hide. Why the antibiotics will be penetrating those normal flora and be killing them. So there is a very large breeding space for the Salmonella to proliferate. So the use of antibiotics kind of prolong the duration of infection, particularly fecal excretion of this Salmonella, because it's going to thrive well. So except you use some specific antibiotics, to penetrate it. So that's the way I put it in my mind. So same for the paratyphi, then for the Shigella, it shortens the duration, because once you use the antibiotics, it kills it straight. And again, if you also use the antibiotics for Salmonella, you kill off the normal flora. This Salmonella can easily go to the gallbladder again and camp there. So Salmonella has a camping effect on the gallbladder. Don't forget, there's a colonization of gallbladder by Salmonella. So it hides in the gallbladder. So people can be a carrier of Salmonella because it can be present in the gallbladder. What about the immune response? So most of the time, Salmonella in the monocytes, but for the animal, for the other ones like the paratyphi, it's the neutrophils, and also Shigella is neutrophils. That's not very high, it's not very high. How do they present? This is what we need to know. So most of the time, Salmonella, they present with constipation. They present with constipation due to hypertrophy of this Peyer's patches. So when there is the infection and there's hyperplasia of this Peyer's patch because of the rigorous inflammatory response that is mounted against that Salmonella, the Peyer's patches becomes enlarged. There's a lymphadenopathy. So that can, because the Peyer's patches is kind of located in the small intestine, that can further narrow the lumen of that small intestine that is already narrowed and can allow for constipation. Then after some time, when it's cleared, diarrhea happens. So just imagine that you have fecal matter stuck in an obstructed area. Then when the inflammatory response subsides, the place opens up again and allow the fecal matter to pass through. So that's where I want us to see the presentation of salmonella causing constipation, then followed by diarrhea. So, but for salmonella paratyphi and the other ones, they usually have this bloody diarrhea only. Why for Shigella? There's no way we forget this. They usually have a crampy. That's the way the question will put it. You will see it like that. The abdominal pain is going to be crampy with bloody mucoid stool. So once you see somebody having crampy abdominal pain, bloody mucoid stool with tenesmus, that is, the urge to defecate is always there. They would go to the toilet now, they would try to move bowel, but in little time again, they will feel that they've not done anything, that they want to do more, and they will try again and nothing will come out. That's tenesmus. Classic for shigellosis. So once you are seeing that, think about a bacillary dysentery from Shigella, crampy abdominal pain, tenesmus, bloody mucoid stool. You can't miss it. Shigella. That's Shigella. That is a triad of Shigella. So what about the vaccine? We have an oral vaccine for salmonella, which is the live attenuated vaccine against the organism, and also we have the IM vaccine that contains just what's it called, an antigen against this capsular polysaccharide. So you just obtain this VI capsule polysaccharide. That's the high end one. Why the oral one is just the whole organism that is attenuated. That's the oral one. Why the high end one is just a portion of the polysaccharide. This VI capsule it's just equivalent to the PPSV23 of strep pneumo. So high M is just containing the capsular polysaccharide, while the oral one is containing the whole organism body attenuated from. There's no vaccine for the paratyphi. There's no vaccine for Shigella. There's no vaccine for Shigella. So don't make that mistake of picking any vaccine treatment for Shigella. So what about the other features? So you don't ever forget the salmon colored rash. So I don't want to mention it here, so that I want us to be seeing it as I'm saying it. So you cannot forget the salmon colored truncal malar rash. So they call it the rose spot. The rose spot. Let me see if there's a way we can check it out online. The rose spot. The rose spot of so this lesions here. So something like this, this kind of maculopapular rash in a way. That's the way it looks like. Although from the history, you will have gotten an idea of what they are talking about, because they will start talking about the person having this fever, having bloody diarrhea, alternating with constipation and constipation, diarrhea alternating together with this rash, this rose spot. So this is a better one. Once you see this, just think about salmonella infection. So that truncal malar rash with abdominal pain, of course, there will be abdominal pain, the fever, and there is a pulse temperature dissociation. So ideally, there should be like a 10 beat per minute rise in the pulse per 1 degree Celsius rise in temperature. So as the temperature is rising by 1 degree, you expect the pulse to rise by 10. But that relationship is dissociated. So you don't have the pulse temperature relationship. So you have like a form of relative bradycardia, with typhoid fever. So we should pay attention to that. I think they call that faggot sign. I'm not too sure now, forgotten, but that's the idea. So the temperature is going to be very high, but then you just notice that either the pulse is normal or it's low. So most of the time it's going to be low. So don't forget about that. And of course, there's GI invasion. Both of them invade the GI mucosa, so they can cause ulceration and hemorrhage. So you treat with ceftriaxone or fluoroquinolone, especially the people with the carrier state. So you have to treat them with ceftriaxone and fluoroquinolone to eliminate that gallbladder colonization. Ceftriaxone and fluoroquinolone. So for the paratyphy one, they get it from animal products usually. Poultry, eggs, birds, tortoise, and all those things. Those are the source. So you just treat it supportively. Don't give antibiotics. Don't give antibiotics. This one can be transmitted from maybe human contact. Like on sorry about that. Sorry, somebody is trying to enter. I think we have to speak with the IT one. Okay. So sorry. Just want to attend to. Okay. So, where are we?
Babawale.
Hello?
Dr. Babawale.
Yes.
Yeah, I lost you when you went back and forth in the diarrhea thing. When you showed us the picture of the rash, which one is it?
Yeah. So this is a rash. This
Rash of which one?
Salmonella
Salmonella.
typhi.
Okay. Then you said something about constipation diarrhea, which occurs in salmonella, but you said something about bloody again. So which one does the bloody diarrhea that has the rash at the same time?
So all what I've been talking about is peculiar to Salmonella typhi. The only
I didn't
thing,
hear you because you were breaking.
really? Wow. Oh, sorry
Okay.
about that.
Can you?
Okay. But can you hear me well now?
Yes.
So the one I was talking about is Salmonella typhi. So I said
Okay.
that it can cause constipation, alternating with diarrhea, and I
Mm-hmm.
explained when I was talking about the Peyer's patches. And
Mm-hmm.
I also said, in addition, they can have this salmon colored truncal rash, which we call the rose
Okay.
spots. The rose
Mm-hmm.
spots. Then I also talked about the fact that they can have a fever, but the fever is associated with a pulse temperature dissociation. Because
Mm-hmm.
ideally, when we have a 1 degree Celsius rise in the temperature, we should have a pulse rising by 10 beats per minute.
Mm-hmm.
But that association is lost. So you can have a fever of like 38, 39 degrees Celsius and the pulse will still be 50 or the pulse is 55. So that's
Mm-hmm.
also in keeping with salmonella infection.
Okay.
And I just said the only thing you just need to take home here is just watch out for the constipation alternating with the diarrhea. Watch out for the fact that the diarrhea is going to be bloody. Watch out for the
Okay.
rash, which is the
So the
rose color.
diarrhea will still be bloody in the Salmonella typhi, not in the paratyphi, because in the books, yeah, I'm reading, it didn't say bloody diarrhea. I just want
It's
to
going
know
to be,
which one.
see, Doc,
Huh?
you don't need to worry yourself. Salmonella will cause a bloody diarrhea. They call it dysentery.
No.
It's not even that's don't worry yourself about what is in the book. I'm not really using this. I'm not even saying what they have here. It's
Okay,
what you are
so
going to see in
both
the book.
Salmonella period, both
It's
Salmonella
going to be
typhi
bloody.
and the paratyphi will have bloody diarrhea.
Yes. The only one
Well,
that might be possibly bloody or not is the paratyphi. That's the one they are even doubting. But with respect to Salmonella typhi, the one that happens in
mm,
human, it will be bloody.
mm,
It's a cause of
it will be
dysentery.
bloody. Oh,
Why?
thank you.
Why? Because it's going to cause GI ulceration. And there'll be what?
Mm,
Hemorrhage.
mm,
So
yes.
it
Okay.
will be bloody. It will be bloody. So for the paratyphi, that's one that can be bloody or might not be bloody. And most of the time, you will not get a question of paratyphi because it's not very, very common. So, um,
Okay.
um, So that's that. So the treatment is basically supportive for the the paratyphy one, and antibiotics are not usually indicated in people that are immunocompetent. So, but Shigella, I've talked about Shigella in terms of the fact that the reservoir for Shigella is also human. It does not disseminate hematogenously, cell to cell. Don't forget cell to cell movement, and it does not produce H2S when we're talking about the LOS algorithm. So we said Shigella and Salmonella are the last one, but Salmonella is a salmon, so it can produce fish odor, blah blah blah. When I was giving that link, so fish odor, H2S, which smells fishy, and also what's the other one? Proteus, which also smells fishy. So both of them are going to produce H2S when they are cultured on TSI Hager, some Shigella and Proteus. Then I talked about the fact that Shigella is not flagellated, unlike Salmonella. So Shigella is not motile. Shigella has both the Shiga toxin and the endotoxin. I talked about the fact that you need a low inoculum of Shigella to cause the infection. Why? Because Shigella is resistant to the gastric acid, so the acid cannot destroy it. So a low amount is enough to cause a problem. I talked about the fact that antibiotics can easily penetrate the Shigella, and Shigella the duration of the infection can be shortened with the use of the antibiotics, and it primarily infects the mononuclear cells like neutrophils. And we talked about the triad, which is the crampy abdominal pain. We talked about the tenesmus and the bloody mucus too. This is the way it's going to be presented in our exam. The crampy abdominal pain, the tenesmus, and the bloody mucus too. Just wait and see. You will see it. So don't forget the fact that it lacks the vaccine and also the means of transmitting the infection, the Fs. So the fingers, the flies, the food, the feces. So fecal matter, contaminated food, flies, settling on this food as well as fingers. So people that don't wash their hands properly after going to the toilet and all those things, they can easily transmit the infection. So similar to Salmonella typhi here too. So contaminated food and water is a common source, of transmitting this. Why the paratyphi usually comes from eating, poultry, eggs that are not properly clean, or coming in contact with some pets and tortoise. So these are the specific species of the Shigella in terms of their severity. So dysentery is the commonest one. Then we have the flexneri, the boidy, and the sony. Nobody's going to ask this. Nobody's going to ask this. So the most important thing is just remember that they all invade the M cells, which is the key to pathogenicity. They invade the microfood cells of the small intestine. They gain entry into the Peyer's patches. They attack the immune cells there, the macrophages, everything there. They replicate, or the neutrophils, and they start replicating. And from there, they burst out and gain entry to the mucosa properly, which they invade, and they release their toxin, which is the Shiga toxin, that will now, inhibit the protein synthesis that we have talked about and destroy the GI mucosa. You don't need to remember that pathway like that. Just always remember that if they want to enter that gastrointestinal tract, just keep the information simple. The reason why I'm explaining like this is just so that you just have an idea, but keeping it simple, the most important thing is to remember that they invade the macrophage cells. That is what they invade. They invade that to gain entry into the GI tract and release their toxin. So macrophage cells is not something we should forget. So moving on to Yersinia enterocolitica. So this is one of those gram negatives, and it's very similar to like Campylobacter jejuni. Both of them, they are very, very similar. When we get to Campylobacter jejuni, we'll see the similarity. So it's transmitted usually from exposure to pets, to fecal matter of the pets, like the cats and the dogs, or from contaminated milk. So don't forget, Yersinia is gotten from people that come in contact with the fecal dumpings of the cats, the dogs, as well as contaminated dairy products like milk and sometimes pork. So let's just put it here like fecal matter of cats, dogs, pork meat and contaminated milk. Yersinia can come from there. What is peculiar to Yersinia? Yersinia is not a cause of watery diarrhea. Yersinia will cause bloody diarrhea. Bloody diarrhea. So if you look at all the diarrhea we have been talking about, we talked about cholera causing rice water, which is watery. We talked about Bacillus cereus causing watery diarrhea. We talked about Staph aureus, which is the enterotoxin of Staph aureus causing watery diarrhea. But with respect to bloody diarrhea, you want to remember Salmonella. You want to remember Shigella. You want to remember Yersinia. These are bloody diarrhea. So if you have this at the back of your mind, you can easily be ruling out all those options that this cannot cause a watery diarrhea, this cannot cause a bloody diarrhea. And again, because of the fact that Yersinia replicates in the lymph nodes, the terminal ileum lymph node, the Peyer's patches of the terminal ileum, as well as the mesenteric lymph nodes, causing mesenteric adenitis, it can mimic appendicitis. So we call that pseudo appendicitis. Pseudo appendicitis. So and that will lead to a presentation of a right lower abdominal pain. So people with Yersinia can have right lower abdominal pain due to mesenteric adenitis, that's inflammation of the mesenteric lymph nodes, as well as inflammation of the Peyer's patches in the terminal ileum, causing terminal alitis, presenting with right lower quadrant pain, which is very similar to what we have in appendicitis. So that's Yersinia for you. So a patient having bloody diarrhea, having a right lower pain. So of course, we don't expect appendicitis to be associated with bloody diarrhea. So once we are seeing fever, right lower abdominal pain, bloody diarrhea, and the person may be a farmer or something, that this is like to be Yersinia enterocolitica. And if they want to be generous, they can add features of reactive arthritis. Anybody wants to remind us the triad of reactive arthritis?
Conjunctivitis.
Conjunctivitis.
Can't see, can't pee.
Arthritis.
Can't see, can't pee,
Can't see, can't walk.
Okay,
can't go
yes, I think that's it. Can't see, can't pee.
Urethritis.
Exactly.
Arthritis. Yeah.
Can't see, can't pee have solved the problem. So lactose fermenting enterics. So lactose fermenting enterics, we talked about this during the classification of the gram negative. I think so far so good now. Maybe the classification of the gram negative is like the simplest, because once you have your LOS, you have solved everything. So the lactose, just want to remember the major ones, which are the fast or the slow. So we said in the fast we have 3, which is E. coli and the twin brother of E. coli, Klebsiella, and the third one is what? Enterobacter. Those are the fast lactose fermenters. So it means that once you put these guys on the McConkey agar, you see your pink colonies quickly. So that's how you know something is a lactose fermenter. Once you culture on the McConkey agar, you see the pink colonies, you can say that this is a lactose fermenter. While we have the slow one, which includes Citrobacter and the Serratia. So Citrobacter and Serratia, they are the slow fermenters. But everything here would form the pink colonies, but they can just be faster than each other. And if you want to segregate E. coli from this family, you just put it in the eosine methylene blue agar, EMB agar, and you watch out for a green metallic sheen color. So once you see your green metallic sheen, you know that, oh, this lactose fermenter is actually E. coli. So EMB agar is specific for what's it called, for E. coli. So moving on to E. coli, we cannot go for an exam and we don't know anything about E. coli. That is impossible. E. coli is very, very important. We must know it by force, by fire. So let me see what is here. An 8-year-old boy is brought to the emergency department because of a 4-day history of severe left-sided hair pain and purulent discharge from the left ear. Okay. 1 week ago, he returned with his family from an annual summer vacation at the lakeside cabin, where he spent most of his time outdoor hiking and swimming. Examination shows a tragal tenderness and a marked edematous and erythematous external auditory canal. Audiometry shows conductive hearing loss of the left ear. Which of the following is the most likely cause of this patient's symptoms? Anybody?
Pseudomonas.
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 otitis
external,
External.
External.
Swimmer's
ear.
So for E. coli, it's a gram negative. It is indole positive. Very important. And it has some certain virulence factors. So this one has some virulent factors we've not talked about. And number one is the fimbriae. Don't forget the fimbriae is for what? What did we say the fimbriae is? It is
Attachment.
for attachment. Thank you.
attachment,
The fimbriae is for attachment. And the fimbriae of E. coli is specifically called the P. pili. Please don't get confused. It's just the naming. We call it the P. pili. And that is the mechanism by which it can cause cystitis and pyelonephritis. This is where the USMLE would wait for us. So they would give us a presentation of somebody that has pyelonephritis, coastal vertebral ankle tenderness, fever, frequency, urgency, and they will tell us the culture, the gram negative, rod that is indole positive. And the next thing is which virulent factor is responsible for this. That's it. So you have to first know the diagnosis to be pyelonephritis. You have to identify the cause to be E. coli. Then you now say, okay, so what virulent factor of E. coli can allow for cystitis or pyelonephritis? That is a fimbriae. With the fimbriae, which is a P. pili, it can attach to the uroepithelium of the kidneys or the bladder, causing cystitis and pyelonephritis. E. coli is a common cause of neonatal meningitis, alongside with which organism?
Listeria.
Listeria,
Aside listeria, which other organism again can cause neonatal
group
meningitis?
Group
Adalid.
Group B.
Group
Exactly.
B.
Group B.
Adalate.
Yeah.
A. galati,
Group B.
Strep
A.
Adalate.
E. galati, E. coli, and listeria.
Listeria.
area,
The three of them,
Listeria
Listeria
monocytogen.
meningitis. And don't forget which drug we are going to add. Somebody with listeria. What drug are we always adding for the meningitis?
Ampicillin.
We will add
Ampicillin.
ampicillin. So E. coli causing pneumonia, causing meningitis, because it needs to be able to escape the alveolar cells of the lungs. It needs to be able to escape the microglia of the brain to cause this true infection. So it needs a capsule to evade the phagocytosis. So that's why the K capsule comes into play. So if they put a picture of somebody having meningitis or pneumonia and they ask what virulent factor, that's not the time to be picking pili, because it's not going to be attaching to the meninges with the pili. It doesn't need to attach. It needs to be able to escape the alveolar, macrophages as well as the microglia by, utilizing its K capsule. Don't forget that E. coli is also encapsulated. So the last is the helpers endotoxin to cause septic shock. This one is common knowledge. We all know it. So what are the different strains of E. coli and what is peculiar to them? The first is the enteroinvasive E. coli. Enteroinvasive. This can invade the intestinal mucosa and cause necrosis and inflammation. It is as simple. Keep it short and simple. Invade, necrosis, and inflammation. And that will lead to what? Dysentery. That is the only take home you need to pick. Bloody diarrhea. You move. The clinical presentation is very similar to Shigella. But trust me, there will be some stuff in the question that they will put there to separate them for us. So, enteroinvasive. Invade the mucosa, cause necrosis, inflammation, and bloody diarrhea. The next one is enterotoxigenic. We have talked about this in the morning. I said it produces two toxins, the eat labile toxin and the eat stable toxin. Just as a reminder, the eat labile toxin overactivate adenine cyclase, leading to increased CMP. And the increased CMP is going to let chloride out, and water will follow. Why the eat stable is going to increase guanylate cyclase activity, increase CGMP, which is going to what? Which is going to prevent what's it called? Which is going to stop from the hairs, which is going to stop chloride from being reabsorbed from the GI into the cell. So that means that you have chloride and water in the GIT lumen causing the diarrhea. Don't forget that the diarrhea is going to be watery. It's going to be watery diarrhea. And it is a common cause of traveler diarrhea. So they will tell us that the person is actually traveling in between countries. somebody is traveling between country and drank some form of water that is containing this E. coli, they can develop watery diarrhea. So have that at back of your mind, and don't forget that there is no inflammation, there's no tissue invasion, and that's why the diarrhea is not what? It's not bloody. Keep it short and simple. The enteropathogenic E. coli, no toxin is produced. It just adheres to the apical surface of the epithelial cell, flattens the villi, and prevents absorption of electrolytes. That is what it does. So this is a very common cause of pediatrics diarrhea, very common in pediatrics. So you just want to do your supportive treatment and the person is going to be okay. So no toxin is produced. No toxin is produced. It does not invade. It just adheres to the apical surface, blunts the villi, and minimize absorption. The next is the enterohemorrhagic. We have talked about this. Release the sugar toxin, the OH157H7, which is very common by taking undercooked meat. Please, if there's a way, if there's somewhere we want to scribble this in our room, write it there. Or you will see it in your exam. I'm telling you, undercooked meat or raw leafy vegetable. That it cannot pass these two that they will ask you. But most importantly, they like this undercooked meat. So if you see your friend telling you, blah 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 blah, they ask about undercooked meat. What do you think is it? Yeah, it's going to be E. coli, enterohemorrhagic, undercooked beef, undercooked meat, and raw leafy vegetable. That is the source of enterohemorrhagic E. coli. So maybe other people eating burger, they could have been served undercooked meat. That's why they have this outbreak that year in the US. So undercooked meat is a source of enterohemorrhagic E. coli, and it releases sugar toxin. What would the sugar toxin do? It is going to inhibit the protein synthesis by affecting the cysteine ribosome, and that is going to affect the endothelial cells. When there's affectation of the endothelial cells, and there's endothelial cell injury, there's going to be inflammation, and from there could be activation of the coagulation cascade, because the endothelium, once it's damaged, that means that you activate the activation of the coagulation cascade, and you start forming different thrombi, microthrombi in the vessel. And when the red cells are trying to pass through that narrow vessel occluded by the microthrombi, they become sheared up. When they become sheared, what do you see on peripheral blood cement? Anybody?
Schistocytes, helmet
Schistocytes.
cells.
So I had to hide it. That means our hematology knowledge is still there. Don't forget it. Schistocytes. And we remember the way it appears on the slide. We have to pay attention to it. You see somebody with DIC, you see schistocyte. Aortic stenosis, you see schistocyte. Microangiopathy from any cause, for example, HUS, you see schistocyte. That is the indicator of the anemia that they're having. And of course, the microthrombi is also going to occlude the vessels of the kidneys, leading to AKI. And of course, from the coagulation pathway, there's consumption of the platelets, leading to thrombocytopenia, which is renal blood flow. So don't forget that. Try the fever, bloody diarrhea, with penta of fever with bloody diarrhea, with thrombocytopenia, hemolytic anemia, and AKI. Your diagnosis is what? Hemolytic uremic syndrome, until otherwise proven. So, that is so people, very common people that take hamburgers. Thank God it's here. I don't even know it's here. Hamburgers. Don't forget hamburgers and dysentery, because the hamburgers will be the source of the undercooked meats. That's the way it works. And I think some of the hamburgers also have some vegetables too. So double dose. Moving on to Klebsiella. Klebsiella is very important in two major organisms, in two major categories of people. What are these two categories of people? Diabetics, it's here, diabetics, and people with alcohol use. You cannot forget this. Somebody is taking alcohol, the person is diabetic, the person is joking with Klebsiella infection until otherwise proven. It's also common in people that have impaired immunity too. But the two common risk factors include alcohol and diabetes. So what does it cause? It causes a lobar pneumonia. Klebsiella causes a lobar pneumonia. So this is a cause of typical form of pneumonia. In fact, pneumonia is going to be productive. You have pneumonia with cough that is productive. And don't forget that Klebsiella is a normal commencer of the intestine. So it means that if this person is taking a bad amount of alcohol, the person becomes sedated, confused, the person can easily aspirate from the intestinal mucosa. And if the person aspirates from the stomach into the airway, there's going to be what? Aspiration pneumonia. With Klebsiella being the cause of the pneumonia. So Klebsiella is a very common cause of abscess in the lungs because of that. And at the same time, it can also form abscess in the liver. So, because of the aspiration pneumonia, lung abscess can follow, can ensue, and also, they can also develop that abscess also in the liver. The color of the sputum have this blood mucoid staining. Blood mucor staining. So blood mucor staining of the sputum, and that's what we call the red currant jelly sputum. So who remembers the color of the sputum of strep pneumo? Anybody?
Rusty colored.
Rusty color.
You just tell people rusty. Is it sputum rusty? Oh, strep pneumo. With red currant jelly, that is likely to be clear. So, and don't forget, it is heavily encapsulated. It is heavily encapsulated. That's why it appears mucoid like this. It is heavily encapsulated. I think those are the points I want us to hold on to in respect to Klebsiella. Also, moving on to Campylobacter jejuni. So, I talked about this guy being similar to somebody with Yersinia enterocoletica. It is a gram-negative too, and it is part of the comma-shaped one or the cuffed one. And we said that it has a tendency to grow at a very high temperature at 42 degrees Celsius. And one thing that is common to the three cuffed organisms, which is Vibrio, Campylobacter, and Helicobacter pylori, is that
Helicobacter.
Yeah.
they
Yeah.
grow very
Oxidase positive.
oxidase positive. Thank you. Oxidase positive. So just like Yersinia, it can cause a bloody diarrhea. But the difference is that you see this diarrhea in children. Very simple. You already know what you are looking for. So they tell that there is a child that's having a bloody diarrhea. Is it a possibility of this child having Campylobacter jejuni infection? Yes or no? So they usually acquire it through fecal oral route, or sometimes person to person transmission. So it's usually fecal oral, or maybe there's consumption of contaminated poultry or meat. Just like in Yersinia, there's those ones are in contact with the fecal matter of cats, dog, pork, as well as unpasteurized milk. So unpasteurized milk too is here for Campylobacter, but it usually follows consumption of contaminated poultry or meat, not the fecal stuff. So, but if somebody also gets in contact with animals like dog, cat, pigs, they can also develop it. So, the risk factor kind of overlaps in a way. And don't forget that Campylobacter jejuni infection can precede development of Guillain-Barré. Don't forget this. I know Dr. Babandi will have mentioned this in the neuro section. So it's Campylobacter jejuni, and certainly there is the ascending paralysis, deep dental reflex problems and the likes. That this is likely to be Guillain-Barré, that we are talking about. Zika virus is another thing that can precede Guillain-Barré, and Guillain-Barré, we know the way it presents, and Campylobacter jejuni, just like Yersinia, can also cause a reactive arthritis. There's so many exhaustive list of organisms that can cause reactive arthritis. So, but what I just want us to hold on to here is that they can put two of these symptoms there and ask you to put in the third one. So that means you must be able to remember the trial at every point in time. Moving on to Proteus mirabilis. Proteus mirabilis. So this is a gram-negative guy, and if you follow the LOS, you can separate everything down like that. So it's going to be lactose. It's not going to be lactose fermenter. It is oxidase negative, but it is what? It produces H2S on TSI agar. And at the same time, it is also urease positive. You remember, urease positive. That's why it has the ability to form which kind of stone? It's Struvite stone. It's Struvite stone. and it has a long flagellae that allows it to swim. So it has a stop, like a swimming motility on the Hager. So because of its flagellae, it's one of the common causes of UTI, and because of the urease that it has, that has the ability to split urea into CO2 and ammonia. And we said that once they split this urea to CO2 and ammonia, which one diffuse out? Carbon dioxide, and it will
Mhm.
remain the ammonia. And we said the ammonia is going to combine with the magnesium and the phosphate to form what? The struvite stone. The struvite stone can even be so big that it might need surgery. So because of the struvite stone, the UTI is always very recurrent. So pay attention to that. Once you see somebody having a stone, maybe they show it on imaging or non-contrast CT, and we see the situation and they ask us which organism is responsible for this. Just look for proteus. You know, very, very important. Moving on to the vibro. The vibro is part of the corpse and it is vacuolated, comma shaped, oxidative positive that can grow in alkaline media. Yeah. So this is very common to developing countries like ours. And the way it works is that it overactivates the GS subunit, leading to increased CMP and secretion of chloride, water, everything like that. But just like Shigella, just like Salmonella, sorry, I almost made a mistake. Just like Salmonella, it is sensitive to the stomach acid. So we need a very large inoculum, of Vibrio cholerae to cause infection, unless this acid has reduced acidity. In which condition can the host have reduced gastric acidity that can favor Vibrio cholerae to set in? Anybody knows?
Use of PPIs.
It is as simple as that. So people usually get it through consumption of contaminated water or uncooked food. You don't want to forget this point. People that eat raw shellfish, they will ask you in your exam. They will put it there in your exam. You will not see water there, but you see shellfish. So somebody that is eating shellfish, like my brother, I pity you because there's a risk of acquiring vibrio cholera infection, and the person will just be going to toilet from time to time. But with ORS, the person is going to be fine. Just ensure you give the person the ORS. Then another organism that most people don't know is what? The vibrio unificus. It's just same as vibrio cholerae, same thing, but this one we find it in the marine environment. And what is peculiar to it? It has a very high tendency of causing bad wound infection. So if somebody has a wound and the person is now playing in marine, is playing in sea, is playing in ocean, salty water, this guy can easily come in and worsen that wound infection and sometimes even lead to sepsis. And it can even progress from normal wound infection to cellulitis. And from cellulitis, you can get to necrotizing fasciitis. But in which category of people? You don't want to forget. Category of people that this vibrophonicus thrives are people that have a very high serum iron. High serum iron. So people with high serum iron have a high risk of developing vibrophonicus infection. And those people include people with hemochromatosis and sometimes people with background liver cirrhosis. So anybody with liver cirrhosis, hemochromatosis, they have a very high risk of acquiring, they have a very high risk of developing severe complications when they get exposed to vibrophonicus. If they have an injury in any part of your body, it can worsen and progress to cellulitis and sometimes necrotizing fasciitis, which can be very bad, especially in people with high iron, people with hemochromatosis or liver cirrhosis. So somebody acquires it, you want to do a proper surgical debridement. Don't forget, once there's necrotizing fasciitis, you have to what? You have to debride. There's no way, there's no escape route, you have to debride. Somebody having tetanus, you have to what? You have to debride. Don't forget. So, and don't forget these underlying risk factors. Very, very important for vibrophonicus. Vibrophonicus. They usually say that high serum iron is important for 3 organisms: vibrophonicus, Yersinia enterocolitica, and Listeria. But me, I don't waste my time farming those two. I just majorly focus on the Bible purification. So, moving on to Helicobacter pylori. So this is a curved. We don't need to even learn all these things. We know them. It is catalase positive. We know that. It is oxidase positive. We know that. And it is a urease positive agent. We know that. And because of the fact that it's urease positive, that is the reason why you can use the urea breath test. Of course, once you get a portion from the stomach, you culture with urea, you expect the organism to release its urease enzyme to split the urea into CO2 and ammonia, and we expect the CO2 to be released in breath. So that means that our pH indicator that we put in this person's breath should read acidic pH. So that's how we can confirm the urea breath test. And we can also do the fecal antigen test. We obtain a fecal sample and we check for the antigen of this Helicobacter pylori, if it's there or not. These two tests, you must always pick them ahead of serology. Don't ever make the mistake of picking serology as a confirmed means of making diagnosis. In 100% of situations, one will be wrong. Always go for either urea breath test or fecal antigen test. Step 1, step 2. Don't forget it. Don't never pick serology. Don't fall for it. It's going to be wrong. So we already talked about how this urease produce ammonia, and that ammonia has a beneficial action because it helps it survive in the acidic mucosa. Just imagine Helicobacter pylori is colonizing the antrum of the stomach. How is it surviving? It's because it releases urease that is going to split the urea into ammonia and CO2, and the CO2 will have diffused into the breath. Ammonia will stay behind and neutralize the acidic environment of the stomach, creating an alkaline environment for it to stay. And this guy has a preference to stay in the antrum of the stomach. That is the part where it stays. But it is implicated in about 90% of peptic ulcers involving the duodenum, while it's implicated in about 70% of gastric ulcers, of peptic ulcers involving the stomach. So that's why if we see a list of options, that which of the following ulcers is going to come from Helicobacter pylori, and we see gastric ulcer, we see duodenal ulcer, some people will be confused. They'll be like, two answers are there, both of them are correct. What you are going to be picking is duodenal ulcer.
Duodenal.
Very, very important stuff. Duodenal ulcer. It can also cause gastritis, chronic atrophic gastritis. In fact, that should be the qualification. Chronic atrophic gastritis. Because it will stay in that stomach, irritate that stomach, make it atrophic, and from there, it can even progress to gastric adenocarcinoma or mucosa-associated lymphoid tissue lymphoma. So, Helicobacter pylori is the only organism in the world that is a cause of a lymphoma or a tumor that responds to antibiotics. If somebody develops multi-lymphoma, just give you a triple regimen, your APC, the person is going to treat the cancer. That's very beautiful. So don't forget that Helicobacter pylori can cause multi-lymphoma or adenocarcinoma. So how do we treat Helicobacter pylori infection? You do your triple therapy, and what you are giving is just simply APC, Action Political Party of Nigeria. So we give them amoxicillin, we give them Hibia, and we had our clarithromycin. It's as simple as that. If this person is penicillin allergic, we can replace it with metronidazole. So if the person is penicillin allergic, we can replace it with metronidazole. Sometimes the person might be resistant to or allergic to clarithromycin. So that means we have to switch to the bismuth-based quadruple therapy if we are concerned about macrolide problems like resistance. So we give the BMT, the BMT. So the way me I just put it in my mind is just that I'm giving like metronidazole and tetracycline. Those are the two antibiotics that are there. Metronidazole and tetracycline. and I'm adding it to the bismuth itself because I've said bismuth-based therapy. So the bismuth is number one, the two antibiotics, which is metronidazole and tetracycline, then the PPI. You can see that it's easy. The two things that must be there, like your PPI will always be there, constant K, and your antibiotics. But if it's bismuth, which we use if somebody's having macula, so that means that the clarithromycin is gone. And if clarithromycin is gone, we must change penicillin too. So that means that
What's the T?
it is tetracycline. So tetracycline, metronidazole, PPI, and the bismuth. So that's that about Helicobacter pylori. Interesting guy. So we move to spirochete. Spirochete.
But why are we adding tetracycline?
Yeah, so tetracycline also helps to eradicate that what's it called? This Helicobacter pylori. So we just have to add it like that just to limit the chance of developing resistance to this metronidazole. Because metronidazole basically covers against anaerobes. So
So in the triple therapy, we have the three. In the quadruple, we have the 3 plus the bismuth. So where does the tetracycline fit in? That's my question.
yeah, so all of them, they work together to eradicate this infection. So the metronidazole in a way also provides some anaerobic cover. Then tetracycline will do its normal job to kill off this organism if we can't use a macrolide.
Oh, tetracycline is
Replacing
that okay? Replacing
yes.
the
So
macrolide.
tetracycline is replacing the macrolide. If you can't use the macrolide, then you combine your tetracycline with your metronidazole. Do you get that, doc? Then
yes.
okay. So the spirochetes. So these are like spiral organisms that looks like this, and they have like axia filaments in them. So they are kind of filamentous in a way, but they are spiral in nature. And we talked about 3 organisms: the Leptospira, the Treponema, and the Borrelia. So we have come across this guy. We talked about these first 2 when we were talking about gram staining, and we said we cannot see Leptospira or Treponema because they are too tiny. But we can see Borrelia. But we need to use a special stain. And the special stain we talked about was what? The Giemsa stain.
Giemsa.
For Borrelia. So don't forget Borrelia species. So Borrelia burgdorferi in Lyme disease. We'll talk about it shortly. And to see Treponema, we have to use a specialized form of microscopy. And that is a dark field microscopy, or you do the fluorescent antibody microscopy. So this fluorescent antibody, you are just, like using antibody against this, what's it called? Treponema stuff, and you are like you are introducing an antibody that is coupled with a fluorescence material, such that when that antibody couples with the antigen of treponema, there is fluorescence. So it becomes white or bright, in the microscope. So that's direct fluorescent antibody microscopy. Very simple. Or you do a dark field microscopy. So this type of microscopies are more advanced than light microscopy, and you can use them to actually see treponema. So they are part of the direct test to look at treponema. So you do your dark field microscopy or you do your PCR analysis. We're going to talk about that test shortly. Don't worry about it. There's something called the Jarisch-Richman reaction. Big name, but simple stuff. Me, I don't bother myself about the Jarisch. I just know Jarisch-Richman. I'm okay. Nobody's going to be spelling. Nobody's going to tell you to be spelled. And even if we do our OET, there's a little chance that they are going to be telling us to be spelling Jarisch-Richman reaction. So you don't have to bother yourself about that. So, what is this all about? So many people get it confused and they limit it to only syphilis. So Jarisch-Richman reaction is a reaction that is peculiar to any of the spirochetes. So it means that if somebody has leptospiral infection, somebody has treponemal infection, or somebody has borrelial infection, and they commence the use of an antibiotic,
what is common to most of them is penicillin. You can give penicillin. Okay, penicillin might not work against this. Maybe ceftriaxone or amoxicillin. Okay, yeah, like amoxicillin, yeah. So once you give it, there's lysis of these guys. And now, the lysis provokes a form of inflammatory response to the products of the bacterial antigen released. And that leads to some signs and symptoms like fever, chills, headache, malaise. They can have vomiting, uh, muscle pain, which is myalgia. Once you are seeing that, immediately or few hours after commencing antibiotic treatment for any of these three, just go and pick Jarish, Erishma reaction. You are going to see all manner of answers that will try to make sense. But this is what you must go for. It is due to the lysis and sudden release of the bacterial antigen after you commence treatment. So it usually follows treatment of spirochete infection. So anytime you start treatment for any of the spirochetes, don't limit it to treponema, leptospira, Borrelia, treponema, any one of them. You start drugs, and suddenly after you start that drugs, they start having this reaction. Just know that is a Jarish reaction. So we get a lot of questions on this. You or maybe one or two. Very simple. Just spam it and we move. Moving on to Lyme disease. Lyme disease is caused by Borrelia. We have started talking about those just individual infections by one. Borrelia burgdorferi. Borrelia burgdorferi is a bacteria, that's part of the spirochete. And what transmits this Borrelia guy? The Ixodes. We cannot go for our exam and we are not able to talk about Ixodes tick. That it is not possible. We should not go for that exam. You must be able to talk about Ixodes tick because this guy is a candidate that carries three different organisms. It carries Borrelia burgdorferi, it carries Anaplasma, and it carries Babesia. It carries Babesia, Anaplasma, and what? And Borrelia. So people usually use my name to remember it, BAB. I remember the last class, we used to use this acronym to talk about it jokingly. My name, BAB. The Borrelia, the Anaplasma, and the what? The Babesia. So these organisms are carried by the Ixodes tick. And the reservoir for the tick is a mouse. But don't worry about this. You're not going to be hacked. And what are the common states? So people that are familiar with the geography of the US, it is common in the northeastern United States. So, I don't really, I struggle with those states, so I just ignore them. But it's good if you know them, it quickly help you. But do not rely on the states. Please rely on what the question stem is actually telling you. It is much more safe than just saying that, even at Texas, or this guy is very common in Texas now, you might miss it. So work on what the clinical picture is telling you. So what are the stages of Lyme infection? The early localized stage. And what are they talking about here? This exotic stick now just come around and maybe takes a bite somewhere and release the Borrelia. And Borrelia will just come and inoculate itself in the skin. And that area you are going to see this configuration. The erythema migrans, rash. Bullae, central area of Clarence, and the outermost erythematous area. Once you see this triple stuff like this part, and this part, this is erythema migrans until otherwise proven. And that is the early localized form of Lyme disease. As it progresses to stage 2, which is the early disseminated form. The early disseminated form. So now it starts getting disseminated. This rash will move to another place. It 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 will move to another place. And in addition to that, the person will start developing the symptoms of face. E for the erythema migrans, the C for carditis, the A for AV block, and the F for facial palsy. So by the time you are seeing features of face, you can confidently say that this is the early disseminated form of the Lyme disease is as simple as that. Facial nerve palsy, which is usually bilateral in most of the time. If you see somebody with bilateral trigeminal neuralgia, what is our diagnosis? Spot diagnosis. Bilateral trigeminal neuralgia. Who knows? Anybody knows? Step 1.
So what was the question?
A patient having bilateral trigeminal neuralgia.
Multiple sclerosis.
Multiple sclerosis. Multiple sclerosis. A patient having bilateral facial nerve palsy until otherwise proven. Your diagnosis is what? Lyme disease.
Lyme disease.
So, in addition to that, they can also have migratory myalgias, transient arthritis. By the time it gets to stage 3, we call that the late disseminated. And the person is already presented with encephalopathy, the person is already getting confused, the person is having personality changes, the person is having memory loss, the person is just changing completely. And the joint problem is getting chronic, more than 3 months. The person is also having peripheral neuropathy. Know that this is likely to be a late disseminated form affecting the brain, and you want to institute your treatment as early as possible. Now, this is where they wait for us. How do you treat? So it depends on the clinical stage. Stage 1, you just want to give the doxycycline. Chicken and you move. But if this person is pregnant or the person is less than 8 years, you have to be careful because of the effect of doxycycline on the deciduous state. So you might not want to give. Hello? So we might not want to give doxycycline in a child which is less than 8 years or a woman that is pregnant. So in that case, we prefer to give amoxicillin. So but the first line is doxy. But if the patient is less than 8 years, the woman is pregnant, just give amoxicillin. But if somebody is having symptoms of early disseminated, which is face, or the person is having encephalopathy, chronic arthritis, immediately you start your IV ceftriaxone. It is as simple as that. IV ceftriaxone for disseminated problems. Why for the early problems, just give your doxycycline or your what? Amoxicillin, as the case may be. So moving on to the next one, which is a leptospira interrogans. You can see it in the exam. It is a spirochete, just like the others, with hook-shaped ends. I don't know if you have a picture. So this is the guy, and it's very common in water contaminated with the animal urine, particularly rats. Rats, that they are the guy that spreads this wonderful leptospira. So water contaminated with the rat urine, can spread this guy. And we have 2 forms of the leptospirosis and the whale disease. The leptospirosis and the whale disease. Now, what are the clinchers you need? They will give you in the exam. Calf pain. Leptospirosis, calf pain. So the person is surfing in some river somewhere, maybe in Brazil, and the person develops calf pain. The person suddenly becomes jaundice because it's already affecting the liver.
Wale, you're breaking.
Hello?
Yeah, you're breaking. I didn't hear. I don't know about others. I didn't hear the last sentence you made.
Hello? Am I breaking? So the calf pain, very important. The affectation of the liver causing the jaundice and photophobia. So once you are seeing photophobia with this conjunctival suffusion, which is absence of exudate in the eye, photophobia, the jaundice, and this calf pain is too classic. Calf pain, jaundice, and if they put the conjunctival suffusion, good. Just think of your leptospirosis. It's very common in people that are surfing in water bodies, people that are traveling in the tropics. Then we have the terrible form, which is now affecting the liver and the kidney. So that's what we call the well disease. That is the the jaundice, hemorrhagic leptospirosis. So that is a form in which you have a massive injury to the kidney and the liver. So the person will develop the fever, the person will develop the jaundice, azotemia, and of course hemorrhage. So, because in this form, there's already damage, severe damage to the endothelial lining of the vessels. So they are bleeding uncontrollably. The liver starts shutting down, causing jaundice. The kidneys also start shutting down, causing the azotemia. So the difference between the well disease and the leptospirosis is just that here we have end organ injury involving the liver and the kidneys majorly. But here, only the liver is kind of involved, and also there is this calf pain and photophobia. That's just the triad: the calf pain, the photophobia, and maybe conjunctival suffusion. But here, injury to the kidneys, to the liver, and of course to the vessels, causing hemorrhage with subsequent anemia from the bleeding. It's as simple as that. So, uh, syphilis is the next one. Syphilis is, I don't know, the chance is very, very high. There's no way, I don't know what syphilis, I don't know what this guy did to the MBMEs. They like it like mad. It's too common. So, it is caused by a spirochete, which we call the Treponema pallidum, and the treatment is penicillin. In fact, I want to tell you that if a pregnant woman is having syphilis and want to treat, and the person is kind of sensitive, reacting to penicillin G, I want to tell you that you repeat the penicillin G, you desensitize the woman with this penicillin G, and you still administer. You don't go for any other option. Penicillin G is a treatment. That is for you to know how important penicillin G is, in treating syphilis. If you are sensitive to it, you desensitize and you still give the penicillin. Very important stuff. Penicillin G is the treatment for Treponema pallidum infection. So we have the 4 spectrum, the primary to the congenital form. So the primary is very simple. Just see the patient present with a painless chancreas. That's all you see in the question stem. That is a painless ulcer. Once you see painless ulcer, single, usually single, that is primary syphilis, until otherwise proven. And you can do some tests to identify it, but it's not very important now. Just know that, okay, if you do a VDRL test, it's going to be positive. The secondary form of syphilis, in this one now, there is now a maculopapular rash. So the patient is now developing a maculopapular rash. And what is peculiar to this maculopapular rash? It involves the palm and the sole. We don't have many infections in the entire microbiology that cause maculopapular rash that involve the palm and the sole. Secondary syphilis is one of them. Rickettsia is another one. Coxsackie is another one, which you are going to be seeing shortly. I'm just mentioning it here so that it won't be the first time we are hearing it. Secondary syphilis, Coxsackie, Rickettsia, they all cause maculopapular rash that will infect palms and the sole. Aside this rash, what else? The person is going to be having a lymphadenopathy. When somebody is having like a generalized lymphadenopathy, you're thinking of either HIV, you're thinking of secondary syphilis. You're having lymphadenopathy. What? You're having a maculopapular rash? Let me see your hands. Let me see your soul. We have to rule out syphilis in this guy. The next, they will have what we call the condylomata lata. So that's like whitish, warty lesion, in the genitals. So once you see this, you think of secondary syphilis. These are the the maculopapular rash, in the body, the trunk, characteristic of secondary syphilis, and what else? Those are the common stuff. We have the patchy hair loss, that might not be, but the common ones are what we have talked about: the maculopapular rash involving the palms and the sole, the condylomata lata, and the generalized lymphadenopathy. So you can do our serology testing, which is the VDRL RPL test. We are going to talk about the test shortly. And you can confirm your diagnosis by doing your fluorescent antibody microscopy. So you do your fluorescent antibody visualization. So sometimes some people can have latent syphilis, in which all the symptoms that we are seeing, they will disappear. But if we do a serology using VDRL or RPR, it will be positive. It's just like latent tuberculosis. We did not talk about latent tuberculosis step 1 because it's step 2 stuff, in which the person is going to be having like a positive IgRA or a positive what's it called, PPD test, but the person is not going to be having a clinical symptom of tuberculosis. There's no cough, no what's it called, no chest pain, no hemoptysis. But if we do the testing, it's going to be positive. That's latent syphilis or latent tuberculosis. Serology without symptoms. So moving on to the tertiary syphilis. So here we just start seeing granulomas everywhere. The gommas, which are like granulomatous lesion, that is so disruptive that the face is good. Look at, can you imagine how someone's face is looking like? Everything is being destroyed. Just like, which form of leprosy? Anybody?
Lepromatous.
Lepromatous.
Just like lepromatous. Just like
face.
lepromatous form of leprosy. You can see the way the face is looking. That's a gomma, category of tertiary syphilis. So, and they can have aortitis. So aortitis because there is inflammatory lesions in the vasa vasorum. That means there is inflammatory lesions in the vessels supplying the vessels. So we have vessels supplying the vessels. We have some tiny vessels that are supplying the tunica media, tunica intima. So you can have some like end obliteratis, inflammation of that vessel, just small, inflammation like that, that will compromise that vessel. And at the end of the day, the big vessel become weak. Because if the vessel that is nourishing the big vessels are out, the big vessel will start becoming weak. So their tunica media starts becoming weak. And that can even be a cause of, aortic aneurysm. Hope we know that syphilis can cause aortic aneurysm. True or false?
True.
So what form of aortic aneurysm do you expect? Is it going to be like thoracic, or is it going to be like descending, or
Ascending.
the ascending, like the thoracic? Yes. So that's syphilis for us.
Feedback appearance.
The what? The tree bark
Back
appearance.
appearance.
Yes. So that's that about hepatitis from syphilis, and it can also be a cause of neurosyphilis. So in neurosyphilis is already affecting the tabes dorsalis. What column is affected in tabes dorsalis?
The
Neuro,
dorsal column.
the dorsal column. So that means that vibration is going to be gone. That means that proprioception is going to be gone. That means that 2-point discrimination is going to be gone, right? So the person cannot do 2-point discrimination. The person cannot have proprioception. So that means that the person is going to be finding difficult to orientate the legs in different points as he or she is moving, because they don't have that joint space, idea again in their mind. So they can fall easily. And of course, the vibration sense is gone because of injury to the dorsal column. They can have this general paralysis. So we call that like their bed, they just lie in bed. They are weak generally. And of course, there's also injury to the protector nucleus. And that brings about the argyrobatin pupil. So in the exam, they can just describe what the argyrobatin pupil is all about. And the next thing they'll be asking us is what's it likely cause? So we know that that's a manifestation of tertiary syphilis affecting the brain. So what happens here is that if we bring an object close to the eye, the accommodation reflex is there. That is, the pupils are going to constrict. But if we shine light to that same eye, the pupils will not constrict. So that is the argyrobatin pupil. The pupil is abnormal in argyrobatin pupil. It only responds to accommodation, but does not respond to light. Syphilis. So what are the signs that we can elicit? We tell the patient to walk. They're going to have a broad base ataxia, right? We tell them to close their eyes and to so the ataxia is due to the loss of the proprioception, and we tell them to close their eyes, put their feet together to do the Romberg sign. They're also going to have a problem with the Romberg sign because to maintain balance, you need 3 senses. You need the vestibular system, you need the eyes, and you need the sensory fibers like the dorsal column, pathway. So, but two must be present together at once to maintain balance. At least two of these three must be present. So if we tell somebody to shut their eyes, so that means we have taken one. We have taken one. So that means that we have left with two. So it means that if we tell the person to put their feet together and stand and be looking straight ahead, if the person is not a texic, so it means that these two are okay, which is what? The vestibular system and the dorsal column, and the peripheral nerves. They are okay. But if the person starts shaking, it means that one of them is problematic. So now, people with tertiary syphilis, once you tell them to shut their eyes, you have taken one out. We are left with the dorsal column and the vestibular system of the inner ear. But because of the fact that they can have tabes dorsali, so that means that this one too will be knocked off. So it will remain the vestibular system, which is not able to maintain balance, solitary. So the person will start shaking and be tilting, be ataxic. And we can say that the Lundberg sign is going to be positive in them. And of course, they have the charcot joint because of the loss of the proprioception. So they keep eating their legs on different places they're not supposed to eat their legs. So they suffer micro trauma to the legs, and you start noticing that the joint will become deformed. So that is charcot joint. They can have stroke with hypertension, without hypertension. So that's linking to the aortitis. Inflammation of the vessels of the brain, leading to ischemic stroke or sometimes hemorrhagic stroke without any hypertension. So it's due to the inflammation of the vessels of the brain. Congenital syphilis. So we have some peculiar features like the lagides, which is the linear scars at the corner of the mouth here. They have the snuffles. Just tell you that the baby is always having nasal snuffles from time to time. That could be signs of congenital syphilis. You look at the nose, the shape is abnormal, saddle shape, saddle nose. They have a notch teeth. So the nose, we call it peg-like incisors. So the patient having peg-like notched incisors, that is the Hutchinson teeth. So they have the mulberry molars. The molars at the mouth look like a mulberry, and the maxilla is very short. It's not seen here. They have a sebal chin. See the chin, which is the tibial bone, is like convex like this. Sebal chin. And of course, they have the deafness. So there used to be this Hutchinson triad. I think it's deafness, it's the teeth, the notch teeth, and I can't remember the third one now. I can't remember, but there's this triad of congenital syphilis of the deafness, the notch teeth, and interstitial keratitis. I think so. I think that's it. So they have a keratitis, they have deafness, and this let's see just to be sure. I'm so sorry. Hutchinson triad, Hutchinson triad of congenital syphilis. Okay, yeah. So interstitial keratitis, the deafness, and the autism. So that's that's what they have. So they are deaf because of affectation of the cranial 8. They have a problem with their teeth, and of course the eyes too. So don't forget that the sabre chin, the convex convexity of the tibia bone, the saddle nose, and they're always snuffing. So that nose is saddle in shape, and they're always snuffing. They have the linear lagides at the corner of the mouth, and the other features such as the Hutchinson teeth. So we have to treat the mother early because the problem occurs in early pregnancy. So treat the mother early to avoid placental transmission. So moving on to the way it's diagnosed. So we can do serology to do the VDRL test, as the venereal disease research lab test, or the rapid plasma reagent test. And what is peculiar to these two tests is that they test for beef cardiolipin. So people with syphilis, they have this what's it called, antibody. They produce antibody that can react against cardiolipin. So that's it. So and this VDRL test and the rapid plasma reagent can detect that antibody to the beef cardiolipin. But the problem is that it is not only syphilis that can produce antibody against beef cardiolipin. So it is a non-specific test. So that is it. But readily available, it's fast, it's sensitive, but it's not specific because there's so many things that can produce antibodies against beef cardiolipin, and that brings us to the positive VDRL. So the P for pregnancy. Pregnancy can be a cause of that. The V includes EBV or hepatitis, EBV hepatitis, the drugs for most of the drugs that can cause lupus, you'll be correct. So procainamide, chlorpromazine, they would cause a false positive VDRL test. Yes. And the R for rheumatic fever, and the L for lupus, and leprosy. So that's the first positive VDRL, the positive VDRL. Don't forget that this acronym can help. And this serology test, as well as the direct testing, they usually go back to normal after we have treated the syphilis. So if we treat somebody with syphilis now, we expect this guy, as well as the direct test, to be normal. Now, what are the direct tests? Either you are looking at the organism directly with a dark field microscope, that's a direct test, or I am sequencing the genome and I'm amplifying the DNA of that syphilis by doing a PCR analysis. So this is true added direct. They don't involve any form of serology. I'm not doing any serology, no antibody conversion. But for serology, we have the ones that are specific to treponema and the ones that are not specific to treponema. So the ones that are specific to treponema, they are the what? The fluorescent antibody test and the treponema pallidum particle agglutination. So we don't have to worry about the big name. What they are just talking about here is that both of them, they usually have like an antigen of the, what's it called, of the treponema antigen. The treponema antigen put on a glass slide or something. And we obtain the serum of somebody that we expect to have syphilis. And once we had it there, definitely the antibody, the serum will contain antibody to the treponema. So the serum that contains the antibody will interact with the antigen of the treponema that we already have on the glass slide. And we can look for anything. So under TPPA, because it is treponema pallidum particle agglutination, so we expect for some form of clumping. But for the fluorescent treponema antibody absorption test, we expect some form of fluorescence. It is as simple as that. Don't keep it simple, don't complicate it. So both of them, they are treponema specific testing, and they are serological. But for the non-specific ones, you talk about the VDRL, I talk about the rapid plasma reagent, and both of them, they are just testing antibody against beef cardiolipin. So we treat somebody with syphilis now. This guy, the non-specific and the dark field, the direct testing, they are going to go back to normal. But this one will never go back to normal. They will still remain positive. I don't know why. So moving on to chlamydia. Chlamydia is very, very interesting. Chlamydia is one of those intracellular obligates.
I didn't see your cursor. You said which one will remain positive?
So the one that will remain positive is the specific one. Doc,
Okay.
I've been using a lot of cursor. Why can't you see my? Can anybody see my cursor?
I see it now.
Yeah,
Okay,
I can
thank
see.
I think my computer is slow. Don't worry. I see it now. Thank
Okay.
you.
So chlamydia cannot make its own ATP. It's one of those intracellular obligates alongside with Rickettsia and Coxiella. So they depend solely on the organism they are infecting for the source of the ATP. And I want to say that chlamydia has two bodies. We should not forget the elementary body and the reticulate body. The elementary body and the reticulate body. So the elementary body is also known as the infectious form, just like we have here EN, infectious form. So it tends to assume this elementary body state so that it can infect the cell by endocytosis. Once it gets into the cell by endocytosis, it will transform back into the reticulate body. And the reticulate body, because it contains a R, is a form that will replicate. and it replicates in the cell by binary fusion. And later, it will reorganize into different elementary body that will be released to infect other new cells. So that is the life cycle of chlamydia. Don't forget the elementary body, which is the infectious form, and the reticulate body, which is a replicative form. So chlamydia can cause so many problems. It is not limited to neonatal or follicular adult conjunctivitis. Remember trachoma, so something like this, follicular conjunctivitis in the eye, trachoma. It can cause non-gonococcal urethritis because we have gonococcal urethritis. Chlamydia can cause non-gonococcal urethritis. It's a cause of PID. This is a cause of reactive arthritis. The chlamydophila pneumoniae and the chlamydophila psittaci are also causes of atypical pneumonia. And I said something about atypical pneumonia to be that most of the atypical pneumonia, they have a low-grade fever and their sputum is what?
Non-productive.
Non-productive, thank you. So what is peculiar to the cell wall of chlamydia? It lacks a classic peptidoglycan because it has reduced amount of muramic acid. So that is why we might want to use other stains like the Giemsa stain to look at the chlamydia. So because chlamydia lacks a peptidoglycan cell wall that is well developed, you cannot use a beta-lactam antibiotics. It will never work. When we get to the antibiotics, we talk about this because we need beta-lactam antibiotics to bind and inhibit the penicillin binding protein. Remember when I was talking about McA gene of Staph aureus. So this beta-lactam works by, example of beta-lactam is penicillin. So they work by binding to the penicillin binding protein, inhibiting this protein, and preventing the transpeptidase activity of this protein in forming the peptidoglycan cell. But this guy already lacks a peptidoglycan cell. You are not inhibiting anything because it doesn't even have it. So it cannot work. It is as simple as that. So how do we make diagnosis? You can do a PCR analysis. You can check for the cytoplasmic inclusion on the Giemsa stain. Don't forget, we talked about the Giemsa stain as a means to identify this guy. And you can also do a fluorescent antibody. Don't worry about the lab testing. They are not going to ask you. What is important is what it costs and the fact that it lacks this classic peptidoglycan cell wall and the fact that antibiotics cannot work against it. Also pay attention to the forms and of course the treatment. So Doxy is a mainstay to treat chlamydia. Doxy is a mainstay. Doxy is a mainstay. And what is the twin brother of chlamydia? Anybody remembers?
Rickettsia.
Rickettsia. And I want to tell you that this same Doxy is also the mainstay of treating the twin brother of chlamydia. So keep it simple and it's going to be easy. Azithromycin, which is a macrolide, can be used if somebody is pregnant and the person is having a chlamydial infection. Azithromycin can be used. And don't forget, when we talked about infection from gonorrhea, we always say that you must rule out chlamydia. If you don't rule out chlamydia, institute treatment for chlamydia. Same thing happens in chlamydia. If somebody is having PID for chlamydia, rule out gonococcus infection. If you don't rule out gonococcus infection, maybe you don't have time, administer ceftriaxone. But if you rule out gonococcus and it's negative, don't worry with the ceftriaxone. It goes hand in hand. Very, very important stuff. So, what are the serotypes of chlamydia trachomatis organism? So we have serotype A to L. For ABC, they go together. So ABC are the ones that cause the high infection. So they cause blindness due to follicular conjunctivitis in resource-limited areas like in our side, Africa. Very important. So if they say the person is living in Africa and the person develops follicular conjunctivitis, think about trachomatis causing trachoma, and they will ask you what serotype. So it's going to be A, B, or C. African blindness, chronic infection. Then we go to the last one, which is the L1, L2, the L3. L1, L2, L3. So that can cause a genital ulcer like lymphogranuloma benign. So don't forget chlamydia. I know it doesn't link, but chlamydia trachomatis is actually the cause of lymphogranuloma venereum. Don't forget. And what are you going to see in the exam that is going to raise your suspicion? Many people don't know this, but we are going to talk about it, and we know it once and for all. All you are looking for is that you ask yourself, this ulcer, is it painful or it is painless? For lymphogranuloma venereum, it must be painless. But they will tell you that something else is painful, and that is what? The surrounding inguinal lymphadenopathy. So if they tell us that the inguinal lymphadenopathy is dilated, bubbles, swelling, it is ulcerated, and it is painful, but the ulcer in the penis or in the vulval area is painless, your answer is lymphogranuloma venereum until otherwise proven. So people are already picking syphilis and they are banging it. But we have already identified that we are seeing multiple ulcers that is painless, and we can see painful inguinal lymphadenopathy. We just pick our lymphogranuloma venereum and we are smiling. So the serotypes of the lymphogranuloma of the chlamydia trachomatis that cause the LV, the serotype L1, L2, and the L3. L1, L2, and L3. And because this guy is caused by chlamydia trachomatis, just institute the doxycycline and you'll be fine. Now, the other ones are packed between the serotype D to K. So you don't need to cram it. Just know them. Urethritis and the PID. Anything that's outside eye infection and the genital ulcer, it's going to fall between D and K. So urethritis, the PID, and because of the PID, they can develop what? Ectopic pregnancy is a risk factor. We know that. They can have neonatal pneumonia, which is a staccato cough. You just have this recurrent coughing, but there's no inspiratory whoop. So that's how you can differentiate it from pertussis. And of course, there's going to be eosinophilia with that neonatal pneumonia. So once you are saying an infant, a neonate having pneumonia, and we did the blood work, there's eosinophilia, you think about staccato cough from chlamydia trachomatis. And of course, the neonatal conjunctivitis, which is very similar to that of gonorrhea, but the difference is that gonorrhea occurs within 2 to 5 days of birth, while the one from chlamydia trachomatis, just like we said earlier, occurs within 1 to 2 weeks after birth. So moving on to Gardnerella vaginalis. You don't want to forget this. Very high yield, very, very high yield infection. And I want to say that Gardnerella vaginalis is a pleomorphic gram variable. We don't know if it's gram positive or gram negative. And it's the organism that is implicated in causing bacterial vaginosis. And you must not forget the Amstel criteria, which is characterized by presence of this discharge, the vaginal discharge, with the positive whiff test, in which when we collect the vaginal discharge and we mix it with 10% QH, we notice that there's exacerbation of the fishy odor smell. So that's a positive whiff smell or whiff test. And that vaginal discharge, when we do a pH analysis, we're going to notice that the pH is going to more than 4.5, like more than 4.5. So that's also in keeping with bacterial vaginosis. And the last is that when we do like a mount examination of that discharge, we are going to be seeing Cleve cells, right? So Cleve cells are just vaginal epithelial cells, just like what we have here, stippled with the Gardnerella vaginalis infection. So many of the epithelial cells in the vagina, they are colonized with this Gardnerella vaginalis. So they form the Cleve cells. So once you have that for the blue-green vaginal discharge, the what's it called? The positive whiff test, in which you have exacerbation of the fishy odor with KH mounting, the vaginal pH more than 4.5, and the Cleve cells being present on examination. So I want to say that bacterial vaginosis is associated with sexual activity, but it is not sexually transmitted. Don't make that mistake. So what they are saying is that you don't transmit this organism by sexual contact, but if somebody is engaging with so much sexual intercourse, the person can actually affect the floral balance in the vagina, causing a drop in the lactobacilli. And when the lactobacilli drops, you can have excessive proliferation of this Gardnerella vaginalis, and from there, and also other anaerobic bacteria leading to bacterial vaginosis. So we have talked about the other components. Don't forget. How do you treat? Just give either your metronidazole or your clindamycin. What is common to both of them is that both of them are useful in treating anaerobic infection. And I want to say that Gardnerella vaginalis is also an anaerobe. So it will work against it. So moving on to the zoonotic bacteria, this is not very high yield. You rarely get questions on this. It just means that these are certain infectious diseases that can be transmitted between humans and animals, and this includes stuff like anaplasmosis, being transmitted by the exotic stick. Remember the BAB. So the B for the Babesia, the A for anaplasmosis, and the other B for the Borrelia. So the three of them are transmitted by the exotic stick. The Bartonella, which can cause cat scratch or bacillary anthematosis, can be transmitted by the scratch of a cat. Borrelia burgdorferi, which is a Lyme disease we talked about. Lyme disease, Borrelia burgdorferi, can be transmitted by the exotic stick too. We talked about we've not talked about relapsing fever, but we're not going to talk about it. That's is caused by Borrelia recurrentis and transmitted by louse. Brucella is not high yield. Unpasteurized dairy products, blah blah. Brucellosis. Campylobacter is high yield. Bloody diarrhea, especially in which age group? Diarrhea in which age group? Bloody diarrhea in which age group? Anybody remembers? We talked about it. Campylobacter jejuni.
Young
In 40,
In
And
pediatrics. In
yeah,
pediatrics. So
pediatric.
contaminated pet, animals, food, and Staphylococcus in birds. Q fever is in. I'm going to talk about that. Don't worry. Ehrlichiosis, amblyoma, which is a non-static amblyoma, non-static ehrlichiosis. Tularemia is usually rabbit. Leptospirosis, animal urine in water. We talked about this, and recreational water use. So don't forget the triad, the photophobia with conjunctival suffusion, the calf pain. Very, very important, and of course the jaundice for leptospirosis. Leprosy, talk about it. So people with lepromatous leprosy, if they come across with another human with lepromatous leprosy, they can develop leprosy. Or somebody that plays with a madilo, but it's very rare. Posturola multicoda is very important because the individual can develop cellulitis at the site of the bite, or osteomyelitis at the site of the bite, especially when they get exposed to the dog bite or sometimes cat bite. So Rickettsia prowazekii can cause what we call epidemic typhus when they come across with the human body louse. Rickettsia rickettii, it can cause Rocky Mountain spotted fever. We cannot go for exam, we don't know this. It's not possible. And the implicating organism is the Rickettsia rickettii, and it is transmitted by Demacanthus or the dog tick. And we have the Rickettsia typhi, which is the endemic typhus transmitted by fleas. And we have the Salmonella species, except the Salmonella typhi that are transmitted by poultry too, causing diarrhea, which may be bloody. And of course, the Yersinia pestis is a transmission of plagues, and it's being spread by fleas and the like. So, moving on to Rickettsia. So, Rickettsia is very common. The twin brother of Rickettsia is chlamydia, and the treatment of both of them is what? Doxycycline. So we have two major forms of Rickettsia. We have the Rocky Mountain spotted fever. So because it starts with R, so it means that this Rocky Mountain spotted fever is going to be caused by Rickettsia rickettii, the R. And the tick, the organism that transmits this Rickettsia rickettii, the vector is what? The tick, the Demacanthus tick, the dog tick. And what is the triad of Rickettsia rickettii, which is the Rocky Mountain spotted fever? Just look out for headache, rash, and fever. But what is about this rash? The rash is due to vasculitis, inflammation of the vessels. You just see petechial rash, starting from the these are the rash starting from the wrist, starting from the ankle, So the ankle is at the joint of the leg, the wrist is at the joint of the hand, and they will start spreading distally. So that means that if it starts at the wrist, it will spread to the palms. If it starts at the ankle, it spread to the sole. And from there, they move inwards to the trunk. It is as simple as that. As simple as that. Don't forget, in addition to Coxsackie virus A and syphilis, it is also another cause of rash that involves the hands and the what? The palm and the sole. So don't forget that. So that's that about rickettsia. Rickettsia. Is very simple. The next is the typhus. We have two types: the endemic typhus and the epidemic. So the endemic typhus is caused by rickettsia, not rickettsia, but rickettsia typhi. Rickettsia typhi. While the epidemic is caused by Rickettsia pro-Kawasaki, pro-Kawasaki, Rickettsia pro-Kawasaki. And the vector that transmits this is the human body larvae. While the one that transmits the Rickettsia typhi is the flea. So most of the time, they focus on Rickettsia rickettii. It's more classic. The difference between them is just that this one, the rash, starts centrally and move outwards. Or like this one that starts from outwards and move inwards. So this one, they start centrally and they move outward. Just know that it's the reverse of the distribution of the rash of Rickettsia rickettii. So moving on to the ones that the Rickettsia illnesses or vector-borne illnesses that are rash common, they are these ones. The ones that are rash rare are these ones. So the ehrlichiosis, the anaplasmosis, and the Q fever. They are rare in terms of the rash. So what's it called? So the first one is Ehrlichia, and the vector is the lone static. Now, what you just need to take home for the sake of the exam is that whenever you see morule inside monocyte, let me give you an example. This is the morule here. Inside the monocyte, you know that the diagnosis is going to be ehrlichiosis. It is as simple as that. So there could be monocytosis because Ehrlichia proliferates in the monocyte. Why for anaplasma? The vector 2 is tick. And the tick is what? Which tick is that? Anybody remember the tick for anaplasma?
Exodus.
Yes. Exodus tick. Exodus. Sorry about that. Exodus tick. And what do I want to say? Yeah. So the exodus tick, but you have the morule proliferating in the granulocyte here. So this is a granulocyte. Consider the nucleus is quite different from the nucleus of this guy. So, what's common to them is that the patient can have constitutional symptoms like fever, headache, myalgia. They can have problem with the kidneys. They can have thrombocytopenia, have liver issues. Not specific. You will not know until you see your blood smell what is happening. Morule inside the monocyte or morule inside the granulocyte. That's what is going to differentiate them. So if we are saying morule inside monocyte, that's ehrlichiosis. We are saying morule inside granulocyte, that's anaplasmosis. These are simple as that. So Coxella bonnetii has no arthropod vector. There's no vector that's spreading this guy. This guy is very common in people that get exposed to the amniotic fluid of sheep or cattle. And they present with headache, they can have pneumonia symptoms, they can have hepatitis symptoms. And usually it's one of the cause of culture negative endocarditis. So, so once you see somebody having headache, fever, pneumonia, hepatitis, after the person works in a butchery or something, just know that it's likely to be Q fever from Coxella bonnetii. Mycoplasma pneumoniae, there's no way we can go for exam and we don't know what mycoplasma pneumoniae is all about. It's very important. It is a classic cause of atypical working pneumonia. What this is trying to tell us is that this person will be up and doing, but by the time you do an X-ray of this person's chest, you'll be amazed at the level of damage that has been done to the lungs. So that's what they call them the working pneumonia. You don't know that something terrible is going on. It's that indolent. So they usually have these constitutional symptoms like headache, but what you are looking out for is a non-productive cough because this is atypical. the cough is going to be non-productive. And if you look at the X-ray, we are going to see like a diffuse interstitial infiltrate, and they are going to have a rash. I like this sign a lot. Always look for the rash. And what is a rash we are talking about here? Who remembers from dermatology? Anybody remembers? Somebody with mycoplasma pneumonia having a rash. What is that rash?
Ma'am, what's it for me?
Erythema
Yeah,
multiforme.
yeah.
Erythema multiforme. So, see somebody having erythema multiforme. The commonest cause of erythema multiforme is what? HSV virus. HSV virus, and followed by what? Chlamydia for mycoplasma pneumonia. So somebody having erythema multiforme with targeted lesion, and the person is having pneumonia with atypical distribution. You already know that that's mycoplasma pneumonia. What is now further going to help you is that you look at the age of the patient. The person is going to be less than 30 years. The person is going to be very young. And the person might be in a clustered environment like prisons, college, military, barracks, and the likes. So what do? You can give macrolide, doxycycline, fluoroquinolone, they will work, but penicillin will not work. Bactalactams will not work because they don't have the cell wall. So it will not work. So give things that inhibit protein like macrolide, doxycycline, or fluoroquinolone. You grafting mycoplasma? No, there's no way you can graft. So don't forget the culture that we talked about, the medium. We talked about 18 Higa. And I talked about a component of that Higa. Anybody remembers? I know, we say make it right.
Cholesterol.
Cholesterol.
Fantastic. It contains cholesterol, to form it, to build its cell membrane and everything like that. So contains sterols for stability. Very important. So the chest rate appears very severe than the patient presentation. That is what you call by the walking pneumonia. And it elaborates cold agglutinin. This is important stuff. So that is why causes of the cold autoimmune hemolytic anemia is going to be what? Mycoplasma pneumonia. Hope this makes sense to us. Can we remember that from hematology?
Yes.
Mycoplasma pneumonia is a cause of cold hemolytic anemia because it can elaborate IgM that starts hemolyzing and agglutinating the red blood cell. So that is an important thing they can test in the exam. Very, very important stuff. Cold agglutinin, IgM. Warm agglutinin is IgG. So let's just start with the fungal and just quickly wrap it up. The systemic mycosis. So all of them can cause pneumonia and they can disseminate. All are caused by a dimorphic fungal. Not all of them, some, some are monophic, if there's a word like that. They only have one form, while some are dimorphic. So dimorphic meaning that they exist in two forms. They can exist as a mode in the cold temperature, 20 degrees. So this is a form in the soil, and the yeast form is when they infect human being. So that's like about 37 degrees Celsius. And the exception to this dimorphic presentation is the coccidioides that exist as a spherule. It is not a yeast, it is not a mode, but it exists as a spherule. When you say a spherule, you know that this is coccidioidomycosis and you're happy. So all of them can cause pneumonia, which can disseminate. Very important stuff. So they can all form granulomas. They are chronic fungal infection. They can form granulomas like TB, but they cannot be transmitted from person to person. Important stuff. You cannot transmit it from person to person. Just like you cannot transmit Legionella from person to person. The individual must get it from the actual source. So how do you treat? If it's local, just give fluconazole or itraconazole. Anytime we are seeing systemic infection and we don't know what to pick, just pick amphotericin B. Most of the time you'll be correct. What is systemic? Amphotericin B. So let's start with those guys one by one. The first is histoplasmosis. Histoplasmosis is very simple. You just have to know what you need to know. And the first thing is where it is. Mississippi and Ohio Valley, you are going to see them mention any one of these two. One of them is going to mention in your exam. They will tell you if the individual is living in Mississippi or the person is living in Ohio River Valley. And they will tell us that when they did the laboratory investigation, they noticed that the macrophages are being colonized by this histoplasma organism. These tiny ones we are seeing here, that is the histoplasma yeast infecting the macrophage. And they appear smaller than red blood cells. So once you see macrophage colonized by the yeast of
Sorry.
Hello?
No, sorry, you're breaking.
Yeah,
I don't know.
sir. You're
No.
breaking.
We can't hear you, please. Yeah.
They said
Okay. How is it now? Can we hear me now?
Yes.
Hello? Is it better?
Yes, sir.
Okay.
Yes.
So
it's better.
for histoplasmosis, we just noticed that the imaging is going to be showing the macrophage colonized by the histoplasma organism. These tiny, tiny ones we are seeing. This is the histoplasma in the macrophage. And it's endemic to people living in Mississippi and Ohio River Valley. Now, what are the unique symptoms? That brings us to the acronym HORS. The HORS, the H for hepatosplenomegaly, the R, the O for oral ulcers, the R for rash, and the rash we are talking about here is actually erythema nodosum. Erythema nodosum. The S for splenomegaly, and the E also stands for erythema nodosum. So HORS should raise our suspicion for histoplasmosis. Hepatosplenomegaly, oral palatal ulcers, the rash, which is erythema nodosum, and the S for splenomegaly. And they also have pancytopenia. Pancytopenia. So how do we get this histoplasmosis? Anybody that is working in excavation, that they go and be digging caves, they can get exposed to the bed and the bat droppings. So these droppings usually have this histoplasma guy, and once it's inhaled, it goes straight in the lungs, and it will cause a chronic pneumonia. Don't forget that. Chronic form of pneumonia. So it's very terrible. And how do we make the diagnosis? Urine and serum antigen. Anybody remembers any organism that will make the diagnosis by urine and serum antigen? Anybody? We talked about this today. Eh?
We know it. Just give us a minute. Oh
So
God,
that would reason
begin
that
with Legionella. Legionella.
Legionella. Fantastic. Legionella.
Legionella.
So you do your urine and your serum antigen test to make your diagnosis of the Legionella. Just like in histoplasmosis. Very important. So that's that about histoplasma. Don't forget the horse. It will help you. The next is blastomycosis. Very simple. Don't worry about the geographical location in blastomycosis. Nobody cares about Eastern, Central, how many you want crown. But don't forget that they will have a broad-based body. That's the stuff. So there's going to be a broad-based body in that you see the parent cell that's going to be larger than the daughter cell. So once you see this, that is a broad-based body for blastomycosis. Very high stuff. There's no way we can forget that. There is no way. In fact, you don't need to see the image. Just look at broad-based body in your exam. Just remember the B of broad-based body. The broad-based body means blastomycosis. And how is blastomycosis going to look like? Blastomycosis infection is very, very debilitating. They can also get it from all this cave kind of thing, and they inhale it. It leads to inflammatory lung disease, serious pneumonia. Sometimes it can disseminate. Don't forget, everything they can what? They can disseminate. And from the lungs, they can disseminate to other parts. But this guy, blastomycosis, likes going to the bone and the skin. When it gets to the bone, it can lead to very serious form of osteomyelitis. And in the skin, they cause some very verrucous ulcer, like ulcer that look like what? Once you see this verrucous, in fact, that's the nomenclature you are looking for in your exam. Warty verrucous lesion that looks like squamous cell carcinoma. That is blastomycosis. And of course, they can disseminate to the bone and cause very serious osteomyelitis. So once you see this, think of blastomycosis. And of course, the histology picture, we are going to look for the broad-based body. There's a bud here, but it is broad, broad-based body. The mother is bigger than the daughter. Coccidioidomycosis, common in California, Southwest United States. What do we see on histology? Spherules filled with the endosphere. So the sphere is not like a big circle containing the endosphere, and this one can disseminate into the bone, just like blastomycosis causing osteomyelitis, can disseminate into the skin too, causing erythema nodosum, which we call the Dasset bump, or erythema multiforme. So we know how erythema nodosum is made. What is erythema nodosum? Anybody knows? Inflammation of what?
Red painful nodules on the anterior shin.
Very correct. It is inflammation of what? I mentioned it that day. We
What
call
is
it
it?
paniculitis. What is paniculitis? Inflammation of the subcut. So it's more like inflammation of the subcut. So it is a paniculitis. Don't forget that. Erythema nodosum. Tender nodules on the anterior shin of the leg. They can also have erythema multiforme. They can have arthralgia, which is a desert rheumatism, desert bumps, the erythema nodosum and dissemination to the bone and the skin. So this one too can look like this in a way, but when you look at histology and they say spherule filled with endosphere, that is coccidioidomycosis. So by the next class, I'm going to be packing in a lot of questions for us to justify all these things. So I'm really sorry. I could not really get questions now. I'm so sorry, but for the next class, I'm going to be showing us questions for all these things. And don't forget too, it comes from archaeological excavations or people that get exposed to earthquakes, which brings about the dust, and the dust contains those organisms, the endosphere. They can easily inhale them and they can develop the infection. So don't forget the warty verrucous lesions for blastomycosis and the osteomyelitis it causes. Don't forget that this one too can cause osteomyelitis, but it will not cause warty lesion. We're just going to be seeing the erythema nodosum and erythema multiforme. And paracoccidioidomycosis too. This one is in Latin America, like Brazil, Argentina, and we see the budding yeast like this that looks like a captain wheel appearance. So we see this captain wheel appearance, all those people that drive the ship. This is what their sailing stuff looks like. So that is paracoccidioidomycosis. It's very similar to blastomycosis in nature, in that it can form osteomyelitis, can form this inflammatory lung disease, can form the verrucous ulcers in the legs too. Looking at Candida albicans. Candida albicans is very straightforward, very common. It is dimorphic, and it can form a pseudo hyphae and budding yeast at 20 degrees Celsius. So Candida is the reverse. Most of the other organisms, they would exist at yeast in 37 degrees Celsius, but Candida decide to exist at yeast at 20 degrees. Then it will now exist in the mold form, as germ tubes at 37 degrees. So the mold form usually contains a hyphae, ideally. So showing us the picture. So what form do we think this will be? Is it the budding form or the mold form? So we consider that these are buds, so this is more like the yeast, and we can see that this contains a hyphae. So this is the germ tubes, or the mold form of what's it called, of Candida. And Candida can cause systemic and superficial infection. So it can start from the mouth, oral thrush, it can go to the esophagus. Esophageal thrush is already AIDS defining unit. Oral thrush is not here defining. And this can be present in units in people that are using steroids, in diabetics, and HIV people because of the immunosuppression. So they can have oral thrush or esophageal thrush. Vulvaginitis too is very common, in people with candida infection and candida infection can also cause vulvaginitis, especially in people that are diabetic and people that use some antibiotics that destroys the flora, so can allow Candida to proliferate and can lead to vaginitis. Candida is the cause of diaper rash, and we are going to be seeing in the questions 10 what we call satellite lesion. So you see the rash everywhere, everywhere. But just be seeing some tiny spot. Let me see. I can't draw it. It's difficult to draw. Let me just show us the satellite lesion in diaper rash. So once you have seen that, you know that this is likely to be Candida. So they show us a picture of this, and we are seeing, you know, this rash like this, and we are seeing some surrounding tiny. Those are the satellite lesion. Very classic for Candida. Let me see if we have anything here. So we are seeing beefy red lesions with satellite lesion. That's the only thing you need. You see these tiny dots around it. That is satellite lesion for Candida. And Candida is also part of the cause of infectious endocarditis, people that ingest drug, including Staphylococcus pseudomonas. The third is Candida. You cannot go for a exam you don't know this. It's dangerous. It's also a problem, particularly in people that are neutropenic, because it can be disseminated and go to different part of the body. And it can also lead to chronic mucocutaneous form, you know, in people with some certain immunodeficiency state. So how do we treat? If somebody is having vaginal candidiasis, just vulvovaginitis? We can give our topical azoles, or we can give one dose, 150 milligram of you know, fluconazole. The person is going to be alright. Can apply topical nystatin to, you know, to the area. But if the person is having esophageal or systemic problem, that's not the time to be starting topical azole. You know, you have to give oral fluconazole or oral amphotericin B. Most of the time, it's going to take care of the problem. So I showed you the image. These are germ tubes, contain the hyphae. These are the buds, you know, with the pseudo hyphae. So these are the yeast form. This is the germ tube. This is the oral thrush, you know, of Candida. Then aspergillus. What do we need to know about aspergillus is that we see that the hyphae are usually branching at 45 degrees and they are septated. So if you look at this guy is branching at 45 degrees here, 45 degrees here, and it is septated. If you look closely, it is septated. So that is classic for aspergillus. And we have different form of aspergillus infection. Aspergillus is very important though. We have to know it. So invasive aspergillosis can occur in people that are immunocompromised, very common in immunocompromised people, particularly people with CGD. Don't forget, aspergillus is what? Catalase positive.
Positive.
So aspergillus can cause aspergilloma. So this usually occur in people with pre-existing cavity. So if we see a cavitary image and we are seeing some ball of fungus inside that cavity, that is aspergillus fumigatus, causing aspergilloma until otherwise proven. So it usually follows tuberculosis infection. Very important. And most of the time it can rupture and lead to hemoptysis. So have that in the back of your mind. I think we have an image of aspergilloma. Fantastic. So we can see this cavity here, already occupied with the ball of fungus, which is aspergilloma. So some species of aspergillus can produce aflatoxin, which we have talked about so many times, and they induce TP53 mutation, leading to hepatocellular carcinoma. So we talked about the fact that the aflatoxin gets activated by the cytochrome P40 system, and they, you know, inhibit the TP53, leading to hepatocellular carcinoma. Don't forget the aflatoxin. Never forget it. What do we use to treat aspergillus infection? So we can give voriconazole or the echinocandin. So voriconazole or echinocandin. There's something we call ABPA. Did we talk about this in respiratory? Allergic bronchopulmonary aspergillosis? Do we remember? Have we talked about it before? Is this the first time we are hearing it?
No.
Okay. So that is hypersensitivity to aspergillus growing in the lung. So this guy is a very serious problem in asthma and cystic fibrosis. This what they are going to test is not going to go beyond this. Asthma or cystic fibrosis having worse heightened hypersensitivity response to aspergillus. Just know that we are dealing with allergic bronchopulmonary aspergillosis. So people with cystic fibrosis and the asthma, because of the extent of the mucous secretion and the heightened hypersensitivity, they react easily to the aspergillus spore, and they start developing some chronic response like chest tightness, fever, wheezing, more like you're having asthma. But the signal that they will use to know that this is not asthma is that it's not going to be responsive to most of the asthmatic medication. So, and once we do our blood work, we are going to notice eosinophilia. Eosinophilia is going to be there, and IgE to aspergillus is going to be elevated, and the person can also have bronchiectasis in chronic form. So, ABPA is a cause of bronchiectasis. So this will be well explained in step 2. So, just know that somebody having symptoms of asthma that is not responsive to treatment with antibiotics. So they could think that this is an acute exacerbation of asthma or maybe infection, and they give antibiotic and it's not resolving. Just think of ABPA, that is aspergillus is a trigger. So you have to treat that infection by giving any of these antifungal infection and also other supportive treatment. So moving on to Cryptococcus neoformans. So number 1, it forms a narrow bud. Don't forget which one forms a broad base.
Blastose.
Blastoma.
The blastose. Cryptococcus is heavily encapsulated. In fact, look at the word, heavily encapsulated yeast. It is not dimorphic. That is, we don't have the mud form. It is a yeast. So it takes the periodicity sniff stain, which is not very important. We can get it from soil or pigeon droppings most of the time. We can put these pigeon droppings there. Bed, Cryptococcus neoformans. Bed droppings or soil. Bed droppings or soil. Don't forget it. Bed droppings or soil. So it's been acquired through inhalation, with hematogenous dissemination to the meninges. So that's why it's a problem of the lungs, the problem of the brain, and the brain parenchyma. So the brain meninges, meningitis, the brain parenchyma, encephalitis, and lungs. So how do we identify it? We already know it. This is what stain is this?
Indian ink
You can
stain.
see that it is very simple. We have seen it. The more you see it, the better you be at it. This is Indian ink stain. And this we might not be, but can we try? What's this likely going to be?
Musicamin, really.
Musicamin.
That will show the capsule, the musicamin stain and the Indian ink stain. So we can use the latest agglutination test, to detect it, which is more sensitive and specific. So that one just detects the polysaccharide capsule. And cryptococcus is going to manifest in meningitis, pneumonia, and encephalitis. So the encephalitis characterized by on CT, which is soap bottle lesions. That's not very, very important. Don't worry yourself. But familiarize yourself with the treatment. How do you treat it? You combine amphotericin B with fluocytosine, followed by fluconazole, for the remission. So very important. You induce with all these ones and you follow up with this. So amphotericin B plus fluocytosine, then follow up with fluconazole. So moving on to mucor and rhizopus. So mucor and rhizopus are like the same thing. They work together, and they are both irregular, broad, non-septate hyphae, branching at wide angles. So the difference between mucor and rhizopus and aspergillus is that aspergillus branches at acute angle of 45. These ones are wide and they are not septated. Aspergillus is septated. So this is what you see. You cannot call this 45 degree. Is this not more than 45 degree? It's already like 90.
It is.
So this is like wide, and the hyphae is not septated. So once you see this is rhizopus on the otherwise problem. What are we going to see in the exam? that's going to quickly raise our suspicion. So these guys can cause what we call, they can cause rhinocerebral mucormycosis. This diagnosis is a diabetic specific illness. Most of the time, anybody with rhinocerebral mucormycosis should have diabetes. If you don't have diabetes, rule out neutropenia, like maybe from leukemia. So what happens is that the individual is going to inhale the spore of this rhizopus or the mucor, and it's going to proliferate in the blood vessels, of the nose, and from there it passes through the cribriform plates to enter the brain. So, but as it's passing, it's replicating in the vessels and it's causing some chronic inflammatory damage to the nasal cavity and even to the sinuses of the face, like in the eyes. So you just see areas of necrotic areas. So once you see necrotic areas in the face like this or the nose, think about possibility of rhinocerebral mucormycosis going from the face to the brain. So once it passes through the cribriform plate of the ethmoid bone, it enters the brain and it comes in contact with the frontal lobe, and from there it can cause frontal lobe abscess. From there, from the face here, remember that the facial veins, they empty into the cavernous sinus. So the inflammatory products can dislodge from the facial veins into the cavernous sinus and it leads to cavernous sinus thrombosis. And I don't know if cavernous sinus thrombosis is treated in step 1. Did Dr. Orion talk about it in step 1?
Yes.
Yes.
Okay,
Yeah.
and we know the presentation. So very important, we get familiar with the presentation of cavernous sinus. We know the nerves that surround it. We know the artery that runs around it. Very important structure. And we should not forget the presentation once more. Headache, facial pain, the black necrotic ischia on the face. Very important. And it can enter the brain, destroy the cranial nerves too. So we need to debride all this necrotic area. We need to remove them. We need to remove this. We need to remove this necrotic area and place them on amphotericin B and ishabuconazole. So that's that about the rhizopus. So what's the time now? What did we say? The fungi, and what we have is hemocystic urachia, and this can cause pneumocystic pneumonia, which can cause a diffuse interstitial pneumonia, just like in mycoplasma pneumonia that we talked about. Don't forget, we see the diffuse interstitial pattern too in the lungs, and most of the time the infection is asymptomatic. We don't see anything unless the person is immunosuppressed. That's when it becomes bad. This guy is very bad. When we come to step 2, we'll talk more about it. And one common predisposing factor is immunosuppression from HIV. And what are we going to see? We're going to see a diffuse bilateral interstitial opacity, which is going to have this ground glass of appearance, on the chest imaging. And we can do a culture like a staining, in which you are going to be seeing cigar shaped or disc shaped yeast on the sieve. Can you see that they are using the silver stain and it is green because it's a fungi? So that's it. Methanamine silver stain are going to be seeing this disc shaped yeast. Or we can do the fluorescent antibody. This is not very common too, but they usually talk about this disc shaped yeast with the silver stain. Don't forget the X-ray finding, diffuse bilateral ground glass opacity. Don't forget the predisposing factor, usually immunosuppression. Without immunosuppression, they are going to be asymptomatic. So, how do you treat? You give your Septrin. It's as simple as that. TMX, TMP, SMX. It's as simple as that. Or you can give pentamidine or dapsone. And once an individual is having a CD4 count less than 200, you have to start your prophylaxis with this same Septrin. You place on Septrin. So you can use that as a prophylaxis in people with CD4 count less than 200. Please don't forget, less than 200, you start prophylaxis for this. So these are the CT findings. This is a ground glass opacity. These are the disc-shaped silver staining yeast. Then the last is Porotrix skenki. So that can cause sporotrichosis, which is a dimorphic fungus, and it's cigar-shaped. Yeast at 37 degrees Celsius. In the human body and in the soil, it exists as a mold. With hyphae. So in the body, it's a cigar-shaped yeast, and while in the soil, it's an hyphae. So they thrive on vegetation, like rose flower plants. So anybody that is a farmer at a rose garden, if their skin becomes bruised with these rose flower plants, the spores can be traumatically introduced into the skin, and it can lead to formation of a pustule or like a nodule. And from there, we'll notice that the spread of the lesion is going to follow the path of the lymphatics. We don't need to look for that. We just see that there's going to be like a linear patterning, or the question stem tells us. So because this rose plant contains the spore of this sporotrix. So once the rose thorn, kind of bruise the skin, they introduce the spore, and from there the person starts developing the inflammation, which leads to the formation of pustule or ulcers with nodules along the path of lymphatic drainage. So it causes a form of ascending lymphangitis. And when it's disseminated, it spreads to other parts of the body. It can spread to the lungs, can go to the brain, can go to any part. And in that situation, you want to give amphotericin B. So for normal localized treatment, give itraconazole or potassium iodide. But for the disseminated form, we use amphotericin B. Okay. So do you have any questions so far? Any questions so far?